ಶ್ರೀ ಗಣನಾಥ ಸಿಂಧೂರವಣ ಕರುಣ ಸಾಗರ ಕರಿವದನ ಲಂಬೋದರ ಲಕುಮಿಕರ ಅಂಬಾಸುರ ಅಮರ ವಿನುತ ಲಂಬೋದರ ಲಕುಮಿಕರ ಸಿದ್ಧಚಾರಣ ಗಣ ಸೇವಿತ ಸಿದ್ಧಿ ವಿನಾಯಕ ತೇ ನಮೋ ನಮೋ ಲಂಬೋದರ ಲಕುಮಿಕರ ಅಂಬಾಸುತ ಅಮರ ವಿನುತ ಲಂಬೋದರ ಲಕುಮಿಕರ ಸಕಲ ವಿದ್ಯಾ ಆದಿ ಪೂಜಿತ ಸರ್ವೋತ್ತಮತೆ ನಮೋ ನಮೋ ಲಂಬೋದರ ಲಕುಮಿಕರ ಅಂಬಾಸುತ ಅಮರ ವಿನುತ ಲಂಬೋದರ ಲಕುಮಿಕರ.
It was my daughter Anisha Arvind singing that Ganesha Stuti.
Very good, very good. Very nice, very nice.
Over to Dr. Shweta.
Thank you, sir. A very blessed morning to everyone present here. I welcome you all to this Arvind Diabetic Center International Virtual Diabetes Summit 2022 on healthy living and diabetes. It is my honor to introduce to all of you the rapporteur and the chairperson of today's event. They have come across the globe to share their valuable knowledge on healthy living and diabetes. I would like to introduce the session 1 chairpersons. Dr. Karunesh Kumar, MBBS MD Director, Diabetes Medical Center, Bengaluru. Welcome you, sir. I would like to introduce the other chairperson, Dr. Alok Modi, MD, FISH, India, FACP, USA, consultant physician, a famous diabetologist from Mumbai. Welcome you, sir. Thank you. And as per just a gentle reminder, the critical part of this program is the time management, as all of us are aware of it. So I request all the resource person will help in adhering to the allotted time. There'll be a full 16 minutes for the speaker, the buzzer reminder at 15 minutes to conclude in 1 minute, and for full 4 minutes for the discussion for the speaker, chairperson, and delegates. It will be 1 to 2 questions. Thank you, sir. Over to the chairperson.
Good morning to everybody. Such a wonderful event, scientific extravaganza we had yesterday. So today also it will be same. At the outset, Dr. Aravinda, my good friend, for conducting such a excellent conference, virtual conference. So I would today's topic is very apt and most needed because we are advancing technologically year by year in all the fields. In the same way, our medical field and diabetes also, we are seeing a lot of advancements. So how to use CGM? Our the basic concept of HbA1c, FPS, PPBS is very inadequate. So we know the glycemic variability is the most important. CGM plays the best role to control the glycemic variability. So such an interesting topic. We have 3 speakers. So I would like to introduce Dr. Rakesh Parikh, a renowned personality, to talk about this topic. Fellow of American College of Endo, Royal College of Physicians and Surgeons, College of Physicians and Surgeons. He is from Bombay, Treasurer, RSSDI, Rajasthan State Chapter, on editorial and reviewer boards of various journals, over 50 publications, including textbook chapters, principal investigator on several global phase 3 trials. I invite Dr. Rakesh Parikh to deliver his talk.
Thank you, Dr. Karunesh. Thank you very much for the nice introduction. And thank you, Dr. Aravinda, for arranging such a fantastic conference and involving us in that. And we are, can someone please give me the sharing rights? I want to share my screen. Neelam?
Yes, sir, we already give.
No, I'm still not able to. It's a host disabled participant screening. So I think you'll have to make me co-host or something like that. So it's an interesting workshop on CGM, and with me, my friend Dr. Amit and Dr. Bharat, both are going to talk on different aspects of CGM. Neelam, I'm still not able to share. It's saying host disabled participant screen sharing.
Just a second, sir.
Yeah. So I'll be just giving an overview of CGM, because after me, Dr. Amit is going to talk on different types of CGM and how to choose the right CGM for a patient. And after that, I think Bharat is going to talk on the interpretation of CGM in details. So I'll just give a brief about the types of CGM and their interpretation in brief, and then Dr. Amit and Dr. Bharat will cover the details of those topics. Just a minute. Now I have the rights to share. Are the slides visible now?
Yes, sir.
Yes.
Okay. Okay, thank you. So, as was being discussed informally before we started this session, now we are moving from the era of self-monitoring of blood glucose to the CGM. So, as is obvious from this graph, if we do only the self-monitoring on particular time points of a day, you will probably get the, you will probably be able to catch some hypers and some hypos, but you won't get the overall profile of the whole day. And we'll be missing several hypos and hypers, as is obvious from this slide. If you compare the slide on the left to that on the right, you can see that on the right, you have picked up a few hypos as well as hypers, which were missed when you did only SMBG, which was 5 to 6 or 7 point SMBG. So that is the importance of CGM and how the technology works. So the CGM basically has a sensor which goes under the skin. As you can see from the graph, the needle is there. It has the sensor. So this sensor comes in contact with the interstitial fluid and it measures the interstitial fluid glucose levels. And then that level or the data is transmitted by a transmitter, which is outside the body. This transmitter is then connected to a receiver, which receives these inputs, and then it might be showing you the outputs in the real time, or it might be scanned intermittently. So basically, these are the three standard components of any continuous glucose monitoring system. One is the sensor, which remains under the skin and keeps on sensing the glucose levels from the interstitial fluid continuously. Second is the transmitter, which transmits this data from the sensor to the receiver. And third one is the receiver, which displays you the values of the glucose. Now, there is a time lag in this process because the blood glucose levels and interstitial glucose levels, there is a time lag of around 8 to 10 minutes. So the CGM values are lagging behind the blood glucose values. And again, there is around 5 to 6 minutes of time lag in the technology involved. So if you compare the blood glucose values with the CGM values, there is a time lag of around 15 minutes in total. The CGM values lagging behind the plasma glucose values. Now, again, this receiver, which is the third part of the CGM, it can either be a separate device, as you can see in the center, the Libre 2, in that you have a reader. So the reader is the receiver here. It can be a mobile app also. So you can have a mobile device on which the app itself is acting like a receiver. Or the third one on the extreme right, you can see that it's actually a connected meter. So in this, the insulin pump itself is acting as a receiver. So insulin pump has a screen on which the CGM readings are continuously shown. So this way, the receiver can be either a separate device. It can either be integrated with the insulin pump itself, or even the mobile apps now can act as a receiver. Now, based on the use of the CGM, you can broadly divide the CGMs into two categories. The first one is the professional CGM. So as the name suggests, the professional CGM is for the professionals, the doctors, and it is not meant to be used by the patients for interpretation. So basically, if the doctor feels that a particular patient requires CGM, he will put up that CGM device on the patient. The patient goes home. The glucose readings are monitored throughout the day for next 3 days, 5 days, or 7 days. The patient comes back to the office or the clinic. the doctor takes out the sensor, and doctor takes the data from the CGM device, downloads it onto the system, analyzes it, and then gives the advice to the patient. So in this category, the patient doesn't have to do any intervention. The patient only puts the sensor or the CGM device, goes to home, comes back for the follow-up. On the other hand, the personal CGM is basically meant for the patients to use. So this is given to the patients who are quite educated, the patients who are able to monitor their blood sugar levels and do the take the actions based on the levels themselves. So those kind of patients, you can give them the personal CGM. So these patients will be able to scan their sensor intermittently, or they might be getting the CGM readings in the real time also, and they will act themselves based on the CGM readings. So based on the CGM readings, they might want to increase the dose of insulin, decrease the dose of insulin, or change in their diet. So those things are possible when you are using a personal CGM. So the choice of using a professional CGM or personal CGM depends on several factors. Whether you are giving it to a patient just to get the overall profile of the patient, and then you want to take the decisions yourself, or if the patient is a type 1 patient, a patient who is brittle diabetic patient, who is quite educated, who knows how to adjust doses, and who can take the action based on the real-time CGM, on the CGM values. So those patients will put them on personal CGM. Now again, based on the readings, how frequently do you get the readings of the glucose values? There are two categories. So one is the real-time CGM. So as the name suggests, the values of the sugar levels are available in real time. So on the receiver or on the mobile app, the patient will continuously see the values of his blood sugar levels. On the other hand, there is intermittently scanned CGM. This is also called as the flash CGM, in which the patient has to scan the sensor with the receiver intermittently, at least once in 8 hours, and then the data is downloaded from the sensor to the device. So in this case, the patient is not able to see the readings in the real time. He has to scan those, and then he can get the whole chart of the preceding 8 hours or 10 hours or 24 hours. Now, what are the differences between the real-time and the flash glucose monitoring or the intermittently scanned glucose CGM? So in the RT-CGM, the data is automatically transmitted to the reader or the smartphone without user engagement every 5 minutes. So every 5 minutes, the data is transmitted and the reading is available on the meter or the reader. In the flash glucose monitoring system, the user has to physically scan the sensor or the reader with the smartphone at least once in 8 hours. The data saving property is not available in the RT-CGM. So in case the connection is lost, then that data is lost. Whereas in the flash glucose monitoring system, the data points are saved. And that is why even after 8 hours, if you scan it, you will be able to capture the whole data. Then RT-CGM will also be able to give you the low glucose alerts or high glucose alerts. They can even give you the trends, whether the sugar levels are going down or up. But that is not the case with the flash glucose monitoring systems. The RT-CGM system has got a limitation that you have to calibrate it at least twice a day. Most of the CGMs, other than the Dexcom G6, which is the latest advancement, in which it is factory calibrated. Otherwise, most of the other RT-CGMs, you need to manually calibrate them by doing the SMBG at least twice a day, and the data has to be entered. Whereas the flash glucose monitoring systems, mainly the Libre systems, they are all factory calibrated, so you don't require to calibrate yourself. The RT-CGMs, most of them last for around 5 to 10 days, whereas flash glucose monitoring system lasts for 14 days. The sensor technology on the RTM system, it's operated at a high electric potential, so it has got low stability, whereas the flash glucose monitoring has got improved stability. Then insulin dosing decisions, obviously you can make only based on the RT-CGM, where you are seeing the values in the real time. But in the flash glucose monitoring, you can't do the adjustment of the insulin doses. There is an interference from the acetaminophen in RT-CGM, which is not there in the flash glucose monitoring system. And the site of attachment, so flash glucose monitoring, as we know that they are attached only on the back of the arm, all the Libre devices. Whereas the RT-CGM, you can put it either on the arm or on the abdomen. So these are the differences between the RT-CGM and the flash glucose monitoring system. So these are the latest devices that are available. The Dexcom G6, which is the latest among the Dexcom. Then in the Libre, you have the Libre, Libre 2, and Libre Pro. Then Guardian Connect and Guardian 3. So there are little differences in these. I think Amit will be covering those probably in his lecture. But broadly, you don't have a receiver in the Guardian Connect because that is connecting directly with the mobile app. In the Guardian 3, it is an integrated device. So the pump itself has got the receiver. For other three, you have got a receiver. All of them are compatible with the mobile devices or apps except the Libre 2. Then real-time readings obviously are possible only with the RT CGMs, and Libre devices are flash glucose monitoring systems, so you need to scan them manually. High and low alarms are available with most of them except the Libre. Insulin integration is obviously possible only with RT CGM devices. Among them, Dexcom G6 and the Guardian 3, you can integrate them with the pump. You can't do that with the Libre. And again, as I said earlier, there is a difference in their site of using the sensor. Okay. So now regarding the interpretation. So when you are having a real-time CGM device and the patient comes back with it, and then you have a report of that. So what are the important points that has to be considered while interpreting that CGM report? I'll just cover the briefs of it, and probably Bharat will cover in details in the next presentation. So once you have the CGM data, you first need to look at the duration, the data quality, whether the quality is good enough or not. So you have to look at whether the patient has done the calibrations as required, whether the whether the accuracy indices are met with. So if the patient did not calibrate on time, or he forgot to calibrate on time, then you will probably have to discard that data and use the data only during the period when the calibrations were done. Then whether the patient has recorded his history and routine. So just doing a CGM will not be enough if the patient, you don't know about the meal intake of the patient, or the insulin dosage that the patient has taken, or changes in the medicine dosage that he might have done, the physical activity that he has done, or the carb intake of the food that he has taken. So you might get the glucose profile, but to relate it to what is the reason for those highs and lows, you will also need to have the details about the dietary intake of the patient, the physical activity of the patient, and the insulin dosage changes if they are made. So these have to be captured separately by the patient, and that has to be ensured before you go on analyzing the data. Then once you are sure with the quality and the the data accuracy and the availability of all the details, then we need to look at the overall profile of the patient. So if the CGM device has worked for say 1 week or 10 days, then the patient will have graphs of each day for those 10 days. Now these graphs are merged together so as to represent a whole single day. So you are having a data of 8 a.m. for day 1, day 2, day 3, day 4, day 5, then 9 a.m. data, 10 a.m. data, and that plot is called as a modal plot. So you get a modal day, which represents the overall duration for which the patient was given the CGM device. That has to be then further analyzed. So you can just analyze a 4-hour period of the modal day. So say you want to look at the postprandial peaks. So you start from the before breakfast to the post breakfast 2-3 hours time, and that modal plot you have chosen for further analysis. Now in that, then you look at whether the glucose levels are in the target range. Are they going above or below target? If it is happening, so then is it because of any corresponding change in the diet? Is the carbohydrate intake of the patient is very high? Is the patient does the patient require any insulin dose adjustment? If the patient is going into hypoglycemia after 2-3 hours or 4 hours of insulin injection, do we need to reduce the dose of insulin, or do we need to make any changes in the diet? So these things have to be done after analyzing a modal plot for 4 hours for these patients. The second thing that we need to look at is the variability. So how much is the variability on day-to-day basis? So if in the same 4-hour plot, the blood sugar levels are varying from something like 80 to 170 in the fasting state, then you need to understand why there is so much of variation on day-to-day basis. Why the patient is having a normal sugar on one day, at the same time hypo on the other day and hyper on the other day. Is it because the patient is not complying with the medicines? Is it because the patient is not complying with the diet? Or is it something else? Like some patient might be going into down phenomena. So they might have a normal or lower side of normal fasting on one day, and some day they might be having very high sugar levels. So that you have to look at. So the glucose variability has to be looked at, and then we need to find out the cause for the variability. And then hypoglycemic episodes, which are very important. So we need to look at the hypoglycemic episodes at what particular time of the day. Is there any pattern? If the patient is going into hypo at a particular day only, is the patient getting symptoms there or not? Is there a hypoglycemia unawareness associated with that? is there any identifiable cause that you can look for that particular hypoglycemia? So these analysis have to be done for that model plot. Now, once you have done that model plot analysis, then you come for day-to-day profile analysis. So you have a profile for day 1, day 2, day 3, day 4, day 5, like that. And then you look at the changes in this. So a patient might be having a very high blood sugar level on a particular day only of the week. So maybe because that is the patient, that is a weekend, and the patient usually goes for party on that day, or the patient doesn't work on that day. So then you need to find out the reason for day-to-day variation, and that can be done by interacting with the patient, looking at the CGM profile along with the captured data on diet, exercise, and drugs, and then interviewing the patient. So like this, you can analyze the report of a CGM that the patient has given. I don't have much of time, so I'll just run a little fast now. So now the clinical interpretation of AGP. So AGP basically is a technique by which once you merge the data and create a model plot for the one day, then you analyze, you make further analysis. So we'll discuss that in next 2-3 slides. So now this is a process by which you standardize the CGM data, organize the data, analyze it, and then use it for optimizing the patient's blood sugar levels. So as you can see on the upper graph, these are each graph is representing one day. These are in different colors. So red graph will be for day 1, say, or the blue one is for day 2. Like that, it is the representation. And the lower one is the model plot. So the data from all these graphs is collected, and then it is represented in such a way that the middle line is actually the median. Then the data is for next 50 percentile, and then 90th percentile, like this. So this is the way the data, this is called as AGP. So AGP is constructed from a model day plot, which collapses glucose data over the several days or weeks. The data plotted according to time as if it occurred on a 24 hours period. And then AGP is visual snapshot of the patient's typical day, revealing the patterns of hypos, hypers, and glycemic variability. So if the graph is going below the target range, then it is hypo. If it is going above the target range, then it is hyper. And if the graph is very wide, that means the variability is very high. If the graph is narrow, that means there is not much of variation in the glycemic readings. Now, there are 3 ways you have to, 3 things that you can analyze from the AGP graph. So first is the metrics and the targets. So it gives you a different color coding, and it tells you about every day. So how much time of the day the patient was in target, or above target, or below target, and that is given as a percentage. So that is one analysis that you have to do. Then the AGP of the overall 14 days profile. So the same thing that I discussed earlier, the FNIR have to be looked at. So if the graph is flat or narrow, then that is good for us. So there is not much of variability. And then you have to review the day-to-day pattern you have to look at. So you can look at the pattern on day 1, day 2, day 3, and then you can also see whether there has been any improvement because of any interventions that were done. So this is the way you have to analyze the AGP graph. Now, broadly, in the AGP graph, you have the middle line, which is basically giving you the median range. And then there is the 25th and 75th percentile of the overall data. So for that particular time point. So this is the maximum readings lie in this particular category. And then the last one is of the 10% of data, which is the extremes of the sugar readings that you see in these patients. And then based on this model plot, you can look for the time above range, that is TAR, time below range, that is TBR, and TIR, which is time in range. And then this can be, this can be further analyzed. You also get the, average readings on each time point. If you look at the time between 6 to 8 or 8 to 10, there is an average reading which is given there at the top. So like this, you can analyze this. I'm just finishing. This is my last slide probably. So I'll just end here. Thank you very much. I think I finished in time. Thank you, Dr. Alok. Thank you, Dr. Alok.
It was a very lucid, it's a very tough topic to be covered in such a short time, and you did a wonderful job. Thank you. Can I just share some comments?
Yeah, Dr. Alok. Yeah, please.
I just attended the TIR Academy from Minneapolis. They covered it very beautifully and very exhaustively. And what I really liked and what they said something at the end of things, this time in range is something which is killing HbA1c. So rather than we progress on the fasting at the postprandial, which reflect into the macrovascular complications, even if we keep HbA1c under control, but if we can get that time in range to 70%, which is the target they are defining, they're trying to get metrics into CGM as a standard of care across the planet. And if you can get the time in range to even 70% from 80% or 75%, the complications, long-term morbidity and mortality can cut down by 10%. So if you can reduce the microvascular angiopathies and, erectile dysfunctions and coronary and heart failures, MACE events by 10% by just getting the TIR increased by 10%. It's a wonderful conversion. And second thing which I have seen in my practice, I have published one paper last year in ADA. I've seen that, the wonderful thing with this CGM is you don't have to do dietary advice. A lot of my patients, HbA1c came under control, weight got down. I could get them because when they see, it's called empowering patients. The elite class, when they see these reports, they themselves start changing their diet. They themselves become very serious with their I call as what we call as empowering patient. This really makes them empowered. You show the fasting postprandial and HbA1c, they come charging at you. Doc, your medicine is not working. What are you doing? But when they see the CGM, they blame themselves. They say, no, it's my fault.
Yeah.
I need.
And they are usually able to find out a reason. They will always tell you, yes, doctor, I did a mistake at this time. I had some sweet, or I did something wrong there. And then you're right. Then they make the changes, and then they try it. If
They willingly do it. When they join lifestyle management voluntarily, you really see results. And the third thing I've seen is inter-day variability, not intraday. Inter-day variability I've seen happens a lot in spite of a very good HbA1c. And that is where your medicines don't work, your insulin doesn't work. Even if you switch over, I tried converting short-acting drugs to long-acting drugs so that I can decrease the glycemic variability. That is where I've succeeded. But even if you do all that gimmicks, it doesn't work. It actually what works is the diet management. And once you see the inter-day variability, just sit with a patient for 5 minutes, just show the graph on his face. I'm telling you, his diet changes automatically. He himself cut down this parathas and other things. They change karta hai, you get very good results. This is my experience. I just thought I'll share the comments. But thank you very much.
Okay, Dr. Karunesh, next session, please. Dr. Alok, you can proceed.
Yeah, it's a pleasure and an honor to welcome on the dais Dr. Amit Gupta. He's a celebrity personality and he doesn't need an introduction, and he's a friend of. It's an honor to know him. But for the sake of priority, Dr. Gupta has done his MBBS, DNB, MNAS. He's a fellow of College of Physicians, fellow of Indian Society of Hypertension. He is FRCP, Glasgow, Edinburgh, USA, FIMSA, FIACM. He's also a fellow of Diabetes India. He's got a which is not going to do justice in this slide. It's a youth CV. He's a member of Membership Advisory Group for the American Diabetes Association 2021 to 22. He's been an advisor to ADS Public Health and Epidemiology, which is from 2022 to 2024. He's been Executive Council member for National RSSD and AGP India Chapter, Joint Secretary Diabetes India and UPDA, Apex Body member for the North, the Art of Living Trust member from 2019 to last year 2021. He's been an executive editor for the Sadhguru International Textbook of Diabetes, RSSDI Proceedings. He has multiple national and international publications. He's also been the reviewer for endocrine practice and ACE case reports and clinical diabetology. He has been a program coordinator for the currently very well-known RSSDI Save the Feet campaign, RSSDI Rotary 100 Villages NCD project, Defeat Diabetes campaign of RSSDI, and so on and on and on. He's got a list of awards, including the Times of India Health Icon Award in 2021, Diabetes Excellence Award 2021, Investigator of the Year Award right from 2017 still now, the National Health Award from 2016 and 17, Diabetes Tech Innovation Award this year 2022, and also the Padma Tripathi Young Scientist Award 2017. And dear friends, I'm missing out a lot of things in the CV. I don't think I'm doing justice with him, but for the sake of time management, I'll keep it short, and it's an honor and pleasure, sir, to invite you. And again, thank you, Dr. Arvind, for this wonderful feast since yesterday. So the dais is.
Thank you, Dr. Alok, for the kind introduction. And I would like to thank Dr. Arvinda Jagdisha for inviting me for this wonderful conglomeration of the academician all across the world. And the conference is going very well, as we can see it on all over the Facebook, social media, and everywhere. And a lot of delegates are attending it and appreciating it. With your permission, I would like to share my screen. And Dr. Rakesh has made my task very easy. The host has disabled participant screen sharing. Please allow me to share the screen.
Ria, can you help you out, please?
Yes, now I've been allowed, so
Yeah.
I will share the screen now. Just a second. Open the presentation. So Dr. Rakesh has already described about the AGP, what is AGP, and how we read the report, and a lot of other aspects of the AGP. And my task has been to discuss the indications and as well as the device selection of the continuous glucose monitoring devices. I'm just waiting for the file to open. It will just open in a second. It's taking some time. Yes, it is opening. So meanwhile, the one of the biggest indication to use CGM is the willingness to use the CGM. As we know, the adoption of the technology is very, very less. And we find it that a lot of people, they are not using the technology. I hope my screen is visible now. So I will just minimize it.
Yeah, it's visible.
So yes. So today we are going to discuss what are the indications of the CGM and how do we select a device. So it is important to understand that over the last 1 decade, a lot of advances has happened in the field of diabetes, and a lot of them belong to the therapeutics. We know that a newer drug class like SGLT2 inhibitor, they got approved in the last decade only. We have advances in the GLP-1 agonist therapies. We have other tags which are available to our disposal. But if you look at the average HbA1c from the 2006 to 2013, you will find that nothing has changed much, and the average control of diabetes all across the world, it remains the same, or some of the studies, they have shown that it has even worsened. So somewhere something is wrong, and we are not able to address that part of the problem, and despite of so many advances in therapeutics as well as technology. We know that the glucose monitoring techniques which are time tested and available to our disposal are the SMBG, that is the self monitoring of blood glucose. We know its advantages that it is it accurately measures capillary glucose. It is relatively inexpensive. It is very, very easy to use, widely used all over the world, and people are very, very familiar about it. The disadvantages are that there can be a risk of user error or the misreported data. Training or checking is also required. The data are limited to the single point in time and requires multiple tests per day for effective clinical use. And it is sometimes inconvenient as well as painful. And the quality of the glucose test strips can be challenging with the multiple glucose meters and the strips available. So accuracy of the SMBG is dependent on 2 factors. One is the user as well as the second is the instrument. So CGM definition and technology, I will not go into the detail. Dr. Rakesh Parikh has already described that. And these are the different CGM technology and devices which are available. So we will talk briefly about them when we go to the selection part. And this is again, Dr. Rakesh has covered in detail that what is a professional CGM and what is a personal CGM, and how these 2 CGM devices can be integrated into the clinical practice. So coming up to the indication. So look at the indications in type 1 diabetes or those who are on multiple daily insulins. So ADA 2022 says that real-time CGM or intermittently scanned CGM should be offered for diabetes management in adults with diabetes on multiple daily injections or continuous subcutaneous insulin infusion. So anybody who is having is on multiple daily injections of the insulin or the insulin pump therapy, they should be offered CGM. So this becomes one indication. The ACE also strongly recommend for all persons with diabetes treated with intensive insulin therapy, which is defined as 3 or more injections of insulin per day, for the use of an insulin pump. Endo 2018, the guidelines are not updated since then, but they again recommend the use of real-time CGM as well as the intermittently scanned CGM in patients with type 1 diabetes who are well controlled and who are willing to use these devices on a nearly daily basis. So there are 2 trials, the Diamond trials and the Gold trials, and these trials support the use of CGM in patients with type 1 diabetes. Again, if we look at the CGM used in type 2 diabetes and those on basal insulins, the AD again says that real-time CGM as well as the intermittently scanned CGM can be used for diabetes management in adults with diabetes on basal insulin who are capable of using devices safely. ACE again says that it may be recommended for individuals with type 2 diabetes who are treated with less intensive insulin therapy. And again, Endo says that short-term intermittent CGM used in adult patients with type 2 diabetes, not on prandial insulin, who have HbA1c levels more than 7% and are willing and able to use the device, it again becomes an indication for the use of CGM devices. So if you look at the AS21, so it strongly recommends the CGM as we have discussed in the earlier slide also. And CGM may also be recommended for any individual with type 2 diabetes who are treated with less intensive insulin therapy. And it can also be used in persons with diabetes who have episodes of problematic hypoglycemia and may sometimes be requiring predictive alarms or the alerts. So this becomes another indication for the use of CGM. There are studies which support the use of CGM data for education as well as behavior modification, as Dr. Alok was pointed in his discussion following the talk of Dr. Rakesh Parikh, that CGM use can contribute to the change in the lifestyle. And so it is how the CGM can contribute to the healthier lifestyle in 90% of the subjects. It can, and the study shows that the people will modify their nutrition choices based on the CGM data. Again, 87% success. And they are more likely to walk or exercise in response to a rise in glucose values. Again, 47% of the response patients. So perception of how CGM data affect nutrition and physical activity, participants reported that almost 90% of them will benefit by the nutritional choices, and more than 50% of them will benefit by making healthier physical activity choices. We know that there can be advantages and disadvantages with CGM also. So the advantage is that it provides comprehensive picture of the glucose variability. Readings are never missed, provides metrics to individualize treatment. It is simple to use and no daily finger stick required with pre-calibration. Disadvantages are that they are expensive, they are more complex, they require training, they require more time, their high level of compliance and interaction is needed, may require multiple finger sticks to calibrate with SMBG. Sometimes there are sensors who will require calibration with SMBG also. So sensor always on the body, this is potential risk for the contact dermatitis, and sometimes this can be challenging. And sensors require replacement at a regular frequency or interval. So this is again a limitation of the glucose monitoring technology. Again, both as with the SMBG, the accuracy of CGM is highly dependent on the instrument only. It doesn't depend on the person itself. So the SMBG depends on both the person as well as the instrument, while the CGM depends entirely on the instrument, not on the person. So just look, this is the ideal what we would like to have, and this is what the real is. So we would like to do a reality check of some of the parameters. We know that the diabetes care that relies on quarterly visits with HbA1c checks, it neglects the reality of life with diabetes that is continuous, as already pointed out by Dr. Rakesh, that time in range metrics is very, very important tool, and it correlates well with many of the comorbidities which we check in patients with diabetes. So it is very, very important to integrate time in range now in our clinical practice. Also, we know that using HbA1c alone may not be very helpful to patients for understanding their diabetes, because they will not be able to understand the impact of the lifestyle on glycemic management. There is no visibility of their response to interventions. So, as pointed out earlier, the patient may not be actually knowing what is happening to him with the treatment. So, patient is only guessing. So, we don't want to do the guesswork all the time. Patient may also be reluctant to advance therapy if they don't understand their glycemic pattern. Also, it has been seen that there is a lot of clinical inertia in terms of treatment adjustment when it comes to intensification of therapy or putting somebody on insulin. But once they say that, once a patient sees that the sugar levels are, or the timing range criteria are not met even with the 3, 4, 5 medications, then the task becomes relatively easier. Also, the blood glucose monitoring has notable limitations. It measures only at single point. The patient engagement and use is impacted by associated pain and social stigma. And the majority of diabetes care transpires between the visits outside of the clinical encounters. And wearing CGM can allow for personal discovery as patients engage in their own care. And this is what the personalized care means. So the more engaged a patient is in his or her own care, the better the chances are better that the glycemic control will improve. Just to have a look at the evidence of the indications which we currently discussed. So Diamond study, it is a real-time CGM versus usual care in patients receiving multiple daily insulin injections. And the study was designed for 24 weeks, a randomized controlled trial, 158 adults with type 2 diabetes on multiple daily insulin. And the primary endpoint was the mean change in HbA1c from baseline to the week 24. And the hypoglycemia, there was no increase of time spent in hypoglycemia. And the mean HbA1c, which changes from the baseline to week 24, you will find that it was definitely better in those group who are in the CGM group. Another study is a mobile study where the CGM versus blood glucose monitoring the patient receiving basal insulin primary care. The duration of the study was only 8 months. The virtual visits due to the COVID-19 pandemic restricted the results of the study. And the limited generally, the findings cannot be generalized, but 1/3 of the CGM group still had HbA1c of more than 8%. But the mobile study results shows that the mean percent of the TIR, which is 70 to 180% at 8 months, was 59% in those who were using CGM versus 43% in those who were using blood glucose monitoring. And the mean percentage of the time more than 250 that is a very severe hyperglycemia at 8 months, was only 11% in those who were using CGM versus 27% in the patients who are using blood glucose monitoring alone. We all know that hypoglycemia risk in type 2 diabetes increases with longer duration of the disease, and this is independent of the HbA1c. Patients even with very good HbA1c or even those with very high HbA1c are equally prone to hypoglycemia. And the risk factor for the hypoglycemia, we all know, the longer duration of the diabetes, multiple or advanced comorbidities, older age, prior hypoglycemia, use of insulin or insulin secretagogues, and worse socioeconomic status. And it is again independent of the HbA1c. This is what has been shown by the diabetes and the aging study. So this study, so CGM can actually improve the hypoglycemia detection and can help in patients who are susceptible to hypoglycemia. These are the various systems which have been cleared by the US FDA, the Libre, the Libre 2, the G6, the Guardian sensor, and the Eversense. We will look into more details in the next few slides. It is again important to understand that iCGM is also now called as, it is not just the intermittently scanned CGM. Now the integrated CGM is also the iCGM. And it is defined as an integrated CGM intended to automatically measure glucose in bodily fluids continuously or frequently for a specified period of time. And systems are designed to reliably and securely transmit glucose measurement data to digitally connected devices, including automated insulin dosing system, and are intended to be used alone or in conjunction with these digitally connected medical devices for the purpose of managing a disease or condition related to the glycemic control. So now iCGM is something with the integration with the clinical practice, with the other devices, and even with the insulin delivery. So what are the clinical implications of using CGM in type 2 diabetes? It can increase awareness of patients' glucose readings, which may lead to reductions in the HbA1c. It is associated with greater HbA1c reduction in patients with type 2 diabetes who are not using insulin. In patients with type 2 diabetes who are not using bolus insulin, CGM use may result in fewer adverse drug reactions. And CGM use may be an option to consider for some patients with type 2 diabetes before therapy escalation, because this will be a guiding tool to that. If we can think of some out-of-the-box uses of the CGM in type 2 diabetes, those who are having higher risk of hypoglycemia in older adults, in pregnant women with type 2 diabetes or the gestational diabetes, newly diagnosed, having episodic use can give insights into the lifestyle. Impaired awareness of the nocturnal hypoglycemia can again be one indication, and not on intensive insulin, but would likely benefit. So these are the different indications which may again increase the domain of use of the CGM. So this is one of the slides where we can compare the available continuous CGM devices and how to choose a device. So there are multiple devices which are available. If we talk India specific, then we know that we have Libre, which is available to our disposal, and the Guardian Connect and the Guardian 3 has also been launched in India. So the Libre 14 days device and the Libre 2, we know that it is having a receiver, while the Guardian Connect does not have a receiver, and Guardian 3 can be connected with the insulin pump. The phone app, Libre 14 days, has a iPhone and the Android app, but it is not released in India. The Libre 2, the phone app is not available, while the Guardian 3 or the Guardian Connect has an app, iPhone and the Android app, only with while the Guardian 3 only with the 770G insulin pumps. Real-time readings are not available with the Libre 14 day, that is the Libre Pro, and must is not there. While the Libre 2, with the Libre 2, the real-time readings can be available, and the must scan. The patient needs to scan the device again and again, while the Guardian Connect does not require any kind of scanning. Alarms are not there in the Libre Pro, while the sensors, they have the alarm system. The integration with the pump can happen only with the Medtronic Guardian 3, whereas sensor Libre 14 is allowed, is supposed to be worn on the arm. Libre 2 is also supposed to be worn on the arm, while the Guardian Connect, the Guardian devices can be, from the Medtronics, they can be worn on the arm as well as the abdomen. The automatic reports or the manual required, the Libre requires the using app, while the Guardian Connect devices, they have the automatic reports or the manual. Both the systems are available. So again, the choice of the device will depend that what kind of device you want to use, whether you want to use a professional CGM where the patient cannot see the data on his own, or you want to use a personal CGM where the patient can also see the data. Again, the choice can vary from the devices, right from the Guardian Connect to the Libre, which are currently available to our disposal. Again, Libre, you can use Libre Pro or the Libre device. So this again is determined by the fact that how long you would like to use the device. For example, the Guardian Connect can be used only for 5 to 7 days. So these are the limitations and the availability of the devices. So with this, I would like to thank the organizers for giving me the opportunity to speak about it. And I would be happy to take any questions if there are any. Thank you. Thank you very much.
Can I ask a question?
Yes, sir.
Hey, Amit, how are you? Nice seeing you. I'm Dr. Ram Kumar. Yeah.
We all know, sir. We all know you, sir. Thank you.
Yeah, I want to know what are the clinical practices these CGMS brought. What I'm saying is we have now time in range instead of fasting and postprandial. So I am just asking you, if the patient takes a sweet or some sugar, that the increase will be very transient, right? So whether these studies, did they bring any changes in our clinical practice?
Sir, your question is not clear to me. Can you be, there was a disturbance, so I couldn't hear you properly.
What I'm asking is, we are more now on time in range, TIR, am I right? And suppose if the patient takes a sweet, there will be a transient increase for certain time. Okay. So whether we can allow a patient to take some sugar in the coffee or something like that with these new CGMS studies. That's what I'm asking.
Sir, the idea of using a CGM is not to throw the sugar out of the control and make it high and give somebody liberty to take the sweet. The idea is to see whether a patient is able to spend the minimum amount of time in the time in range or not. So this is what we are doing. So I don't think we are asking the patient that since you are having you are spending 90% of the time in range, now you have the liberty to use the sweets and you can allow your sugar to go high. So again, that can be misleading. So what we aim is that whenever we are seeing a patient who is not meeting the time in range criteria, so we want to push the patient so that he gets into the time in range. But I am not sure whether if somebody who is already in time in range, we will allow him to say that.
Amit, just hear me. What I'm saying is, you are depending on time in range. Okay.
Yes.
Suppose if the patient takes a spoon of sugar in his coffee, there will be a transient increase. But you are saying that time in range will be more useful than this fasting and postprandial. So are we going to change in the future our guidelines? That's what I'm asking.
What I have understood from your question is that, sir, if the time in range is going to be a very, very important metrics in the future, right now HbA1c is also an important parameter, and I don't think we will be doing away with the HbA1c. So both the things are going to be there, and idea of doing a time in range, it has to be coupled with the HbA1c also. So it is not just the time in range. So time in range plus HbA1c, this is what the current guideline states. I hope I am clear to you because whatever I could understand.
I think I'll explain it. I will talk to you personal, and I want to mention that we did some studies with laughter yoga. With after laughter yoga, there is a decrease in the sugar. We used CGMS. Thank you very much. Bye.
Sir, if you see the latest ADA ESD statement, which is now talking about the 5S, so they also have mentioned the yoga also. So the 5S includes the sleep, the strengthening, stepping, sitting, as well as the that part, the strengthening part mentions the yoga as well as the Tai Chi. So it is now a word accepted fact that the yoga is going to improve the lifestyle and it is going to improve the HbA1c. So now the ADA and the ESD has also included in their recommendations the recent consensus statement.
Okay, thank you very much. Keep laughing.
That was a good wordings from the laughter man, Dr. Ram Kumar.
No, a magician also, sir. He is a magician.
Yeah, he's a magician as well.
Thank you, sir.
Deliberation of Dr. Rakesh Parikh and Dr. Amit Gupta. Both of you are really a tech man and you are updated with the latest data. Thank you so much, Amit. And over to Dr. Alok for the next speaker introduction, please.
Sure. So after this wonderful session on CGM by two exalted speakers, we have another third Amitabh Bachchan in this scenario. A very good personal friend of mine, Dr. Bharat Sabu, who's a well-known personality and a stalwart person. Again, I'll be doing justice. If I will not be doing justice if I were to read out everything which I cannot cover. Dr. Bharat is a chief diabetologist and director at Prayas Diabetes Center, Indore. He's been trained in data science for precision medicine from Edinburgh University. He also holds a scope certification for obesity. He has a postgraduate advanced course in diabetes by ADA Chicago, USA. He's trained in postgraduate training in endocrinology, diabetes and metabolism by European Society of Endocrinology. He's also gone beyond medical science and he's enrolled with IIT Roorkee for a course in artificial intelligence and machine learning. That's wow, Bharat, I didn't know that. He's a life member of EAC and RSSDI with memberships of ADA, ICE, ACE and ESC. He's been organizing chairman for Asia Diabetes Forum's Masterclass in Diabetes. He's also the president for the Madhu Prayas, which we all have attended and we have loved his conferences. He's organizing secretary for the Endo Dialogue 2022. He has multiple papers and presentations at national and international levels. The recent being 3 posters at ADA 2022, 8 posters at ESC 2022, 2 posters at ACE 2022, and the list goes on and on with EASD and ADA and IDF 2021. He received the Best Oral Poster Award in IDF 2021, one of the top posters in EAC 2022, top 20 posters in EAC 2021. He is a winner of Journal of Endocrinology Travel Grant, winner of RSSDI USV Award, winner of Upcoming Research in Diabetes Award at DiaCareCon 2021. He's also authored a book called Diet Therapy and contributed various chapters in the book. He's also himself working on developing an artificial intelligence based model for precision healthcare delivery in diabetes. So again, Bharat, I'm sorry I'm not covering all your achievements and looking forward to listening to you and welcome to the dais, and I'm sure we all are going to learn a lot from you today. So the stage is yours, Bharat. Please carry on.
Good morning, everyone. I am thankful to my dear friend Arvinda for giving me this talk regarding interpretation of CGM. It is a very important topic and it has been made easier by respected Amit sir and Rakesh sir because they have taken most of the talk which I am going to talk to you today. So the job which is assigned to me today is interpretation of CGM, how to save time. Now, we have seen all the things what we have seen in last 2 lectures, and now I'm coming straight away to my topic, how to use AGP and TIR to the maximum benefit, because the graphs look very complex and the problem is interpretation of the graphs. And many people are finding it very difficult to interpret, how to interpret them. So I will be trying to make it easier in next 15 minutes or so. Now, this is a typical graph, and when we see this graph, when we try to plot it in the form of AGP, we see there is a median line, which is actually the median from where all these wavered lines of CGM is passing, which simplifies the complex data set which is there into manageable snapshot. Now, this is what is done by the AGP software. Now, after this, what is done is, this is a normal AGP. This is the ideal AGP for our patient. It should look like this. The blood sugar should always be within target range. You can see the various percentiles. 25th to 75th percentile, which is represented by this light blue line. The light gray line is 10 to 90th percentile, and median is this dark blue line. This is the median from where most of the values are lying. Now, this is the normal graph. How it looks, it is like this. And this is the CGM matrix, which we try to see. If we see, it looks very complex. So what an AGP does is, it actually algorithmically calculate where the median lies for all the values, and then it gives us a line which we need to follow. Now, and this we would see, and what we would accept as a good control in diabetes, because when we see these graphs, it may look wavered, but these are isolated findings and they are not reflecting in the median. So AGP really makes these things very easy. So always go for looking for AGP first. Now, This is a typical graph where it represents a good diabetes control. How a patient can interpret it. This is a median which is falling in the target range, and that makes it really simple to estimate that our diabetes is in good control. Now, this is again a graph, but the median is sometimes wavered. You can clearly see here these two places where median is wavered, and all these 10 to 90th percentile and 25 to 75th percentile are also crossing above the target line. Compared to the previous graph where it is not so much crossing, this is crossing by some substantial margin. And now when I try to see this, let us see. This is the graph, and this is whole of the graph almost is lying above the target range of blood sugar values. Now the median is very wide. It is very widely distributed sort of graph. So the gaps are very wide, and it is not that narrow as the first graph which I have shown you. So there is something which is not right in spite of HbA1c being 7. Now you can very clearly see at some points the graph is very thin, and at some points the graph is very thick. So this is something which we need to look for. If the graph pattern is like this, then we need to be very cautious, because see this ball, this is actually representing the median sugar value, and how it passes, just see. There is too much of up and down into it. So it is not actually what we want. We want a smooth sailing. So it is not there. So again, coming back to the same graph, this is the red zone where the median is lying, but it is actually not what we intend our graphs to be like, because it is having 2 highs and 3 lows. There are 2 peaks and 3 troughs in it. And this is what is causing problem to the patient. Most of our graph is lying outside the target range. Now what to do with it? How to derive the treatment priorities based on the same graph which I have shown you. Again, when we see the CGM or the AGP data, it gives us 2 2-hour slots where the blood sugar values is high. So what we need to do? We need to first and foremost see where our median is lying. Then we need to reduce the variability. The treatment priority should be to reduce the variability of the patient, because the blood sugar values are very variable. Then how to reduce the variability? By changing the medication. If we are able to reduce the variability, the graph will come down. Then we need to improve the stability of the graph. So this graph should look stable. Then we need to see after that, if the graph becomes stable, it will look like this. So actually we are able to flatten the curve which is there. Then we need to reduce the exposure of the patient to high blood sugar values. So once we are able to do it, then actually we are helping our patient in reducing the blood sugar values to a normal zone. And this is the zone where we want our patient to be. Now, there are different patient scenarios for AGP use in India, because we are a diverse diabetes population, and indications can vary from HbA1c, which is not matching with SMBG, elevated HbA1c, high glucose variability, insulin adjustment. There may be hypoglycemic patterns with the patient, a patient who is non-compliant, so we need to put a AGP to him, therapy adjustment when it is required, especially in our insulinized patient, hyperglycemia pattern, like I have told you, when we want to find, and baseline assessment of a patient. So all these are indication for use of a AGP in patient. And how to go ahead? The patient presents in the clinic. We screen him for the underlying problem, which is diabetes, maybe high variability, maybe hypoglycemia. We should check historical blood glucose records to aid us in finding the variability, and identify indication for CGM out of the indications which I have told you. We need to counsel him. We need to consult at clinic. We need to tell him the rationale of CGM to confirm the underlying problem. We need to set expectations around the target time in range, because the time in range is what we are talking about, and diet and lifestyle advice. And then we should apply the AGP sensor, and we should follow him for 14 days, 10 days, whatever sensor duration is. And we need to plan a follow-up to AGP to track the target TIR. Then again, we need to advise the diet, lifestyle, and therapeutic intervention based on the AGP report. Then again discuss with patient and interpret the AGP. So this should be the flow of the events in and around AGP application. Now, the guide to interpret the AGP report, because we know CGM requires a standardized report format, because I have told you the data is so wavered that we are not able to get it to what it is telling to us. And AGP ensures actually that we are taking most of the things which are correct into consideration by the way of median, because there is too much inconsistency in CGM data. When we see of same patient, it is very wavered. Now, what it gives us glucose statistics and targets, which are clearly mentioned on the AGP report. We get the graph for the 14 days, and we get the daily glucose profiles also. I will tell you one by one how to deal with them. And it again tells us the time in range, what is there, and how our patient is doing and behaving with the time in range. So first and foremost thing is date and time, which is there in the AGP report, how many days has elapsed, and percentage of time the CGM was active, it tells us. Then it gives us the glucose ranges, the target which is there. And the targets are clearly mentioned according to the age and the type of diabetes. Then the average glucose of the patient is given. Whatever the average glucose of the duration of CGM application is clearly mentioned. There's nothing, there's no rocket science in it. And glucose variability is also given. Like in this case, it is 49.5, while it should be less than 36%. So the patient is having high variability. So we need to target our treatment to reduce the variability. And then it gives the very important graphics, which is time in range. So we can clearly see in this graph, the target range or the time in range is only 47%, while it should be greater than 70%. So we need to focus our treatment on moving our patient to the time in range and reducing the variability, because variability is too high in this patient. Now, again, coming to this ambulatory glucose profile report, it is actually the summary of glucose value from the report period with median 50%, as I have told you. Now, this is the daily glucose profile. It gives you day-to-day picture, Monday, Tuesday, Thursday, Wednesday. So if there is some exception or some event which has occurred, there is something which the patient has done, which is he or she is not routinely doing, we can catch it up. With a meal even, we can catch how the blood sugars are behaving, with the exercise, with sleep patterns. We can do so many things with this day-to-day graphs. And after this, I would just like to say the time in range is the time in target. So our target should be the time in range. So we should focus on the time in range. Even in the day-to-day graph, there is a side column which tells us the daily glucose average, the time in range, the time in target, how the patient is, time below target, time above target is also given. So we need to focus on these three things. The time in target is the most important thing, because if it is in check, then time below target and time above targets comes secondary. So first we need to focus on the time in range. So this is given. Then after this, at the end, there is a total time in range which is given for the duration of the period it is measured. Now, to summarize it, the time in range actually can complement HbA1c for a wide range of people with diabetes. And it is an integral component of CGM data and day-to-day treatment decision making, because it impacts our treatment. How the patient responds to treatment is also reflected in time in range. Now, how this has evolved actually. CGM actually, it shows us that we can miss some highs which are there. These are these finger prick testing which we were doing with this green colored dots, and they were all coming in time. But there were some unnoticed highs and some unnoticed lows which were getting missed. And this is what was given to us by CGM. Then the AGP came. And the AGP was utilizing the very same data which the CGM gave us, and it was giving us the median value or the median curve of these values. And then came the concept of time within range, time above range, and time below range. So this is how we have progressed from SMBG to time in range as far as the monitoring is concerned. Now, how the interstitial fluid measures glucose. Just a brief about it. Just I'm giving an example of Libre. It measures the glucose in interstitial fluid in subcutaneous tissue. And as it has been already told, it's a reliable indicator of blood sugar values. And actually, to understand CGM, one thing is very important is to understand the physiologic lag. Because you see the two engines, blood glucose and the sensor glucose. The blood glucose is always ahead and sensor glucose is lagging behind. So it will lag behind when it is going down or it is up. So the blood glucose level are stable or changing slowly. The readings can be similar, but it cannot match all the times. And the interstitial glucose reading tend to lag blood glucose reading by 5 to 10 minutes. And when the readings are changing rapidly, the number can be quite different and lag time may be longer. Make this very clear. Many patients will come to you, my blood sugar value at this point of time by my finger prick was this, but the sensor is showing this. So you should know that this is actually a physiological lag. There is no harm with the sensor or problem with the sensor. And that is why it will not always match the sensor glucose value, as I have told you. Now, top reasons why your value will not match, you should know this thing. First thing, as I have told you, your glucose is changing rapidly and one of these arrows could appear on the meter. Then the finger stick check or sensor scan was not performed at the same time. Even if they are performed at the same time, they are not liable to match. In the first day of wearing, it is calibrating itself. So first day of wearing, your numbers may not match. Sensor may be loosely attached. That is also one reason why the numbers may not match. Not washing finger before performing a finger stick test can impact the blood sugar values, and blood glucose strips were expired or contaminated. The built-in Freestyle Libre or any other sensor was not used for a finger stick check, and 500 mg or more of vitamin C or 650 mg or more of aspirin can also impact blood sugar values or a CGM value. So make this very clear. Now, SMBG to CGM, as I have told you, that is a journey which is continuous, and even frequent tester, they miss the significant glucose variation. That is why CGM is a very important tool. Now, what is the role of A1C in landscape of glucose monitoring? Because as I have told you, A1C does not tell us the whole story. The utility of A1C is enhanced when it is used as a complement to CGM. You can see these are 4 patients with A1C 7.6 to 7.7, and all the 4 AGP graphs are different. So it clearly tells us that HbA1c is just an average. It is not giving us the true picture, or it is not giving us the glycemic profile. The glycemic profile will only be given by a sensor when we apply it to our patient. Now, how to make best use of CGM? We should focus on time in range. Look for time in range, time above range, and time below range, because these are the 3 things which are most important. Now, time in range provides actionable information than A1C. A1C is just a tool to measure a long-term glucose value, but the time in range metrics actually show the day-to-day time in range where the sugar is, and our focus should be to increase the time in range and decrease time below range. If we are able to achieve these 2 things, then definitely the time above range will be minimal. So the primary goal for effective and safe glucose control is to increase the TIR while reducing the TBR. Now, there is an international consensus on time in range, and this is actually the consensus says that the consensus panel identified time in range as a metric of glycemic control that provide more actionable information than HbA1c. So HbA1c is the second tool now, and the time in range metrics by the way of AGP or CGM is the first tool which we should monitor. Now, again coming to this, what are the recommended TIR ranges for different diabetes population? Type 1 and type 2, we should intend for a target range of more than 70%. A old high risk individual, type 1, type 2, TIR of more than 50 is okay, we will manage with it. But the time below range should be less than 1%. When we need to take a note of this, that the time below range should be less than 1%. In pregnancy type 1 diabetes, more than 70% is the time in range. And in pregnancy, gestational and type 2 diabetes, the target range should be much higher. It should be very good. Now, coming to the TIR targets for type 1 diabetes or type 2 diabetes non-pregnant are the same. They are TIR of more than 70% and time below range of less than 4%. So again, coming back to how to interpret AGP, just to end my talk, I would like to say it is very simple. You need to look for what the graph is saying. The graph will tell you the whole story. If you start looking at the graph, and don't look at the first part which is there, which is the CGM matrix, it will really confuse you. You look at the next graph, which is the AGP matrix, and it will clearly first focus on the blue line, which is the median, and then see the deviation, dispersion, the crest and the trough, and the whole story will unfold in front of you. Then you will know what to treat, when to treat, and how to treat. And we should definitely learn to check blood sugar, and we should check it very often. Thank you.
Thank you, sir. Thank you so much for such a wonderful talk on interpretation of CGM, how to save time. That was a wonderful talk. And I would sincerely thank all the three speakers for sharing such a valuable information and being a part of our conference. Over to you, sir. Arvind, sir.
So, on behalf of Dr. Arvind Diabetes Center and ADC International Virtual Diabetes Summit 2022, I wholeheartedly thank Dr. Karunesh Kumar, Dr. Alok Modi, Dr. Rakesh Parekh, Dr. Hamid Gupta, and Dr. Bharat Sabu for a wonderful deliberation and for your valuable time and being a part of our conference. Thank you so much. Thank you so much for all of you. Thank you.
Thank you, Dr. Ravinda. Thank you. Thank you.
Thank you.
We'll move on to next session. Over to Shweta.
Yes, sir. Thank you, sir. Let's start our next session, session 2. I'd like to introduce our rapporteur, Dr. Ajoy Tiwari, MD Internal Medicine, FICP, DIP in Diabetes, Director and Consultant Diabetologist, the President of India, UP. I would like to introduce the chairperson. Dr. Vinod Mehtal, Consultant Diabetologist, Founder Member, United Diabetologist. He is a famous diabetologist from Mumbai. And I would like to introduce Dr. Ishita Sachdev, Clinical Associate, Dr. Panikar Super Specialty Hospital. Welcome, ma'am. Welcome you all. Please, over to you, sir.
Thank you. Thank you for the introduction. And without further ado, I would like to invite Dr. Faraz Farishta for the next talk on interchangeable insulin, not controlled with OADs. He's MD of FS Endocrine and Diabetes Center, Professor in Medicine Institute of Medical Sciences, Chairman of Investigator Council for ISCR, Executive Committee Member, IMA, Hyderabad City. Over to you, sir.
Thank you, Dr. Ishita, for that warm introduction. And then thank you, I would say, Dr. Arvind, for again bringing out the best, I would say, and the wonderful hosting what we have seen since yesterday. So without much wasting of time, I would straight away start with my talk, which has been given. And then I would like to welcome my two chairpersons and rapporteur as well. So we all know when it comes to management of diabetes, there is a lot of inertia which we see, and then that is not uncommon. So you will see anybody who is on one oral anti-diabetic drug having a A1C of more than 7%, it takes at least 2.9 years for the time to intensify the therapy, and somebody who is on 2 drugs. So this is what we see commonly in India. You will see it takes as long as 7.2 years. So that golden period, that period where good glycemic memory is building, is getting lost. And we all know that, yes, diabetes, it is there is deterioration of beta cells which keeps on happening. So it is not that when you're diagnosing somebody with diabetes today, almost 50% of the beta cells are already exhausted. There is something called as ticking clock hypothesis. So it says that 5 to 7 years before is where at least the beta cells start deteriorating, and your patients are at complications and at risk of developing macrovascular complications, at least in that IGT or IFG phase as well. So early insulin is the only answer, because we all know it is the most physiological thing what we can do, and we can definitely preserve the beta cells and help your patient to overcome the glucotoxicity as well. And these 2 trials, I think, have made a lot of difference in the way we are treating diabetes. The UKPD, especially the follow-up, the DCCT EDIC, where it says that even 1% A1C, so somebody who is at 9%, if you're not able to reach at 7, but still even a 1% A1C reduction gets the microvascular complications down by 37%, death related to diabetes down by 21%, and one second. Sorry for that. My slides are visible, right?
Yes, sir. Slides are visible.
Yeah, thank you. So I was talking that even 1% A1C reduction would help you to get down the micro and macrovascular complications. So all of us here who are interested in cricket, I'm sure my friend is very much, Dr. Arvinda is interested, and the other colleagues are here. I'm going to make two very important announcements now. First is there is a decider between India versus Australia. So this is happening at Hyderabad. I know it is not the second, it is the third ODI, which is happening today. And there is one more important announcement which I would like to make is, of course, this is a little older one, but this again is a very important announcement that FDA approves the first interchangeable biosimilar insulin product for treatment of diabetes. So what does that say? It says that there is an interchangeable biosimilar product and may be substituted for the reference product without the intervention of the prescriber. So this itself tells that the biosimilar is very, very similar. It has less or it has absolutely no problem in getting substituted. And then you will see the Biocon's insulin glargine. It has global trials. There are many trials which have been done across the globe involving more than 2,000 patients now. I will just talk on few of them. The InStride 1 study, this was done to see the non-inferiority versus the standard glargine in type 1 diabetic patients, which was published in ADA 2017. Here, you will see the objective was to prove the non-inferiority of Biocon's glargine with the standard insulin glargine in type 1 diabetic patients. It was a multi-center open label randomized comparative phase 3 trial. It involved around 558 type 1 diabetic patients. So the patients were divided equally between one arm on Biocon's insulin. The other arm, the patient was on the standard glargine. You will see when it comes to the A1C or the fasting, there is hardly anything to choose. Both the lines, you will see the blue and the red line intersect at every and each point. So there is nothing much to choose. So that clearly tells the non-inferiority of it. So both the basal and bolus insulin dose level did not differ between the groups. And I would say the most important other factor is the rates of hypoglycemia and other adverse events were comparable between the two groups. So this is also very, very important. Coming to the InStride 3 study. So this is, again, I would say a very important study which was done to see the immunogenicity. I think this is where we all are a little worried when we talk about the biosimilar. So this was done to assess the efficacy, the dose, safety, and immunogenicity when people with type 2 diabetes switched between Biocon's glargine and reference insulin glargine. So again, there were two arms. In one arm, you will see the patient were started on as a reference on the standard insulin glargine plus the Lispro. In another arm, for the first period, that is for the first 3 months, patients were given on Biocon insulin, that is glargine plus Lispro. Then there was a switchover. So then patient was switched to the standard glargine for 3 months. And again, they were shifted back to Biocon's glargine for 3 months. So this was entirely for a period of, you will see, 9 months where the switchover was done and compared to the reference insulin glargine. Again, you will see the change in the A1C from baseline to week 36 with Biocon glargine compared to the standard is almost very similar. And the overall incidence of hypoglycemic events, again, is almost similar between both the arms. So equivalent efficacy, safety, and immunogenicity demonstrating that patients taking reference glargine is similar to the Biocon's glargine. So this is, again, very, very important. I think this clears the air of the point that if we are worried about the immunogenicity, it is not there and it is similar to the standard glargine. How does it help in our clinical practice in a country like India, where the entire thing is being spent from the patient's budget, I would say. So you will see a patient A on reference glargine versus the patient B on interchangeable glargine. Patient A, that is the standard glargine, is stabilized on 20 units. So cost is around 53 per day. So at end of 1 year, the patient spends around 19,000. When you see and compare with patient B, where same units, but the cost is 40 Indian rupees. So at the end of 1 year, it is around 14,600. So you will see almost the patient is saving around 4,000 to 5,000 per month, which is very, very important in a country like India, because that can help in taking the other medications, and then that can help in doing the other diagnostic tests as well. So timely initiation of interchangeable glargine makes a huge economic benefit to the patient. There were a lot of challenges where we only had the standard glargine, which are now eased out with biosimilars. Few of them I would talk about. The reserve for patients who can afford the standard. Now we have the biosimilars, so it moved towards the affordable and optimal therapy. Because of that, there was late insulinization. Now we can do the timely insulinization. Because of the delay in insulinization, there was rise in complications. Now we can reduce it. And the rising economic burden, which was on the insurers, the government agencies, on the patients. I would think the major burden falls on the patient, and now that can be saved. So at the end, I would like to say that most of the guidelines now say that, yes, basal insulin therapy is the most easiest way to start the insulinization when your patients are not getting control. So somebody who is not getting control on 2 oral hypoglycemic agents and not meeting your target, somebody who's having 1.5% above your target, somebody who is having an A1C of 9% and having osmotic symptoms, these are the indications where the basal insulin therapy should be started. And then, yes, now we have, I would say, one of the best biosimilars, which has now got US FDA approval for the interchangeable status, which is very, very promising. So we can do that and then help our patients to have a better glycemic control. So to end my talk, I would end it. This is for my friend, Dr. Arvinda, that a quote from Nelson Mandela: "It always seems impossible until it's done." And I think you have proved it today. Thank you so much.
Thank you, Dr. Paras. That was a very excellent presentation, I would say. And let's just like to ask one question, Dr. Paras. I mean, you have been speaking about the original and the biosimilars. We know that when it comes to the sequencing, I mean, the original has got their own molecular clone bank, and the biosimilar, they don't have access to this clone bank. So in a way, they are unique, and each biosimilar which comes into the market, they are actually unique. They are different from the other biosimilars. And then if you look into the regulations, I mean, the US FDA has given approval for interchangeability only for Biocon's Semglee. That is only one which has been approved as an interchangeable biosimilar. But in the Indian market, if you see, we have a lot of biosimilars which have come in the Indian market. And then each biosimilar has to prove their effectiveness as well as safety independently. So in view of this lack of, you can say, regulations in India, do you think this can be a point of concerns with the other biosimilars which we have in the Indian market?
Oh, definitely. I think this is a very important point which you have taken out, Dr. Vinod. This is very, very important when it comes to the management of diabetes therapy. So I think if I had to give an example, it is something like the generic version of the oral hypoglycemic agents, what we have now. So when you compare it with the standard, we all know what results we get when we using the standard therapy versus the generic. I'm talking about the oral hypoglycemic agents, because there's a lot of difference. So until we get the confirmation for the other drugs, other basal insulins, also, as you rightly said, in market, which will have to prove their sustainability, and which will definitely require at least, if not the interchangeability status, but the non-inferiority and the immunogenicity. I think these are the two important things which we all look at. So until we have that, I think Right now, what we have, the best biosimilar having the interchangeability status is the insulin glargine from Biocon.
So if there are any more questions, or we can move to the next talk.
I think there are no questions in the chat box, sir.
Okay, thank you, Dr. Faz. Thank you so much once again for your excellent presentation. And so moving on to our next topic. First of all, let me begin by thanking Dr. Arvinda for inviting me here, for being as a chairperson for this very important and very interesting conference, which is we have been going on now. So coming to the next topic is basically on approach to hypertension in patient with type 2 diabetes. So we know that diabetes and hypertension kind of go hand in hand, and there's a lot of implications of both these high risk factors in our diabetic patients. And so to speak on this with us, we have Dr. Saibal Guha. Dr. Guha is ex-resident from General Medicine and Critical Care, Scott's Hospital Research Center, Faridabad, and also ex-registrar from Internal Medicine, IGIMS Patna. So Dr. Saibal, that's all yours. Thank you.
Thank you for the kind introduction, and good morning to you all. At the outset, I would thank Dr. Arvinda for giving me this opportunity to to share this august audience. And I'd be talking on treatment of hypertension, especially in context of the diabetic population. We all know that hypertension in diabetics is quite common. It's twice as common as compared to the non-diabetics, and nearly 75% of adults more than 40 years with diabetes either have hypertension or have a BP more than 130/80 and not getting treated for it, in contrast to only 30% prevalence in the general population. 8 out of 10 diabetic patients are affected by CV-related issues. Diabetic face a 2 to 4 increased risk of CVD, and concomitant hypertension with diabetes triples the risk of CAD, doubles the mortality and stroke risk, and is responsible for up to 75% of CV events. We have seen that hypertension accelerates the progression of the diabetic complications like nephropathy, retinopathy, and neuropathy. And conversely, BP reduction reduces the morbidity from heart failure by 56% or macrovascular complications by 34%. And some trials have shown that systolic BP is perhaps a stronger predictor than diastolic for both CVD and other events. What's the pathophysiology behind this? The pathophysiology is of diabetes and hypertension are closely interlinked. We have seen that the overactivity of sympathetic nervous system or the RAS activation, abnormal renal sodium handling, endothelial dysfunction, these are the common things which exist in both the diseases. Both hypertension and diabetics are low-grade chronic inflammatory diseases which lead to a prothrombotic state, increased production of inflammatory cytokines, and leads to CV events. Obesity is an independent risk factor which adds on to the risk of both diabetes and hypertension. And it all leads to our belief in the common soil hypothesis, which shows that all these diseases increases atherosclerosis and causes metabolic syndrome. Why a tight BP control is needed? We have seen from the value trial with valsartan and amlodipine that a lowering systolic blood pressure to less than 140 by 6 months only reduces stroke and CVD events and mortality. Steno-2 studies have also shown wonderfully that intensive control of hypertension, hyperglycemia, and dyslipidemia in diabetics reduces CVD events to a great extent. There's a modest reduction in BP of just by 9 to 11 systolic or 2 to 9 mm of diastolic, reduces the CV events to a large extent, and also the microvascular complications to a large extent within just 2 to 5 years. So that shows that why a tight BP control is so important. In fact, a tight control of blood glucose only decreases the risk of microvascular complications, whereas some trials have shown that tight control of BP reduces both micro and macrovascular complications. Also, these benefits come instantaneously as compared with the tight control of blood glucose, where the benefits come a few years later. Tight BP control is obviously more cost-effective and much more easier for clinicians to do. And the trials have shown that this tight control, the beneficial effect was twice or thrice when the patient is a diabetic hypertensive. Hence, the IDF consensus guidelines have also shown the reduction in stroke morbidity, heart failure morbidity, reduced left ventricular hypertrophy, decrease in CAD events, reduction in progression of renal disease and nephropathy, all are achieved by a tight control of hypertension in diabetic population. Having said so, we also see the ADA guidelines have also said that the patients who come with a BP of more than 180 by 110 needs to be treated right from the first visit. Once with a lower BP, we should take multiple readings, and treatment should be initiated if multiple readings are more than 130/80, or if patients have a lower risk of CVD, we can wait up to a BP of 140/90 and see whether it comes down or not. The most international guidelines now recommend a target of less than 130/80 for people with diabetes, and diabetics who also have proteinuria or a UACR more than 500. The National Kidney Foundation suggests that the target systolic BP should be less than 125. However, there is a J curve existing here as well, and limited data shows that both renal and CVD outcomes are probably worsened if the systolic BP is lowered to less than 110. What is most important in management is the way of assessment, which we often tend to miss in our basic clinical practice. The patient should be seated with the backrest, feet resting on the ground, arms resting unsupported, and appropriate cuff side is needed. Patient at least 5 minutes of rest is needed for the patient to come and the BP measured. Cuff should be next to skin and not over the clothes. We can also assess autonomic neuropathy by measuring the supine sitting and standing measurements. If initial BP more than 130/80, we should take 3 readings. What is important is that hypertension diagnosis can be made if the average BP is more than 130/80 on 2 successive visits within 1 month. We often take this value as normal. Many patients say that my BP at home is less than this, but in the clinic it's high. But nevertheless, we should tell them, we should inform them that this BP is high enough for a diabetic patient. And this measurement method is very important because patients today are very tech savvy. They will come and say, well, your BP measurement in the clinic method is faulty. I measured it and it was something different at home. So coming to the therapy, first and foremost is a non-pharmacological approach. And the DASH trial have shown that lifestyle modifications such as exercise, a low sodium, high potassium diet, a low saturated fat and cholesterol, high in carb, fibers, fruits is recommended. What's more important, we have seen recently many celebrities losing their life at a very young age. So it's important to convey to our patients that diabetics more than 35 years of age should not start an exercise program more vigorous than walking without consideration of an exercise test like a TMT. Significant peripheral neuropathy or major foot deformities, if they are present, then cycling or swimming are perhaps better than walking programs. And if the BP is more than 140/90 and patient also has albuminuria or other target organ damage, we should start pharmacological therapy right from outset. This is the age-old algorithm for management of diabetic hypertensives. As I've said, less than 130/80, follow up for 3 months. More than that, we start with lifestyle. If controlled within 3 months, continue with lifestyle. If not controlled, start with drugs, starting with ACE/ARBs, then thiazides. We can add on the CCB or a beta blocker later on. And if still not controlled, we can tag this as resistant hypertension and look for the causes. That's in a nutshell the mechanism of assessment. The most important group of drugs which we use in a diabetic hypertensive as ACE inhibitors or ARBs. ACE inhibitors are the first line in management of diabetic hypertensives. ACE and ARBs have shown to be equally effective in reducing CVD events. ACE inhibitors have a greater reduction in CV events that would have been expected through BP lowering alone. So there's much more to ACE inhibitors than just BP lowering. Both ACE and ARBs also have specific renoprotective effects independent of the level of BP. And when macroalbuminuria is there, the UACR more than 300, definitely ARBs are preferred in patients with type 2 diabetes and ACE are preferred in type 1 diabetes according to some trials. ADA has also recommended ACE and ARBs both for use in type 2 diabetics with CKD and other microvascular complications, and ACE specifically for patients with more than 55 years of age at high risk of CVD. And it also recommends beta blockers if the patient has known CAD. No creatinine level is an absolute contraindication to ACE or ARB therapy, but yes, caution should be there when the creatinine is more than 3 because we know that there is an increased risk of hyperkalemia or a rapid decline in renal function in the patient of advanced CKD. Coming to the next group, the diuretics, the all-head trial have demonstrated that as compared to lisinopril or amlodipine, if the subjects are assigned to chlorthalidone, the BP reduction is equivalent but the risk of heart failure is further lowered. So in that group of patients, probably chlorothalidone is effective. A low dose thyroid have shown that it reduced the cardiovascular event rate by 34% compared with placebo, and the absolute risk reduction was twice in diabetic subjects as compared to non-diabetics. Coming to the calcium channel blockers, both the non-dihydropyridine group as well as the dihydropyridine groups are effective and they reduce cardiovascular events. The non-dihydropyridine groups like diltiazem and verapamil, they significantly reduce albuminuria and may slow the progression of proteinuric renal disease. Beta blockers are definitely carvedilol and metoprolol reduces microalbuminuria by 43 and 30% respectively when added to ACE or ARBs. However, carvedilol has been seen to be nearly 50% more effective than metoprolol for preventing progression from normoalbuminuria to microalbuminuria. And also, it does not affect adversely the glycemic control or the serum lipoprotein levels, unlike metoprolol or atenolol. And if there is concomitant heart failure or a prior MI, beta blockers should always be added as an initial therapy in combination to an ACE or ARB. And interestingly, certain newer oral hyperglycemic drugs have also some role to play in control of hypertension in diabetics, as we have seen from the various cardiovascular trials, which we have been talking about over the last few years with empagliflozin and dapagliflozin. The combination of decreased BP and body weight loss beyond simply decreased blood volume results in significant cardiovascular benefits. GLP-1 agonists have also shown some reduction of body weight and systolic blood pressure. Among the DP4 inhibitors, sitagliptin and vildagliptin has shown to lower the systolic blood pressure independent of their blood glucose lowering effects. Though the treatment of hypertension doesn't differ much in type 1 and type 2 diabetics, but there are some subtle differences, like in hypertensive type 1 diabetics with micro or macroalbuminuria, ACE inhibitors are preferred. In hypertensive type 2 diabetics with microalbuminuria, again, ACE and ARBs have seen to be equally effective. But in type 2 diabetics with macroalbuminuria or with renal insufficiency, ARBs are the preferred group of drugs as compared to the ACE inhibitors. What can be the causes of poor control? That can be either the disease factors or the patient factors or the clinician factors. Disease factors, diabetic per se, have shown to increase the requirement for antihypertensive medication. As you have seen, when we are treating hypertension in a patient who is non-diabetic, but who becomes diabetic, we see that his requirement for antihypertensive medications increases over time. Then there's an inadequate patient knowledge about hypertension and CVD risk. Many times, borderline high pressures like 150/90 are considered normal by most of the patients, but that is not so, and their needs. There is a component of patient education there, which is our duty to do. Then clinicians' inertia is also there. Only 10% of diabetic patients with BP more than 130/80, and only 50% of those with BP more than 140/90 were started on antihypertensive medication. And in an US survey, only 22% clinicians correctly identified control of hypertension as the most cost-effective intervention. Unfortunately, only 28 to 36% of hypertension patients have their BP controlled to target levels. And only 4 to 10% of diabetic patients meet the combined ADA goals for BP, LDL cholesterol, and hemoglobin. That basically shows the glaring facts that there is much to do about control of blood pressure, especially in context of diabetic population. So the guidelines for management of diabetic hypertensives are that the target BP should be below 130/80. All routinely used antihypertensive drugs have been shown to be beneficial. Most of the patients need more than one drugs ultimately in their treatment duration. Lifestyle changes like weight reduction, regular exercise, moderation of sodium, protein and alcohol intake, as well as control of hyperglycemia, dyslipidemia, proteinuria, and quitting smoking should be emphasized for all patients of diabetes who have hypertension. Pre-hypertension, that is BP of systolic of 130/139, diastolic between 80/89, they should be given lifestyle behavioral therapy for maximum of 3 months. And if not controlled, they should be put on pharmacological therapy, and one should not wait for more than that. The choice of treatment drugs should always include an ACE inhibitor or an ARB if ACE cannot be tolerated, and should usually include a diuretic. Subsequently, obviously, a calcium channel blocker, beta blocker, or alpha blocker may be used. We should use oral hyperglycemic drugs, as we have said, the SGLT2 inhibitors, GLP-1 or DP4 because they also have a synergistic effect in lowering the blood pressure. And ultimately, it has been seen that the achievement of the target goal of BP is more important than the particular drug regimen used. So that is more important that we achieve the target goal. However, ground realities are different. As we have mentioned, only 28 to 36% of patients have their BP controlled to less than 130/80, and only 4 to 10% of diabetic patients ultimately meet the combined ADA goals. So there's lot much to do, lot much to teach our patients regarding this. And in this day of increased stress, lack of exercise, bad food habits, we find that incidence of diabetic, incidence of hypertension, both are increasing. And here we see that as a company policy in some companies, they are handing over blood pressure cuff as one goes up the rung, goes up in the promotions to a higher level. So thank you for patient listening, and I'm open for any discussions. Thank you.
Thank you, Dr. Gua. Thank you so much for your excellent presentation. So just one question I would like to ask you, Dr. Gua. I mean, how relevant is ambulatory blood glucose monitoring in our diabetic population? Because we know that a lot of patients who come to the clinic, they may be having what we call as white coat hypertension. And then people with diabetic tend to have autonomic neuropathy, which can have an impact on what we call as dipping and non-dipping, which again has got implications on the cardiovascular complications of the patient. Which group of patients would you recommend a 24-hour ambulatory blood pressure monitor?
Yeah, thank you. That's a very pertinent question, I would say, because these days the patients come with irregular lifestyle, and also, as you rightly mentioned, patients with autonomic neuropathy, and in their patients may have a tendency of blood pressure fluctuations. So ambulatory BP monitoring and ambulatory blood sugar monitoring both have an independent role in the control of this. And in patients with an irregular lifestyle, there we need to do an ambulatory blood pressure monitoring also to see the fluctuations of blood pressure. And that would also exclude Vicodin hypertension, as you rightly said. And we would be able to see clearly at what time his BP is going up. And there comes the role of chronotherapy as well. We need to time the medications properly as well to control that. So that's very important, I would say.
So if there are any no more questions, we can move ahead to the next session.
Thanks, Dr. Saibal. Thank you.
Thank you.
Thank you, Dr. Gua. Thank you so much.
Thank you.
So again, for the next session, again, we have got a very interesting topic, and to speak on that, we have Dr. Anuba Srivastava. Basically, she'll be speaking on the landmark trials which has been happening in the field of diabetes. Dr. Anuba, basically, she has done her MD medicine and a fellowship from USA. She is a professor in the Department of Medicine. MLN Medical College Prayagraj, has got multiple honors and medals which she have got in her long career. She's also got the Dr. S. Rastogi Memorial Award.
Thank you, Dr. Vinod. I think
it's a big list, yeah.
No, it's also kind words. I should thank my chairpersons for kind introduction, and special thanks to Dr. Arvinda for organizing such a wonderful conference and making me a part with the galaxy of speakers, I should say. Wonderful scientific deliberation. And I will congratulate my previous co-speakers. They were apt on time. So I will try to sum up my talk. I think the lessons are to be learned from the history. So I'll try to be on time. And I will also thanks Dr. Ajay Tiwari for being here. So without further delay, I'll start my talk. So I'll be talking about the landmark trials in the field of diabetes over an era. And as we all know, from the era of ancestors, we are told about to learn the lessons. Otherwise, till these will be repeated, and we have to learn. So the landmark trials conducted with a huge population for long duration, enhanced our understanding over the disease and its natural progression. So this understanding of the natural progression would definitely help us these lessons to be put into translated into clinical guidelines. Numerous researches have been conducted in the past which taught us various lessons to optimize the treatment approaches in several different populations. So talking about the landmark trial, as per se, that we'll be talking on the glucose control trial. On type 1, it is the DCCT and the EDIC. Outcome trial, the insulin trial, the origin and the debot, the GLP-1 trials, the ELIXA and the LEADER trial. I'll just go through the glimpses and the lessons what these trials have shown. This is one of the most sought after trial, the UKPDS trial, which was conducted over the intensive glucose control versus diet control and the reduction of risk of complication of diabetes. So it was a 20-year interventional trial from 1977 to 97, and around 5,000 patients of type 2 diabetes who were recruited, and followed by a post-trial monitoring of 10 years. They were divided into two conventional group with diet and intensive group with medications. And as you can see, there was no significant difference amongst the two groups over a period of time. So what were the clinical implications? For a newly diagnosed type 2 diabetics, it showed a significant reduction in the microvascular, but not the macrovascular disease, with intensive control of blood glucose. The tight blood pressure control, as Dr. Guha was saying, definitely if all the other arms were controlled, it definitely reduced the microvascular complication and improved the morbidity with decrease in the incidence of heart failure and cardiovascular accidents. Nearly 50% of the participants had one or more complication at the diagnosis, so emphasizing the need for early diagnosis and treatment, though the intensive group does not increase the risk of cardiovascular disease. Even the follow-up 10 years, they also showed up similar. The legacy effect persisted and the microvascular risk was reduced, though there was, after 6 years, they show early loss of glycemic differences. Coming to the DCCT trial for type 1, there's a diabetes control and complication trial, which was followed by the epidemiology of diabetes intervention and complication trial for around 6.5 years. This DCCT trial was conducted on type 1 with the same aim of comparing the intensive with the conventional diet therapy, and the EDIC trial examined the long-term effects of the original DCCT intervention. As you can see, definitely over a period of time, that the legacy effect persisted. Once these patients were controlled on an intensive therapy, they were able to maintain a 10% reduction of A1C was associated with 21% reduction in the risk of cardiovascular events. So intensive diabetes therapy has long-term beneficial effect on the risk of cardiovascular disease, in addition to diabetic retinopathy, nephropathy, and neuropathy reductions. And this was similar seen in type 2, but also in type 1 patient in this study. And once this were followed by EDIC trial, this metabolic memory was there. This effect persisted even after 10 years. Talking about the cardiovascular risk reduction trials in type 2 diabetes, first to mention the action to control cardiovascular risk in diabetes study group, the ACCORD trial, where the strategy was the intensive therapy versus the standard therapy, was conducted over 10,000 patients, a multicentral trial. We have seen there was significant A1C reduction with the intensive group within 4 months as compared to the standard therapy, and the rates of primary outcome in the two groups began to separate after 3 years. But the lessons what we were learned were, compared with the standard therapy, use of intensive therapy to tight normal A1C levels for 3.5 years increased the mortality, and it did not significantly reduce the major cardiovascular event. This was one of the highlight of the trial, higher mortality rate in intensive group. So there always remains a dilemma of a tight control or a loose control. So it is the clinician who need to decide what seems to be better. But as these major RCT trials, Another trial I'll talk about is Action in Diabetes and Vascular trial, that is the advanced trial, which was conducted on around 11,000 patients with one in the intensive glycemic control and the standard glycemic control. As we can see, this was followed up for around 3 years. And the cumulative evidence showed there was, as compared to the microvascular and the macrovascular complication, there was no significant difference, but definitely the prevention of macrovascular complications requires a multifactorial approach, addressing all the major modifiable risk factors. As Dr. was talking about, the blood pressure control, the blood lipid control may definitely be required along with the glycemic control to produce a reduction in the macrovascular complication. The intensive control of glucose an important role in prevention of microvascular complication, as has been seen in the previous studies also. Talking about the STENO studies, it was a study which was done to assess the cardiovascular risk factor assessment in the two groups, the modification, which to modify the risk factors, cardiovascular risk factors to the conventional targets and to the strict targets, dividing into the intensive and the conventional therapy. Definitely, as compared to the A1C level, the total cholesterol, the blood pressure, and the LDL cholesterol, the intensive therapy patients showed a better outcome as compared when compared for mortality, for stroke reduction, for MI reduction, for revascularization procedures. So the lessons what we learned from these studies were the intensive intervention with multi-drug combination and behavior modification has sustained beneficial effects with respect to vascular complication on rate of death and cardiovascular complication. So summarizing the glucose lowering trial, the ACCORD, the ADVANCE, definitely the primary outcome of the occurrence of the non-fatal MI, the non-fatal stroke was reduced. But if we can say there was no benefit on major cardiovascular event, and enhancement, 22% increase in the mortality in the ACCORD trial. The ADVANCE trial also showed the reduction in both the macro and the microvascular without any enhancement of mortality, and same by the VADET trial. Other long-term cardiovascular outcome trial done with the DPP-4 inhibitors, talking about the TCOS trial, used sitagliptin and was conducted on 14,000 subjects for a period of 5 years with the primary objective of MACE criteria, and these are long-term effects of DPP-4 on the cardiovascular outcomes. The SAVOR trial where the sexagliptin was used, this has to be terminated because of the increased risk of hospitalization for heart failure. The allogeptin trial for the objective of non-inferiority was conducted for 5 years with 5,400 subjects. The Carolina trial, where there was a non-inferiority trial between the linagliptin and glimepiride for a 6,000 subjects. So the basic objectives of these trials was to determine the effect of DPP-4 inhibitors on the cardiovascular outcomes and to assess the major adverse cardiovascular outcome. So in the TCOS trial, sitagliptin did not increase the risk of major adverse cardiovascular, even though sexagliptin enhanced the rate of hospitalization for heart failure. Allogeptin, they included more of the hospitalized cardiac patient, and they did not see any increase in the major cardiovascular event. And similar with the vildagliptin, which is not associated with increased risk of major adverse cardiovascular, making most of the gliptin except sexagliptin considering the heart failure to be safe, cardiovascular safe. Other major cardiovascular trials done was SAVOR-TIMI trial. We've talked about these. The EMPA-REG trial has also shown, this was study which was done with empagliflozin on around 7,020 patients with a primary endpoint of 3-point MACE criteria. And this showed their superiority or non-inferiority if you consider, and there was in respect to the major adverse cardiovascular event, but also they showed decreased risk or reduction in 38% in lower risk of death due to cardiovascular disease, 35% lower risk of hospitalization due to heart failure. A word about the Carolina trial, which a head-on trial of 6,000 patients with lina and glimepiride, with both the patients were on standard care. It was a multicentric trial conducted in 43 countries, and they were at par or it was a non-inferiority trial, though the events of hypoglycemia seen were more with glimepiride. Some prevention trials, one of them being diabetes reduction assessment with ramipril and rosiglitazone medication. So this was for the prevention or delaying the development of diabetes in patients with impaired glucose tolerance or impaired fasting glucose. So the results, what we have seen, the ramipril, when a dose of 15 milligram demonstrate neutral effect on the new onset diabetes or death. It is possible to slow the development of type 2 diabetes with lifestyle intervention. Medications also show significant slowing of the development along with rosiglitazone, which was shown to be effective as intensive lifestyle. Lifestyle changes has to be primary approach to reduce the risk of type 2 diabetes. In those who are high risk, lifestyle modification intervention is not feasible. The risk-benefit ratio should be sought and the medication should be advised. Talking about the Finnish diabetes prevention study, which they assess the short-term and long-term changes in diet and exercise behavior, effect of intervention on glucose and lipid metabolism. So you see the intervention group, when the patients, both the control and the intervention groups showed better reduction in the progression of diabetes. So the reduction in diabetes was related to number and magnitude of lifestyle changes made. Each component of the intervention may have to be sought. This similar results were seen with the Indian diabetes prevention studies, where the interventions were done in the native Asian Indians with IGT who were younger, leaner, more insulin resistant, as is the Indian diabetes. Difference, if we see the medications used, they have similar effect, and there was significant difference between the control and the modification. So hence the lifestyle modification with or without metformin, both have shown reduction of the incidence in diabetes in Asian individuals. So both lifestyle modification and metformin have shown significant reduction in the incidence of diabetes in Asian Indians with impaired glucose tolerance. A word about the diabetes prevention program. The goal is to delay the development of type 2 diabetes in person with IGT. Here also, both the interventions were well accepted and safe. Intensive lifestyle resulted in weight loss, increased activity level for the duration of the study. 58% reduction with intensive lifestyle was seen. Metformin reduced around 31%. Lifestyle was more affected than metformin. Acarbose for the prevention of type 2 diabetes, that is the STOP and IDDM trial, aim to assess the effect of acarbose in preventing or delaying conversion of IgT to type 2, and it can also be one of the alternative along with the lifestyle if the patient is unable to control on maintaining the target of 70% time being in CGM. So the recent trial trial, the dapagliflozin and the cardiovascular outcome in type 2 diabetes, that is the DECLARE-TIMI trial, which shows there was significant reduction in the major adverse cardiovascular event, the reduction in the heart failure, cardiovascular diseases, and the renal benefits were seen. The DAPA-HF trial, which showed the lower risk of worsening of heart failure or death from cardiovascular causes and better symptom score. Based on the DAPA-HF, US FDA has approved dapagliflozin to reduce the risk of cardiovascular death and heart failure hospitalization in patients with heart failure with reduced ejection fraction with or without diabetes. Now the data are also available for the preserved ejection fraction with or without diabetes, and making it a good choice for the cardiologist and the nephrologist more than the diabetologist. Coming to the DAPA-CKD trial, which has shown the reduction in the average of 39% of worsening of the CKD patients, 50% reduction in the benefit to the major endpoint with or without diabetes, and dapagliflozin delayed the initiation of dialysis and reduced the number of deaths regardless of diabetes status. So a word regarding the cardiovascular benefit of the GLP-1 RA in type 2 diabetes, when we're talking about the semaglutide, the SUSTAIN study, the albiglutide, the liraglutide, the exenatide, and dulaglutide, which all have shown to have a beneficial effect when talking about the MACE criteria. A word regarding the semaglutide in a dose of 2.4 milligram once weekly have shown a favorable cardiometabolic modulation and successive weight management in obesity. Last but not the least, the STEP trials with SEMA, the SURPASS trials with tirzepatide. I had tried to sum up all this in same trials, but what we have seen, the previous trials have definitely showed us a way. Still the intensive control and the conventional control, we can say that we have evidences that intensive control have shown a better result in controlling the microvascular complication, but certain studies have shown enhancement of the cardiovascular death. So we should be slightly skeptical. We cannot have a generalized route for all when prescribing medication. Lifestyle holds true. We should advise for the patients with higher cardiovascular risk assessment, the tight control can be beneficial. The modern medications should be a part of our armamentarium, which not only advocate the glycemic control, but all the other arms, the blood pressure, the weight. And I have given you lots and lots of data. So I think lessons have been learned and we are moving in a definite new era. Thank you. I would be happy to answer any questions.
Thank you. Thank you so much, Dr. Anubha. I would say that 20 minutes is too less of a time to even touch upon these important landmark trials. But then you have done a very excellent job. I mean, you have just highlighted the big points which has been in these landmark trials. Just one question, Dr. Anubha. I mean, for all these big trials, I mean, this important landmark study, which one would you pick up as the one which has got the biggest impact on your routine clinical practice? For me, it has definitely been UKPDS, because this one which has definitely.
We use day in and day out. We always take UKPDS as a gold standard. When we talk about control or the lifestyle modification has to be part of our clinical practice in day-to-day practice, where we not only talk about diabetes. Now the RSSDI even has taken, or the WHO have taken that to prevent or halt pre-diabetes. So we need to mention UKPDS trial, the DCCT, their legacy effect, hit early, hit hard, with lifestyle modification, now even the metformin being included to be used for pre-diabetes. So we need to bring down the level of the glucose. We have to keep maximum patient 70% being in, if we say this in time in range, so as to prevent the micro and macrovascular complication. And not only use of newer medications. Whenever we suspect we are having patients of atherosclerotic risk factors present. So why not give the benefit of using wonderful drugs we have nowadays?
UKPD is also demonstrated the concept of metabolic memory, the good and bad memory. This is a study which has got the longest follow-up, and they recently had the 44-year data with them, and that was quite significant.
Sure, sir. Definitely, sir.
Ma'am, I do have one question. When we suggest lifestyle modification and we encourage weight loss, what would be your biggest sustainable factor to tell the patients? Because, you know, they're like, okay, we'll give up this, we'll give up that. But how long is that sustainable? What would be the sustainable lifestyle modification that you would advise them?
Very good question, Dr. Ishita. Actually, we are talking of reversal of diabetes. Now, the patient is coming and talking of reversal or remission of diabetes. We all agree 5%, 10%, 15%. 15% of body weight to maintain that for a period of 2 years without an oral antidiabetic, okay. But how are you able to maintain this for so long period? You have to maintain this lifestyle, this diet, what we are talking, for such a long period of time. Though I don't say anything is impossible, if we definitely are able to motivate the behavioral changes in the patient. I think you are yourself an example for this. So we need to actually be a role model for the patient themselves. Right amount, right type of food, right time of food. and like more of changing the carboholic character of our food to more protein rich food, enhancement of FITT in our physical activity. We have to have not only the prescription for diabetes in our patient, we definitely need to write. We just don't rely only on the dietitian. You have to mention of the type of food should be taken, the time duration, time when they should be taken, the amount they should be taken. Similarly, for the exercise, a structured exercise prescription should be there, the frequency, the type, the timing. So these will definitely matter, and we can have more and more patient diagnosed at a pre-diabetic level, more and more patient going into remission of diabetes. We have to create, I think post-COVID, we are seeing there is a momentum of wellness, momentum of fitness. I think Dr. Ajay is there. He's a keen cyclist. And so we have to become a role model in ourselves, and so that we can promote to the community. The people look forward to your doctors. So though it is not a very easy task, let's make it a momentum to have a lifestyle modification.
Thank you so much, Dr. Anubha. I think we are running on time now, and it's time for us to conclude the session. So I would like to thank all the speakers who have come in and have shared their beautiful insights over here. And once again, a big thank you to Dr. Arvinda, who has brought this session together, a good academic session, which we are quite looking up to. So thank you so much, Dr. Arvinda.
Thank you, Dr.
Thank you, sir. Thank you so much. As Arvind sir is busy in the all DA, there is oration going on, and thank you so much, ma'am. And thank you for all the three speakers with the immense knowledge. We could carry a valuable knowledge, and thank you, chairpersons and the rapporteur. Thank you for the session. And let's move on to our next session, session 3. I would like to introduce the chairperson, Dr. Sumesh Raj, MD, FRCP, Professor of Internal Medicine and Diabetology, Sri Gokulam Medical College, a famous diabetologist from Trivandrum. Welcome, sir. And I would like to introduce our next chairperson, Dr. Kandula Sai, MBBS, FDRC, graduation from Rangaraya Medical College, Kankininad, FDRC, from Diabetes Research Center, Chennai. Welcome you, sir. Over to the chairperson.
Yeah, good afternoon all. So this is a technology workshop, and the first session is by Dr. Sachin Mishra from Unnao, and he'll be talking on the EMR and future of diabetes. He has won the Young Diabetologist Award in 2021. He's a physician and diabetologist and active participation of multiple organic researchers and ongoing research, and he has won so many awards to his credit. And he was a faculty in Diapon 2021. Over to you, Dr. Sachin, for your interesting talk.
Thank you, Shomesh sir, for such a good introduction. So moving forward. So are my slides visible now?
Yes, sir. Your slides are visible.
So I am Dr. Sachin Mishra. I am physician diabetologist at Unnao, RKM Center, and today I just want to firstly thank Dr. Arvinda sir for organizing such a nice conference full of every topic which I can ever search for at the topic of diabetes on Google itself. So moving forward, I have been given this responsibility to slightly talk about EMR and future of diabetes. So EMR, electronic medical record, we are all knowing, we are all practicing during these days of COVID era, more nicely practicing. And now EMR as a tunnel towards what is the future of diabetes. This is today's topic of my talk. Moving forward, what is EMR, its role and methodology? So EMR, electronic medical record, just doesn't stop at a point of having app at your center or having a web portal at your center for the entry of your diabetic friends. It has it has to have these 8x4 systems of diabetes digital clinic. Then we will have we will easily say that we are having a digital clinic full of every kinds of things. So first, in the most important aspects, it is patient engagement. As soon as that diabetic friend of yours enters to the diabetic OPD, lands to the lobby of your diabetic OPD, how you engage, how your staff engages to that diabetic friend is a goal, is a point of EMR and its reference and all its fundamental characteristics. So now moving towards the next, it is health analysis. Health analysis through all methods, either by physical or by artificial intelligence of that diabetic friend. Then wellness, how do you treat and what all do you provide at your center? So moving next, it is biosensing variables, which has been towards the technological aspects of today's diabetes era, that either it is CGM or it is what we say insulin pumps or whatever the technological aspects, it is by biosensing variables. Now telemedication, it has been increased during COVID era and now we are really practicing it. It is also into action by the government. So now telemedication is also a very important part of this digital clinic. So health information exchange between multi-centers and centers, because so that there can be easy approach to the type of diabetic friend appearing at your center. So home care, the most important part we need to access in diabetes and diabetology about all kinds of care, either it is exercise, food, lifestyle, or any kinds of insulinization, pump therapies. And last but not the least, it is almost important, it's cloud computing. Whatever you have, where you keep and how do you analyze is the basic future of diabetes. So with this EMR, its role and methodology, I am just going to move forward towards my next slide, which says EMR for diabetes management plus future of diabetes, that whatever we work in the future, because for diabetes, because of diabetes and under diabetes, is a new term, a very well-known term to everybody out here, is precision medicine. And with this precision medicine, I am having these 17 slides onto my screen. So moving forward, what is precision medicine? The National Institute of Health, USA, defines precision medicine as an emerging approach to disease treatment prevention that takes into account with individual variability in genes, environment, and lifestyle. So this was a clear-cut definition. Now making it more easy to understand precision medicine and how we define and compare current medical practice. What it says use of vital signs to today, relative to last visit, assess symptoms, physician uses expert background, experiences and judgment to diagnose, prescribe. This was current medical practice. Now personalized medicine is collect and analyze these current medical practice data, whatever we have collected, and work according to this. Physician uses this information and data to make more informed diagnosis, more relevant and more accurate. Moving forward towards the precision medicine, use massive data network that aggregates and analyzes information from huge patient cohorts, healthy population and experimental organization, and helps in reaching towards the disease mechanism and precision diagnosis, the perfect classical characteristic diagnosis towards characteristic perfect clinical treatment. And for each every whatever word we think in terms of diabetes, we have a perfection in these types of medicine practice, which we call as precision medicine. So moving forward, what we have in precision medicine, what was the paradigm, what is the paradigm shift? Yesterday we were practicing system-based medicine, that is infusion medicine. Today we are practicing pattern-based medicine, that is evidence plus intuition, both medicine, that is pattern-based medicine. And tomorrow we are going to compile all these things: symptoms, pattern, lifestyle, characteristics, the genetic influence, and all those characteristics of that person who's landing into ROPD, and that will be turned into an algorithm. And then that algorithm will be called as precision medicine. According to those, we will get an idea that what kind of medicine has not to be prescribed, what kind of lifestyle has not to be prescribed. in this kind of diabetic individual. Individualizing the treatment is the goal of future of diabetes. So applications of rules, algorithms, and reference databases enables actionable clinical decision support and precision efficient care. This is what I'm talking about. Moving forward, what my next slide says, not one size fits all. This is the fact of, this is the most important part of my presentation. What we are doing everywhere is the traditional methods. We don't have to follow now. We have to collect the data. We have to help our governances. We have to help our associations, help our research bodies to develop algorithms, precision medicine, so that we only get a help to personalize and individualize the treatment and all kinds of modifications with our diabetic friend. So moving forward, ideal objectives of precision medicines in diabetes: improve diagnostics. Yes, it improves. Establish what evidence we have and what evidence is needed to develop best practice guidelines. Provide education to implement best practice guidelines and best practice research, which is the most aspect in the most biggest aspect in terms of Indian and Asian countries. Establish a research program to address open questions. Accelerate the process for getting access to trials and regulatory authorization. Modify guidelines, and if we modify and improve the daily to daily guidelines, we will now be individualizing the medicine pattern of our diabetology, and that will be termed as precision medicine. So moving forward, the path to precision medicines comes across these very beautiful points, very well illustrated in this slide. Understanding the disease, risk factors, mechanism, and natural history, then identifying the disease, specific biomarkers, then vertical integration of biomarkers, generation of algorithms through this precision medicine kind of thing, where algorithms will be developed in future, are being developed, regulatory engagement of both doctor, paramedical staff, and the diabetic friend, patient engagement, testing single biomarkers or biomarker sets in intervention trials. This is the most important. We at times in trials give hundreds and hundreds of tests and hundreds of investigating sets, but these kinds of precision medicine will also help in just justifying that what kinds of tests we need in this trial. So clinical education, health economic assessment, most important factor is this only, the money factor, the regulatory approval of these kinds of all the work we do in precision medicine, which will be the future of diabetes. Then clinical translation, how we translate these kinds of data, these all data, how we translate into the effect of my diabetic friend, and then patient feedback, either it is good or it is bad. So this is the precision prevention, how we prevent, prevention and remission and reversals. Dr. Anubha ma'am was also talking about reversal. We are talking about these three things only. So preventing the pre-diabetes, reversing the pre-diabetes, and remission of the diabetes is what we need in present era. Risk for factor avoidance, lifestyle interventions, monitoring, treatment efficacy, minimizing the side effect. These all can be done at one go with precision medicine, which is the future of diabetes now in the coming era for diabetology. Now, precision prognostics. So as this diagram clearly depicts, some in white, some in black, some here in gray, black and white mix, and combined with precision medicine, what we can know, the cerebrovascular disease and patients, retinopathy patients, cardiovascular disease patients, nephropathy patients, neuropathy patients, we can easily classify them, get them a superior most consultation prior to the time where the disease affects the body nicely and need of hospitalization is there. Then we can have patient-centered outcomes and we can have reduction in death. I pursue this slide as like this only. Prognostics can be made at a better level with this precision medicine. Moving forward, more correct, more fine, and more to the dot precision diagnostics with precision medicine can be made. Epidemiological evaluation, probability based on clinical features, the symptomatic assessment, and diagnostic testing. The most important thing is that what we go for, what the point we need to make our diagnosis is going to be more clear with these kinds of precision medicine practices. Probability-based decision will be less, and evidence-based decision and perfect decision will be more. So moving forward again, so this is all the work that has been done with ADA, American Diabetic Association, on this precision medicine. So phase 1 and phase 2 have been completed, and we are towards now phase 3 and phase 4. Though it's a long process, but it's very, very much needed at the molecular level also. And yes, if we practice this, if we go into these kinds of researches, if we follow these kinds of guidelines, we are going to be then now called as the future of diabetes country, not the leading capital. So moving forward, this is a diagram, slightly blurred. So this is a very beautiful photo depicting what and how precision medicine works. So these are the 4 classes what we have at our society: childhood, adolescence, adulthood, middle life, and older age. N number of classes are there in terms of what they eat, what they work, what they exercise, and what they want, just depicting about the dietary prescription. So according to these, the demographic details, the what they bring into our OPD with the printed investigations, or their physical statuses, we have an input raw data. According to many input raw data, we create an algorithm. The data testimonial is made, and then a test segment has been tested. For example, a purple one needs red, or what I can say, a meat or potato, tomato or apple kind of thing. The yellow one needs, as per diet, needs cheese. The green one needs green leafy vegetables. These kinds of things can be easily pointed out by precision medicine. The perfection of just individualizing the every aspect of diabetology, whatever we are talking about, either it is technology, it is lifestyle, it is diet, exercise, it can be easily done by precision medicine in coming future. So moving next, it is again the beautiful picture, principle of personalized precision targeted medicine. One picture says all. What it says, that where the benefit of exact medication, lifestyle, and diet has to made in which group? Drug not toxic and not beneficial, so not at all impactful. Drug toxic but beneficial, so it is toxic, not to be given. So drug toxic but not beneficial, so not at all to be given, but drug not toxic and beneficial at the same time. This is what precision medicine says: drug not toxic and beneficial. So with this very beautiful photo, we can take any characteristics of diabetes, either it is diet, it is lifestyle, it is person-to-person aspect, it is CGMS data, where CGMS has to be placed, where insulin pumps has to be placed, what is the treatment goal, what are to be treated, what are the molecules given onto the treatment. We can easily cope up with this precision medicine. This red word, we have to make it into our minds that what we are going to do in future with this precision medicine and how we are going to practice it. So moving forward, so it is an infinity circle of what I say precision medicine. Infinity circle means wherever we start, we will come to the back point, and a part of this cycle, we will have a very beautiful result. So I started from here, evaluation of real world evidence and clinical trials, stakeholder education, for example, who need to get educated about precision medicine, the future of diabetes, regulatory approval, health disparity assessment, health economic assessment, clinical translation, stakeholder feedback, whatever is the feedback of the person who is studying or who is getting knowledge about precision medicine, the future of diabetes, capacity building, research, and again regulatory management. And out of these, what we get is society or societal benefits for our diabetic friends. We goal it, we create an impact on it, and if we practice in it in future, let me tell you, we'll have boons and boons of very good diabetic reversals, as well as pre-diabetic reversals, as well as remissions. So moving forward, so artificial intelligence in electronic medical record for diabetes management, the next step to precision medicine. Is this the next step to precision medicine? Yes, it is the next step to precision medicine. Why? The all slides which I went throughout. For example, one picture says all. the correct medication, what is the impact of that medication, what kind of structural exercises we have to give to that personalized diabetic friend landing into our OPDs. How we are going to prescribe the diet and how we are going to preserve the diagnostic factors and prognostics also. These all, again, I summarize, can be targeted in just one thing, that we support this precision medicine, we practice, we collect the data, we influence those data. If we not give to some association, we itself influence and categorize the data, that how we are going to work it in future, because future of diabetes, irrespective of all technological abilities, future of diabetes depends upon the algorithms and the correct spot where we have to hit hard. For by this slide, so these are digital diabetes industry currently comprising 7 key segments. As we are talking in a technological session, these are all together available at Indian and Asian platforms, connected devices manufacturers, what these device gives, app services providers, data management solution providers, value enhancement service providers, HCP solution providers, ecosystem data integrators, and other service providers are all present in the markets itself. They are searching for us. We are not letting them enter into our systems, because we are not able to practice medicine at a high level. But it's time to focus for the future of diabetes. We need to know what is precision medicine, and we need to practice it accordingly. With this beautiful slide, नापो तो जानो, शक्कर से ज्यादा मीठी है जिंदगी, life is sweeter than sugar, check to know. Thank you. I suppose I completed that time. Thank you, Dr. Ravinda sir. Thank you to the respected senior chairpersons of this session.
Yeah, thank you, Dr. Sachin. It was an excellent talk. And one question from my side. It is you are always told in this, it is a patient-centric approach. And again, and the last slide was regarding the artificial intelligence. Do you think if artificial intelligence comes in the near future, it will replace the role of diabetologist?
Sir, actually, the end point of the diabetologist is, are we going to accept that data which is being providing according to the patient or not? First point. Or if we are going to accept that particular algorithm for that diabetic individual, are we going to make it at that point only? For example, a certain amount of structured exercises are being provided by the algorithm of precision medicine. So are we going to accept for that diabetic individual, which is, for example, he's saying that he's having a frozen shoulder pain. So are we going to accept it in terms of shoulder exercises, or are we not? So the ultimate decision makers are we only, the diabetologists, the endocrinologists, the medicine practitioners. But what it says, we are going to get a data that what we have not to be prescribing or not to be advising in these or any kinds of individual by this precision medicine. So the guideline says it is not the idea to the doctors. It is idea where not to practice for the doctors. And it will, let me tell you, sir, it will not only affect the metropolitans, it is grossly going, precision medicine, the future of diabetes is grossly going to affect the peripheries of India, the peripheries of Asian countries, because the main thing, the main control, the reversal, the remission is accommodated in the metropolitans, not at the peripheries. The peripheries where we get uncontrolled hospitalizations, everything, the emergencies, the diabetic emergencies, these will be reduced, because because of our data, will give an idea to those who are practicing in peripheries.
Yes, thank you, Dr. Sachin. The point well taken.
I think Dr. Sachin, when we announced this our conference, Dr. Sachin said, sir, I want to speak on EMR. He was very, very enthusiastic and he volunteered, but the way he has prepared his slide was excellent, exhaustive, and very well presented. Good one, Dr. Sachin, good one.
Thank you, sir. Great going, sir.
Over to Dr. Kandula and Dr. Sumesh, please.
Yeah.
Dr. Kandlasai, I should say, I'm honored to see that memento there. Yes. Thank you so much. Thank you.
Showing there.
Okay, thank you. At the outset, let me thank the great Arvind and team for giving us the opportunity to be a part of this fantastic conference. Let me introduce the next speaker, Parimal Swami. His topic is point of care testing in management of diabetes. We can go to the lot of the things, what is credit. Over to Swami.
Okay. Am I audible and my slides are visible, sir? Full screen?
Yes, sir.
Hello.
You're audible
Yeah.
and
Yes, you are audible and we
Thank
can
you.
see.
Thank you. Thank you, Dr. Arvinda, for hosting such a nice conference. It is 12:25 and I am not on the time. So that speaks about the efficiency and management of Dr. Arvinda. Respected chairperson, sir, and the friends who are here. It's a great opportunity for me to discuss about a very, very important and interesting topic, that is point of care testing in diabetes. Now, when we go to these two great quotes, the wisest are the most united, the loss of time, and hastiness and superficiality are the psychic disease of the 20th century. I think the reality of the point of care testing lies between these two things, two limits. Time is of essence, and the haste sometimes makes waste. So there are many perils of the quickness of practicing medicine. So I'll be discussing and evaluating the point of care testing between these 2 points. Now, there are various definitions of point of care testing. I've summarized all the important points. The testing which are performed at or near patient and at the site where care of treatment is provided. All testing which are not undertaken in central laboratory, that is about the pathological test. But now there are many, many tests, the physiological tests, which are not done in a laboratory, but they are done right on the patient's body. And these tests, they also come under the purview of the point of care testing. Performed by a competent individual. Point of care testing does not mean that they have to be taken lightly. So they are important tests and they have to be performed by a competent trained person. And the result should be acted upon as soon as possible. Only then we will get the benefit of point of care testing. The faster test results leading to a faster turnaround time, results are typically available relatively quickly so that they can be acted upon without delay. So that is in a sense the point of care testing. One unofficial definition of point of care testing is that the results should be available before the patient leaves the premises of the healthcare provider. So these are the important points. What is point of care testing? Now, it was introduced way back in 1962 with the development of a method for rapid analysis of blood glucose, that is our good old glucometer. And in 1977, the pregnancy test, they came into the practice. And now the point of care test market is projected to reach around $38 billion from 2020 to 2023. Again, the blood glucose level detection, the diabetes remains the center point of care testing, and the cardiological analysis, especially the acute coronary syndrome diagnostic, which are done at the bedside or in the emergency room, they also constitute the big chunk of the point of care testing in present day clinical world. India, of course, provides a huge market potential for POC diagnostic devices and to progress and fulfill the healthcare demand of the large population which are there in our country. The market split by type of the point of testing, again, the blood glucose testing, that remains the primary POC in today's clinical practice, followed by infectious disease testing. We have seen the rapid development of the infectious disease testing during the COVID time. Cardiac marker, again, they are being used in big hospitals. Now the usage is now being increasingly used in smaller places also. Then coagulation testing, pregnancy and fertility testing, again, a big market. And in the ICU, that is the portable blood gas and electrolyte testing. These are done. We all are doing urinalysis in our bedside lab or in our clinic's lab. So this is the market split by the type. Now, these are the different POC devices. I'm not going into the details. And some of them, you know that even the thermometer, the blood pressure monitor, they all come under the purview of POC. Now, there are different type of point of care testing platforms. The biggest chunk of point of care testing is taken up right now by the pathological test or the biochemical test. So there are various platforms. Some are open platform where you can perform multiple tests on a single instrument, and then there are dedicated single parameter tests. Like the one example is Siemens urinary albumin creatinine ratio analyzer, and it gives the result within 3 to 5 minutes. And there are certain open-ended platform where you can use different strips, different cartridges, and can get a large array of tests with you. I have just summarized the range of point of care tests done with a particular system, and you can see in an addition to the infectious disease or some other thing, the diabetes, the test of the systemic inflammation, the cardiac markers, and the thyroid hormones, which are basically being used by us in our day-to-day diabetes practice. They can all be done in our site lab or the lab which is attached to our clinical setup or our clinic. Now, the World Health Organization came about the assured criteria for the point of care test, and the point of care test instruments. The technology should be affordable, sensitive, specific, user-friendly, rapid, and even sometimes equipment-free, and it should be delivered to the needy as quickly as possible. Now, India provides a huge opportunity to do the point of care testing because of certain barriers to the delivery of good healthcare in our country. These can all be overcome by this assured technology. So the lower turnaround time, the personalized diagnostic can be provided. The previous speaker has given us an excellent account of the precision medicine. So again, we can customize the test and we can get the customized results and accordingly manage the patient. Early detection and proper planning of the treatment can be done right there with the first visit or with the immediate visit of the patient. And there is huge amount of time saving by the point of care testing. Now we go to the point of care testing in the field of diabetes. We know that till now it is the diabetes market which occupies the prime position in the point of care testing. And we have all used, and our patients are now using SMBG instruments, the home glucose monitoring, then the continuous glucose monitor. Again, they are available to the patients directly. HbA1c monitoring, many of us now doing HbA1c monitoring in our clinic, and even in health awareness camps, we are doing this because the results are available quickly and the results are fairly accurate when we do it with the appropriate instrument. And again, in ICU, the ketone measurement is being increasingly used to manage the patient, to label the patient that he or she is out of ketoacidosis. So all these instruments are making life of the patient as well as the life of the healthcare provider very easy for the management of type 2 diabetes and type 1 diabetes. So there is 360-degree glucose metabolism monitoring is provided by the glucometer, HbA1c monitor, and the ketone monitors as well as the continuous glucose monitor. Now, present day glucometers are beyond glucose, and you can take out various inferences from the blood sugar values which are fed to the mobile phone app directly from the glucometer, the Bluetooth enabled glucometer. You can take out the trends. If you use the food diary, then impact of the particular food, and something like a rough personalized glycemic index for a particular patient. Now, there are certain systems, point of care systems, which are available for the hospital usage. One such system is I am describing, that is called the Cobas system. And with the help of this one glucometer, you can check the blood sugar of, say, multiple patients, and through the compatible app, you can get the inference or the data about different patients from a single system in a single app, and then you can initialize the treatment. And you can also see that there are various algorithms which help us in the calculation of the safe insulin dosage at the start of the therapy, daily suggestion for the adjustment of the planned daily insulin dosage, dose calculation for each individual insulin doses, and which depends on the blood glucose level and the amount of the meal which patient is taking. So this is the aim of the point of care testing, is to act upon immediately as soon as the results are there. So primary aim of POCT is acting on the information and favorably impact the clinical outcome is seen by such type of system. Now, we can also assess the diabetes target organ damage with these instruments. We have got now portable portable as well as a smartphone enabled fundus camera, pocket ECGs. If you you can take your diabetes clinic in your briefcase, lipid screening instrument, dedicated lipid screening instrument. They give fairly accurate results, not very, very accurate, but fairly accurate results. Especially they are used in health camps, or where we have to measure, evaluate multiple patients or large number of patients in a short time. Many of us are now using urinary albumin creatinine ratio analyzer. They are excellent when you compare them with the gold standard method. They are excellent. Again, you have to be careful about the make or the brand of the instruments. And we use a range of the foot examination instruments, right from simple monofilament to the portable biothiometer to the various instruments, which not only gives us the about idea about the ankle brachial index, but they also give the idea about the endothelial dysfunction. Now there are some instruments which can calculate multiple parameters in a single go. So these instruments are making the life of the patient and doctor very, very easy. They are making our treatment more evidence based, and they save time. So that is the whole aim of employing point of care testing and diabetes management. Now, there is reasonable evidence for point of care testing. When we go to the literature, there are some debates, but there is reasonable evidence that there is clinically meaningful reduction in HbA1c and hypoglycemia incidence. Early detection, possibly early intervention in diabetic retinopathy, very strong evidence that early detection of diabetes kidney disease through USER monitor. There is increased prescription of organ saving or organ protecting pharmacological agents like statin, SGLT2 inhibitor, and GLP-1 analog. Increased prophylactic intervention to prevent foot ulcer, and improved clinical outcome and quality of life, and cost saving on the long run. So these are there are evidence to support the usage of POCT in our day-to-day diabetes practice. I'm just giving you one example from a third world country where the community health worker uses glucometer and HbA1c monitor to detect about the glycemic status. The data is immediately transmitted to the healthcare provider. The community health worker and healthcare provider, they agree upon a treatment line of treatment, and the treatment is implemented to the patient. And then with monthly visit, the treatment is updated. And this sort of intervention, which is the truly point of care testing and point of care treatment, resulted in significant reduction in not only HbA1c, but it also showed durable HbA1c reduction in a large number of patients. So again, both the health worker and the physician, they agreed upon the treatment which was detected or which was sort of a designed based on an algorithm fed into the app, which was used by both by the community health worker as well as the physician. Now, with the increasing power of the mobile computing and mobile phone computing power, we will be seeing more and more tests being done. There is also an improvement and the precision, increased improvement in the precision of the data collected through the variables. And the day would come when you can see the fundus just by putting your mobile phone camera against the eye of the patient. No need for a dedicated fundus camera or anything else. So this is the power of point of care testing, and this is the future which we are looking at. Now, with the advent of multiplex point of care testing, where a single sample is run through multiple platforms and we get a huge amount of data, including the data which can be used in personalized medicine, and the day is not far then when the multiplex point of care testing would be available for us for the management of diabetes as well as some other diseases. Now, there are certain point of care testing which are underutilized. I have been using these tests, and like body composition analysis, the muscular strength, the grip strength, and the assessment of cardio fitness efficiency of the person, which can be done with the help of a simple setup. These three things together, they are the most robust indicator of mortality, morbidity, future complication, and life, and the evidence or the guide for the lifestyle intervention in our in our diabetes patient. But they are being underutilized. They should be utilized more, and together they surpass even the conventional risk factors for the mortality, morbidity, or the outcome of diabetes patient. The future, maybe we may be looking at a future where patient will not leave the home and you will not see or touch the patient, because every conceivable data, including the physical data like blood pressure, pulse, the heartbeat of the patient, the respiratory condition, everything could be transmitted to you, and you will be advising the treatment. I don't know whether it is good or bad, but it may come, and there are chances that we have to practice medicine sometime in future like this only. Now, the reality check, the analyst training and the operator training is essential. If the POCT is effective only if the action is taken immediately. It is more expensive. Right now, it is more expensive than laboratory testing. So we trade cost with the time. And it is neither foolproof nor error-free. So we should keep these things in our mind. This is the reality check, the advantages and disadvantages. I've already summarized the caveats about the advantages and disadvantages. I'm not going into the details of this slide. The causes of errors. We are using an instrument which is not validated, or we are using a carbon copy of instrument of the original instrument, which is not that specific or sensitive. This is one of the biggest error. Lack of current and updated manufacturer's instruction. The simple thing, like if you keep the glucose strip exposed more than 3 minutes in an environment, then the result could be faulty with the simple test like blood glucose monitoring at home. Failure to follow the manufacturer instructions like the temperature control or environmental control, which is necessary for the proper running of certain instruments. Using old reagents, failure to implement quality control measures, faulty techniques, and not acting or delayed acting on the results. These are the errors which are associated, and sometimes we have to pay a huge cost for these errors. How to prevent these errors? Evaluate the instrument, evaluate the technology, evaluate your environmental condition, and then select the instrument. A protocol should be there how to advise how patient will undergo that test and how you will get the results, so that the minimum time is spent and you get the maximum return on the investment, both in terms of your revenue and in terms of the patient's health. Regular quality control program. This is very important for the POCT instrument. Follow immediately, and training and competency assessment of the staff is essential when you are using POCTs. This is just a risk score. How frequently you have to do it. I highlighted only 2 instruments which are most commonly used in our day-to-day practice. The glucose monitor, weekly quality control, HbA1c monitor, weekly quality control. So this is very important, and basically it depends upon the analytes, the risk associated with the analytes, the device, the type of device, and the user friendliness of the device. As the score is more, the monitoring is, or the quality control is more frequently required. Now, my take-home message that point of care testing is reasonably sensitive, specific, and it is cost-effective when we used it, keeping the bigger picture in our mind. Select the proper instrument, define your workflow so that you can derive the maximum benefit and you can do the test quickly. You can have the range of POCT instrument in your clinic. If you are having dedicated diabetes clinic, then these instruments should be there in your premises. Fundus camera, ECG it goes without saying. Open platform with semi-automatic automatic pathology analyzer technique embedded in your clinic's workflow. They can use so that you can measure a list of biomarkers. UACR reader, that is urinary illumin creatinine reader. Neuropathy detection system, which may range from just basic monofilament to very advanced system. Ankle brachial index estimation. And I have already mentioned about the body composition analysis, grip strength, and cardiorespiratory fitness estimation can be done within few minutes, but very robust indicator. And if you can afford, and if you get those kind of patient, then you can have the endothelial dysfunction detection system. So these are the instruments which you can use in your day-to-day diabetes practice, and they'll give you a comprehensive picture about the patient's health and give you a proper guide to your management. So friends, it was a pleasure to be here. Thank you, Dr. Arvinda, again, and thanks for a patient hearing. If there are any questions, I will try to answer those questions. Thank you very much.
Thank you so very much, Paran Swamiji. The very elaborative talk and explanation regarding your techniques about the point of care testing in management of diabetes. You covered latest, past, and future catch also. So, any questions?
Yeah, can I ask one question, Dr. Piramal?
Yeah, Ashish. Yeah.
Hi.
Hi.
Dr. Piramal, thank you for the latest update on this point of care, because this is coming in a very good way in diabetic clinics. Now, you said that we need to get quality control done every weekly. Now, the thing comes like, from where do we get this quality control done, and how much will that be the cost? Because that also keeps on increasing.
Very good question, Dr. Ashish. There are various commercial quality control program. You can involve one. There must be certain individual in your city who have taken training for the QC, Quality Council of India, and they can implement a basic, intermediate, or advanced level of quality control program in your clinic. They come themselves and they check the instrument. for like glucometer, every day we check our glucometer with the semi-automatic analyzer, which is doing the glucose monitoring. So we do the simultaneous, from one sample simultaneous test, run into the glucometer and put into the usual analyzer, pathology analyzer. So that way we come to know about the accuracy of our own glucometer. It is my advice to the patient that you have to check your glucometer against the pathology lab at least once in a month. So if you get the said a result which is not more than 10% deviated, then you can use the glucometer for next 1 month or so. And again, there are various programs, especially for the pathology instrument, which can be run by a certain organization. And I think these are essential for both, for the patient's well-being and for the medical purpose also.
Actually, why I asked this question was there are so many diabetologists and endocrinologists with us at this moment. And this is one thing which I think so we are not practicing very frequently.
Exactly.
So it can be an insight for all of us that we should enroll this. Another thing is, this is my request that next time when you give a good presentation, please do share a protocol, like what protocol has to be followed, because that will give a good insight to all of us. So it was a wonderful.
Thank you.
I really enjoyed it.
Thank you, Dr. Ashish. I gave one slide where they have compiled the recommendation for the instrument check. So I can share that whole thing, the scoring system. So how frequently you should check your own instrument. So if you want, I'll share with you. Thank you very much. Thank you very much.
Thank you. Thank
you. We will go to the next session. It is on artificial pancreas by Dr. Amit De from Kolkata. And Dr. Amit De is a consultant physician, diabetologist in Apollo Sugar Clinic, and he is a winner of several awards and is actively involved in research in related to diabetes, and he has participated as a speaker in various national and international conferences. An update topic that is artificial pancreas. Over to you, Dr. Amit De.
Thank you very much, Dr. Raj, for the kind introduction at the outset. Many congratulations to our very dear Dr. Arvinda for conducting this wonderful scientific session, and thank you for giving me a topic, giving me this topic to speak on. So allow me to share my screen. I hope my screen is visible.
Yeah, it's visible and you are audible.
Thank you. So good afternoon, everyone. And I will be taking you over the next 10-15 minutes on something which is very new to us, but it's evolving every day. And so we must keep ourselves updated. And we are going to talk about closed loop systems, automated insulin delivery system, and that is artificial pancreas. But before I take you to what artificial pancreas is, let us try and understand what artificial intelligence is. Dr. Sachin gave a wonderful deliberation about precision medicine. So AI is the ability of the computers to do things that would require intelligence if done by humans. That's how simple it is. It means understanding, learning, and then reasoning to make decisions to solve the problem. So AI emulates these aspects of human intelligence by means of a number of tools. In diabetes care, there are various algorithms which are used. One such is the expert in medicine. So the system with the ability to capture the expert knowledge, facts, and reasoning techniques to help care providers in routine work. And the most common used expert system in medicine is the RBR, the rule-based reasoning algorithm, the case-based reasoning algorithm, and fuzzy logic algorithm. Why I'm mentioning about these algorithms here is because this is where we will find importance in the algorithms of the control algorithms of the insulin pump. So in the insulin pump, these three algorithms are used in the following way. You can see here the RBR and the CBR is used in the insulin dose recommendation and the bolus calculators, whereas fuzzy logic is used to detect the blood glucose pattern in the pump users. Let us try and understand what automated insulin delivery means. So this you can see is a subcutaneous continuous glucose monitor, which is the rectangle on the abdomen. It transmits the interstitial glucose level to the handheld controller, and that hosts a control algorithm and the user interface. So this insulin pump delivers the subcutaneous rapid acting insulin analog and insulin delivery is adjusted in real time by the control algorithm. This entire communication between the system components is wireless. In these control algorithms, you find the utility of a closed loop system, which leads to direct insulin delivery in response to the sensor glucose levels. And they use few algorithms models like the model predictive control algorithm, the proportional integral derivative controllers, and the fuzzy logic control approach, which I just mentioned earlier. If I give you an overview of how the insulin pump has evolved, it has been a fascinating journey, the evolution of insulin pump. And it's nothing new. It started since the 1950s and the 1960s. We had initially the insulin pump, then came the insulin pump with the CGM, and of course now we have the hybrid loop insulin pump. This is the evolution of the insulin pump right since the discovery of insulin. I think the year 1960s were very important, where the invention of the first insulin pump was done. And that evolution continued through the years, where in the 2000 we saw the emergence of the sensor augmented pump, which was the next step in the insulin pump. And then there became, in the year 2010 onwards, there became a revolution. The revolution of do-it-yourself artificial pancreas. And they called it the hashtag We Are Not Waiting movement, which was launched in 2013. Parallelly, Medtronic and the other companies kept on evolving their insulin pumps into the first closed-loop insulin system in 2015, which was MiniMed 640G, and followed by, of course, the 670 and the 780G, which is now available in our country. So this has been a fascinating evolution, and how the insulin pumps has developed over the years. The first insulin pump, we should never forget our history. The first insulin pump was developed in 1963 by Arnold Kadish, and it delivered glucagon and insulin and was about the size of an adult backpack. That's where it all started. Then came the biostarter, and that was in 1974. It was developed by Dr. Ernst Friedrich, and an early prototype of the artificial beta cell system was this biostarter bedside system using intravenous route for insulin and glucose delivery and continuous flow blood glucose sampling. The goal was to maintain blood glucose level at a predefined value. The first Medtronic pump was launched in 1983, and that was named as MiniMed 502. Same year, they brought out the 502A and was considered a technological breakthrough in size and programmability. So that is the first Medtronic MiniMed pump that came into existence in the year 1983. And since then, it has been a growing journey. We had the sensor augmented pumps, and then we had the SmartGuard suspends on low pump. Then that was evolved into the suspend before low pump. And of course, going ahead, we had the SmartGuard Automate, which adjusts for both the hypoglycemia and the hyperglycemia. It adjusts the basal rate. So that is the 670G. And going ahead, we now have the 780G, which not only adjusts the basal based on the highs and the lows, but also adds to a corrected bolus if necessary based on the algorithm findings. Now, the JDRF had classified the stages of artificial pancreas device system into 6 stages, and this is very, very important. The first generation had the first 3 stages. Of course, we spoke about the initial pumps, which had the very low glucose insulin pump. So basically, the pump would shut off when the user not responding to low glucose alarm. So that was that. When the glucose level falls, the pump would shut off. The next generation, in the next stage, it came the hypoglycemia minimizer pump, which could predict hypoglycemia, and that caused the alarm to cause stoppage in the insulin delivery below the low threshold. That was 640G. Following that development, there was also the advancement into the third stage, where there was the hypoglycemia as well as hyperglycemia minimizer. So that is how it evolved. And finally, we went into the second generation of the pumps, wherein we had the automated basal and hybrid closed loop system, and the closed loop at all times with mealtime manual assisted bolusing. That was the 670G, and the 780G was based on the algorithm. A certain bolus dose calculations can be done and that can be administered. Going ahead, we'll definitely have the fully automated closed loop. So wherein the pump will be able to not just adjust the basal based on the highs and the lows, but also every bolus based on corrected values. So the question of carb counting will be completely gone. And then comes the bionic pancreas in its true sense, which is the work is underway, and I will show you later, the third generation pump, which will be the fully automated multi-hormonal or bihormonal closed loop pump. So this is what the Medtronic's MiniMed 670G looks like. These are the parts of it. You can see the contour, the CareLink system, which gives the data interpretation. There is the Guardian sensor, and of course the SATA. So this is how the modern pumps, they look like. And as I had said earlier, this was the standard pump therapy, which was the manual mode. So it's suspended on low and it's suspended before low. It had to be set. And then, of course, came the auto mode. This is the hybrid closed loop. So it regulates the basal delivery through the algorithm doses every 5 minutes, and patient boluses for the meals and accepts for correction. Then finally, last year we had a wonderful introduction of the MiniMed 780G, and 780G automatically adjusts the basal insulin rates every 5 minutes and supports the selection of a lower glucose target than the 670G. The system will also have fewer alarms and be easier to use. It will be more user-friendly because the goal is to keep the time in range more than 80% using the 780G model. The pump is also Bluetooth enabled, hence it easily connects with the smartphone. And I'll quickly show you how the two pumps are different from each other. So you can see here the 670G, the algorithm does not use manual set basal rates. So changing the basal rates will not impact the auto mode. So after 48 hours of data collection, the algorithm will automatically calculate the total daily dose, and thereby it will set the basal rate with auto adjustment corrections. So it prevents the lows with the basal, and it also prevents the high with the basal, because the algorithm has a prediction based on which it can stop or it can increase the dose of the basal insulin. Now in the 780G, everything is just the same, but you can see here right at the end that it prevents the highs with auto correction. And also if the auto basal, it has maximal delivery and above 6.7 millimoles per liter is the dose, then auto correction is applied if required after active insulin calculation. So that is the advancement that had gone into 780G beyond the 670G. So this has been the evolution of the Medtronic pumps, and we always talk about the Medtronic pumps in our country because that is the commercially available pump that we have. But just after this, I'll show you there are many more pumps which are in under process. They are under studies, and they are soon going to be available worldwide. And of course, they are available worldwide. They'll soon be available in our country as well. So the Medtronic pumps had a wonderful journey from the 1990s. As we said, they started with the 502 and over the evolution into the 2020, wherein brought in the 780G system. And finally, they are looking at the personalized closed loop, which will be AI and machine learning driven, individualized, precision medicine directed closed loop system for the patient. Now let's look at the other types of the artificial pancreas that we have at hand. And one such is the islet bionic pancreas. And this, they are trying to bring in its true sense, a bihormonal pancreas, and this is what it looks like. They have the insulin cartridge, the infusion set, connected via Bluetooth to the smart devices, and they use the Dexcom G6 sensors. Now this islet bionic pancreas, the algorithm initialization with only the patient's weight autonomously adapts to the individual's insulin needs, and it eliminates the quantitative carbohydrate counting. So it also eliminates the need of carb counting. They have the insulin-only algorithm. They have studies on that. They're also doing a clinical trial on that. And they're also working on the bihormonal insulin and glucagon configuration. This I'm talking about is the Gen 3 islet. So this was one of their study, the individualized response of automated glycemic control with the islet bionic pancreas in the insulin-only versus the bihormonal configuration with the stable glucagon analog, dasiglucagon. And this is what this showed, that in the bihormonal group, There was better improvement in the time in range. There was improvement in the blood glucose values with significant statistical numbers coming out. So the future directions for islet bionic pancreas is the next, which is the Gen 4 islet bionic pancreas. And of course, they are doing a pivotal trial, which is, you can see here, they have submitted in the clinicaltrials.gov. Their studies have probably been completed, but the results are yet to be updated on the website since I last checked last night. And they are doing a pivotal trial on the insulin-only bionic pancreas. And very soon they will also be bringing out a trial on the bihormonal, closed loop system. There is also other type of pumps, and we call these the patch pumps. And one such is the DiaBloop's automated insulin delivery system, which includes the Kaleido insulin pump and Android controller, and also the Dexcom C6 CGM. It is the second hybrid loop, closed loop approved in Europe for adults with type 2, type 1 diabetes. What it does is that every 5 minutes, the glucose measurement is transmitted via the Bluetooth technology to the handset. The DPLG-1 artificial intelligence analyzes this data in real time while considering the patient's physiology, their history, their data entries in terms of meals and exercise to determine the correct dose of the insulin to administer. And recently, they have also partnered with AccuCheck Roche. So they're trying to bring in a collaborative effect, and hopefully we will be able to have this in our country as well. This is something that we have almost all of us have heard of, the Omnipod. Omnipod is also an interesting insulin patch. So it provides up to 3 days of non-stop insulin delivery. So this tubeless, no daily injections. It consists of this tubeless dashboard for insulin delivery system and a smartphone-like touchscreen, which is Bluetooth-enabled controller. Although these are not an ideal closed-loop system, but these are in the evolution of making into a more, patient-friendly and painless journey of insulin or pump users or insulin patch users. There's another company called the Bigfoot. So Bigfoot is working on the Bigfoot autonomy, so which is based on the snap pump technology and design. So now they're trying to develop a screenless pump device. A smartphone mobile app will be the main user interface. And of course, patch pump, we have done a study which shows the patch pump is very user-friendly, and of course, it will be more preferred rather than the conventional pumps which we have. So user will enter their carb counts for meals on the phone, which will then recommend a dose and allow delivery without having to touch the pump at all. This we hope will be available in our country. This is AccuCheck Solo Micro Pump. It's a small tubeless insulin delivery system that allows the users to take bolus doses directly from the pump or from the diabetes manager handset. And it also enables the users to detach and reattach the pump without wasting any insulin, which is most of the time disadvantages in cases of patch pumps. Now, there was an evolution, as I said, since 2010, and that is the do-it-yourself pancreas. So what is this? These are the components of a DIY open apps. It consists of the glucose monitor, the Raspberry Pi, which is the controller, the battery, the Kerling USB stick, and the insulin pump, which has been hacked into by normal people, normal parents of diabetes children, and normal engineers who were interested to work on a more user-friendly, rather a more cheaper version of the commercial pump. There are various types of the DIY pumps, and one is the open apps, which is a safe and powerful system that intends to adjust the insulin doses to maintain the blood glucose level in the recommended range. And the first open APS was developed by Dana Lewis with his team. Then there is also the loop type of the algorithm, which runs on the iOS. So the Apple iPhone receives the CGM data and communicates with the insulin pump via the Bluetooth. The first loop was developed by Nate Ruckle and a DDAD. DDAD are basically patients of diabetes children, parents of diabetes children. So DDAD peach pump in 2016. And the third type of APS which is available is the Android APS, which is an open source APS which runs on the Google Android smartphones, which will again receive the data from the CGM via the Bluetooth and communicates to the insulin pump. It was developed in Europe by Milos Kozak and Adrian Tepe in 2017. So one such is the open APS. This is what it looks like, and it was these are the slides I've taken from Dana Lewis's presentation himself. And it's a fantastic innovation that them, although they would have limitations in terms of the algorithm, in terms of the safety. It's not regulated, as they always give a disclaimer that it's not regulated, but it's a fantastic revolution that has come across in the open APS. So who's regulating these activities? The users are. Most users test their own medical devices, and their question answer approaches are even stronger when utilizing open source tools made with, by, and for the community. But off-label use, so that it's not regulated. Well, the response was so strong that JDRF themselves went on to create an open protocol system, and that is now a fantastic resource to support these open APS system, wherein there can be their open APS system can be all connected to the cloud, and they can have the CGM, their mobile device, and the pump integrated, and JDRF is working on this. So there are some amazing stories in the do-it-yourself loop, and this is my second last slide. One is a computer scientist with type 1 diabetes, Ben West, spent 5 years of his spare time decrypting the radio link between his Medtronic pump and the corresponding USB stick. And the other, John Kostick, together with his wife and the other parents, had to view the CGM values of their children from a distance on a specially set up website on a PC, laptop, or tablet, or on a smartphone or on a smartwatch, and to intervene if necessary. And they later came to be known as a very famous in the DIY group is Night Scout, with the logo of the watchful owl. Today, one can probably control his own pump via USB stick in such a way that the programmed basal rate is optimized with the rising or falling of the glucose values for a maximum period of 30 minutes. As a result, the values are more frequently within the self-defined target range. So it's more of a user-generated, customized response that they get. This was part of the first DIY closed-loop project, Open APS. So nothing is impossible, and start by doing what's necessary, then do what's possible, and suddenly you will be seeing that you're doing the impossible. And that was the message that was carried forward by the DIY individuals. Thank you very much, and I wish all of you Shubha Mahalaya. Today's Mahalaya, which marks the arrival of Ma Durga. So thank you very much for your patient hearing.
Thank you, Dr. Amit. It was a very good presentation and excellently taken message. Now, due to paucity of time, we will straight away end the discussion so that the next session can go on. And thank you, Dr. Aravinda.
On behalf of Dr. Arvind Diabetes Center and ADC International Virtual Diabetes Summit, I wholeheartedly thank Dr. Sumesh Raj, Dr. Kandula Sai, Dr. Sachin Mishra, Dr. Parimal Swami, Dr. Amit De for their wonderful deliberation and active participation. Thank you so much for your valuable time. Thank you.
Thank you.
Over to Dr. Shweta.
Yes, sir. Thank you, sir. Thank you all the three speakers. It was a wonderful session. Let's move on to our next session. I would like to introduce the chairpersons, Dr. Sadashiva Rao Y, Senior Wound Diabetologist of Andhra Pradesh, Managing Director of Elamanchi Hospitals and Research Center, Private Limited. Welcome you, sir. And I would like to introduce the other great person, Dr. Ajay Kumar Gupta, MBBS MD Medicine, FIACM Scholar, American Diabetes Association, MSCE, Co-Founder and Medical Director, Lotus Diabetes Private Limited. Welcome you, sir. Welcome to the famous diabetologist. So over to you.
Yeah, good afternoon, and thank you very much, Arvinda and his team, for giving me this opportunity. And I would like to welcome the next speaker without wasting any time, Dr. Dhruvi Hasnani, who is well known. She has done her MD, Fellow of the Royal College of Physicians from UK, and she has done her PG Diploma of Diabetes from the RSSDI, ISPAD Fellow, Pediatric Diabetes Fellowship is there. She is a consultant diabetologist at Rudraksha Institute of Medical Sciences, HOD of Clinical Research, RIMS Ahmedabad, Treasurer of RSDI Gujarat Chapter, winner of Torrent Young Scholar Award for Diabetes, faculty for ND EP program, and speaker at numerous international national conferences, and has to her credit 10 international and 25 national publications. She's a reviewer for Pediatric Diabetology Journal and Journal of Diabetology, and she's the investigator for clinical trials. Over to Dr. Dhruvi.
Good afternoon, respected chairpersons. Thank you, Rao sir. And it's always, a little nervous to talk in front of you. Congratulations to the team of ADC for such a wonderful program and successful second day as well. And let me start by sharing my screen. I think I'm the opening speaker for this session for diabetes in young. And I think I'm going to start by talking about the dilemmas, the diagnostic dilemmas that come along with that. All of us present here, we have all met from time to time to talk about how we can better the treatment, how we can better the management for diabetes in the young. And I have more than often talked upon this same topic of diabetes in young. And a lot of us have discussed what would you describe as the age young. So now, during Diacon, when we were discussing along with a couple of senior physicians in the room in the conference hall, and they were like, anybody below your age group is young. And then I was like, I am, only in my early 30s. And he's like, no, then everybody below my age group, which is below 70, is young. So for this particular talk, I think we are going to concentrate on the young adults below the age of 30 and also the teenagers and the pediatric age category. I have no financial disclosures to make, but we have to talk about how worrisome is this aspect when we talk about diabetes in adolescents, diabetes in the young people. And it is a challenge to both the patient as well as to the doctor. Of course, there is an increase in the prevalence of diabetes. And after the global pandemic, we've seen that there are young adults in their 15 teens, and even as young as, say, pre-pubertal time, we have seen them with some sort of insulin resistance signs and symptoms that are going to make us, point out them having insulin resistance or pre-diabetes. This development of diabetes in the young ages is going to, of course, have several repercussions in the coming future. And we generally say the earlier the onset of diabetes, the earlier is the onset of the complications. And this is what is going to translate into very significant morbidity and mortality, which is going to be a loss, not just to the economy, but also to the society as a whole. So it is pertinent that whenever we get the platform, we talk about the appropriate diagnosis, the appropriate management, and how better can we do as physicians, as primary healthcare professionals, and how can we help and support this younger population who are going to be the future of the country. Correct diagnosis, motivation of the patients for therapy for a long term, since, time and again, we have discussed that it is not possible to reverse every kind of diabetes that we are dealing with, especially when it comes to adolescents. We require to talk about regular follow-up, regular compliance and adherence, which is one of the biggest challenges that all of us have faced. Now the scenario is changing. Beforehand, when we would talk about this topic of diabetes in young, our majority of the focus would lie on only type 1 diabetes. Dr. Rao, Dr. Arvinda, Dr. Chowda, and myself, all of us have, concentrated on our talk generally on type 1 diabetes when we talk about diabetes in young. And to this day, when we have to differentiate, or when a teenager or say a young fellow, a young adult in his early 20s or late 20s comes to us, the first differential diagnosis of that hyperglycemic episode has to be type 1 diabetes. But now we also have to think about type 2. In a country like India, we have to also talk about malnutrition modulated diabetes mellitus. We have to think of FCPD when we talk about the forms of diabetes in young in India. We have to think about LADA. We also have to talk about monogenic diabetes, which one of my esteemed colleagues is going to talk in the next talk. There's this beautiful algorithm, which, it's quite easy to understand, quite easy to follow also for differential diagnosis of diabetes in the young. Just find out, take a very proper family history of diabetes and then try to understand and go by the arrows. If the family history is negative and there is ketonuria or ketosis and the C-peptide is absent, it could still be type 1 diabetes. If the family history is negative, there is no ketonuria, there is some sort of C-peptide present, please try and get an abdominal X-ray done with or without symptoms, with and without pain as well. There could be some pancreatic calculi present. There could be chances of FCPD, especially in the southern part of India. Also, never forget to rule out other endocrinopathies, genetic defects, or genetic disorders that are related with diabetes. Again, if the family history is positive, it is a totally different scenario. You have to find out if there is a presence of 3-generation positive family history or not. If yes, see if the C-peptide levels are good or not. If the person or the young adult is responding to sulfonylurea or not, there are quite some chances. The probability of monogenic diabetes is quite good enough. But without doing a genetic analysis, it is not possible to label this young adult to have MODY or any other form of monogenic diabetes. Now, if there is no positive family history of, say, more than one generation, there is good amount of C-peptide. There is, some signs of insulin resistance, acanthosis, or say skin tags, or say some buffalo hump, recently having obesity. This could be an early onset of type 2 diabetes for this young adult. So there is a very nice position statement presented by the ADA, and this is from 2018, which talks about different characteristics of the prevalent forms of primary diabetes in the children and the adolescent, the type 1 diabetes, type 2 diabetes, MODY, as well as the atypical forms of diabetes. And even though 85% prevalence is still type 1, do not forget to have a differential diagnosis with early onset type 2 as well as MODY or any other genetic format. Now, what are the dilemmas? That's the major point that we have to focus on. We are still on the road to awareness. We've not reached that destiny wherein the advocacy of diabetes in these young adults has reached to a level that we say, okay, it's enough. No, it's not enough. We have to talk about this at every opportunity possible. We just yesterday had the opportunity to talk at a school where we were talking about pediatric obesity leading to early onset of type 2 diabetes in the adolescents and in the teenagers. Self-monitoring, all of these kids, all of these teenagers, all of these young adults who are also dealing with a lot of other issues in their lives have to deal with a chronic condition along with that. And, this will lead to something which is known as diabetes distress and leading to a poor blood glucose control, which Dr. Chawda presented his presentation at ADC day 1 yesterday. The patients also struggle to remain compliant to the insulin and medications and have so much of psychological and mental health issues at the time when they have to focus on their careers, make a life, explore the world, try and make their own footing into the world. They have to deal with being compliant with the insulin and the medications as well. All of these insulin and medications are not adhered to properly if the person is not compliant to. Again, we don't call them patients, we call them persons with diabetes or people with diabetes or young adults with diabetes. And language matters is what the keynote address yesterday by Dr. Shashank Joshi said. And we have to make sure that these dilemmas are addressed well. An important thing that the ADC talked about yesterday in one of the sessions was hypoglycemia. And both the patient as well as, let's not call them patients, the people as well as the physicians are concerned about the risk of hypoglycemia in all of these young adults who are working day in and day out. So there is this beautiful testing protocol that you can, follow for any young adult coming to your OPD. If the child is symptomatic, please still make sure that you are BMI done, you're checking the height, the weight, the anthropometric data, even the waist circumference. Try to look at a full detailed family history. Talk about, different generations. At what age did the parents get? At what age did the grandparents had the onset of diabetes? If there are any signs of insulin resistance or not, if there are any other associated conditions or not, if the mother had any history of diabetes or GDM or not. Now, in all of this, we do sometimes forget. We do an fasting TPG, we do an HbA1c, we also do the CGMS, but sometimes we forget the simple and the normal lipid panel. We need to assess the albumin excretion. We need to do a dilated eye exam for each and every type of diabetes and a simple blood pressure monitoring as well. In spite of the child being, in the teens, in spite of the young adults not complaining of any symptoms of hypertension, please always get a blood pressure measurement done. Also check for hemoglobinopathies. In India, check for sickle cell anemia or thalassemia if it is prevalent in your geography. Now, this is a picture of a 14-year-old boy. This has been taken from Dr. Unikrishnan sir's paper with type 2 diabetes. The laboratory investigations have, pointed out that this child is having a young or an early onset of type 2 diabetes and should not be, just ruled out as having type 1. Now let's come to an important thing about monogenic. I'm not going to go deeper into it since the next speaker is also going to talk about it. But monogenic diabetes is still responsible for almost 1 to 3% of all young onset diabetes. And there are multiple genes that are involved and that can cause one or both of the main phenotypes, be it the congenital neonatal diabetes or the moody majority onset diabetes of the young. And the timely and accurate genetic diagnosis will provide us with an opportunity to target therapy to the underlying gene, which is causing this moody, and refine our management, identify even the other affected or at-risk relatives. So I'm going to skip that and show you that there are up till now identified almost 18 gene panel, which is, identifying for the moody gene analysis. Now, there's of course neonatal diabetes, which is diagnosed in the first 6 months of life. It could be both transient as well as permanent form, and it is not typical of autoimmune type 1 diabetes. And even the permanent form can be well managed in some of the cases with sulfonylurea. This is another case of fibrocalculous pancreatic diabetes, and it is quite prevalent in the southern part of India, in the coastal part of India. And this is an abdominal X-ray of the patient with FCPD showing pancreatic calculi. And sometimes resolving this can help resolve the hyperglycemia of that young adult. Now, malnutrition modulated diabetes, we're in a country where we are dealing with both, malnutrition as well as overnutrition causing the obesity related diabetes and malnutrition causing malnutrition modulated diabetes. Most of the time, these young adults coming to us are from a very, very underprivileged background. And this is because they have a history of inadequate nutrition, not just for themselves, but also during the time when they were conceived. Their mother also had a history of, inadequate nutrition. Their BMIs are always on the lower side. They have no ketonuria, no ketosis. They are always having a very severe hyperglycemic, episodes, and they have a high insulin requirement in spite of having relative insulin resistance. How different it is, very quickly, the malnutrition modulated diabetes versus the type 1, the onset is quite gradual. When we talk about the malnutrition modulated diabetes mellitus, C-peptide is a little bit good and better than type 1. Ketosis is never there. There is insulin resistance, but there is severe hyperglycemia without any ketosis. I quickly come to LADA. LADA is the latent autoimmune diabetes in adults, and it is an autoimmune positive type 2 diabetes, also many a times often termed as 1.5 diabetes. And these are the adults that gradually, say within a period of 3 to 6 months, are going to become insulin dependent, and they have to take insulin for a longer period of time. But these are also the adults who respond quite well in the initial phase. And, the doctors might feel, or the physician might feel, that this is something else other than LADA, and a differentiation or a diagnosis with LADA should not be ruled out. Get a C-peptide done, get repeated at 6 months, and see how the person is responding to the medications that we are prescribing. This is the UK-PDS trial subgroup analysis, and even at that point of time, Paul Zimmet tried to say that there were 12% of LADA patients in the trial of UK-PDS. Paul Zimmet was the person who actually coined the term LADA, latent autoimmune diabetes of adults. Now, in the long term, what are the implications of these types of diabetes in the youth? And simplifyingly, this slide, we have to understand that earlier the onset of any kind of diabetes, earlier is the onset of complications in all of these young adults. So what should we not forget? We have to screen all of these adults or young adults for microvascular complications, be it nephropathy, retinopathy, or neuropathy. And there's a beautiful Today study that is showing us that all of these adolescents and young adults this was the Today study, which was a follow-up study of, say, 26 plus or minus 2.8 years, and at least there was one complication in 60% of the participants, and two complications occurred in 28% of the participants. Now, say, for example, a 15-year-old teenager getting diabetes and you plus 26 years, still he is in a younger age category of, say, only in his early 40s. This person is still quite healthy, heartily, and he has to live for more than 20, 30 years more. So all of these, young adults or the participants in the Today study who had onset of type 2 diabetes in the youth had higher risk of complications, microvascular complication as well as macrovascular complications. So these participants in the Today study had a median A1C which increased over the time, and the percentage with the A1C less than 6% had lesser complication in comparison to those with higher A1C. So which means we have to be a little bit stringent, a little bit, very strict in achieving their HbA1c target. Serious cardiovascular events in their mid-20s has also been observed in all of these young people with early onset of diabetes. And researcher of the study says that the microvascular events were shocking, noting that although the numbers are small, the people in the mid-20s, they should be zero, and there shouldn't be any cardiovascular event. And we have to, in fact, try to screen them early for early diagnosis and early management. Don't treat them lightly just because they are kids. All of these kids have, higher risk of having all these macrovascular complications. Contrary to the inclination of being gentle in treating them because they are kids, the data that is available suggests that we can't let this initial period, we have to give them the legacy effect. We have to give them the, window period wherein the earlier and the stronger intervention will give them a better metabolic memory in the later years. So suboptimal response to currently approved medical therapies. Of course, we all understand that we cannot give all molecules to everybody, but the recent studies are also approving the use of liraglutide in obese, early age, early onset of type 2 diabetes in the younger adults. The use of SGLT2s is also a little dicey, but priorly, the European Association said that you could use dapagliflozin. After, say, a couple of years, they said you cannot use dapagliflozin. And the movement still goes on and on, but be individualistic, give a customized approach to the person in any age category, be it a teenager, be it in the early 20s or the late 20s. Try and see what sort of a diabetes there is and have a proper differential diagnosis. The NICE and the ISPAT guidelines are talking about complications of the youth onset of type 2 diabetes, and there is a summary of screening: screen for hypertension, screen for dyslipidemia, screen for retinopathy, screen for nephropathy, NFALD, PCOS, as well as for obstructive sleep apnea. The clinical profile of diabetes in the young seen between 1992 and 2009 at a specialist diabetes care in South India has shown that almost 48% had type 2, 43 had type 1, 4.5 resulted into GDM, 4.4 had other forms of diabetes, including FCPD and genetic syndrome. Even our ICMR diabetes of young registry showed that both type 1 as well as type 2 had, significant proportion. Even if type 1 was 63 and type 2 25, type 2 being 25% is the 1/4 of the population having type 2 diabetes. Now, coming to the pearls of practice, I'll quickly summarize everything. Patients who are adhering to the key aspects of the treatment regimen and getting a better glycemic control will stay away from any sorts of complications in the future as well. The use of technology, like Dr. Amit Dey suggested, like Dr. Parimal Swami all talked about in the previous session, is going to help deliver a better behavioral therapy. Telemedicine is, of course, available. A structured transition from the adolescent to an adult care is important for the future success of controlling diabetes. Now, we all understand that diabetes is one of the larger pandemic, that is one of the most common endocrine disorders in children and adolescents across the world. Several unique challenges are being presented, but what we have to understand is early screening, early diagnosing, accurate and appropriate management with optimal glycemic control and risk factor modulation to keep this young adults complication free and give them a happy and a good quality of life in spite of diabetes. The answer still remains education, education, and education. And any elephant, there's always an elephant in the room when we talk about diabetes in the young, and proper diagnosis is a must. So with that, I'm going to thank you all. Thank you, Dr. Arvinda Jagdisha, for such a wonderful conference and for the opportunity to talk on the platform. Thank you to the chairpersons.
Thank you, Dr. Dhruvi, and thank you for enlightening us upon this diabetes in young. So means you are very right. Nowadays we are getting young age diabetes means 14 to 19 years. So this will be very helpful for our practice also then. And now I invite the second speaker to speak upon monogenic diabetes and neonatal diabetes. Dr. Mohsin Aslam is from Hyderabad and he is a consultant physician and clinical endocrinologist at Asian Institute. And he has got many achievements. He is an alumni of Academy of Young Leaders and University of Melbourne. Many presentations, 25 presentations in the local CME national and international conferences, and he has more than 20 publications in the peer-reviewed national and international chapters. Over to you, Dr. Mohsin.
Good afternoon, all, and thank you, Dr. Ajay sir, for your introduction. I'll just share my slide. So I'll start with thanking my friend Dr. Arvinda for inviting me to give a lecture on monogenic and neonatal diabetes. It is, we all know it is important to distinguish neonatal diabetes from other causes of hyperglycemia in newborn, as neonatal diabetes mellitus is more likely due to be some underlying monogenic defect. So early diagnosis and urgent genetic testing helps us in understanding the clinical course, progression of the disease, and also guiding appropriate and affordable treatment to the patient. So monogenic diabetes describes genetic forms of diabetes that are caused by mutations occurring in a single gene, and they follow a classical Mendelian law of inheritance. And it is also important to know that these forms are separate from and do not overlap with the more common polygenic diabetes. And patients with monogenic diabetes are typically characterized by young age of onset, they are non-obese, absence of islet autoantibodies, they have detectable C-peptide levels and absence of insulin dependency. They have a history of a parent with monogenic diabetes and additional non-diabetic clinical features if the patient has diabetes as a part of genetic syndrome. And monogenic diabetes is broadly classified into three groups: neonatal diabetes mellitus, maturity onset diabetes of the young, and syndromic monogenic diabetes. This neonatal diabetes mellitus is caused by mutations in one of the 38 genes, and they describe patients with diagnosis before the age of 6 months. And MODY is caused by mutations in one of the 11 different genes. This describes patients with isolated non-syndromic diabetes that is dominantly inherited and diagnosed outside of the neonatal period. Syndromic monogenic diabetes is caused by mutations in one of the 18 different genes and describes patients where diabetes occurs as a part of monogenic syndrome with characteristic extrapancreatic features. And these patients may be diagnosed within or outside of the neonatal period. So this is a table which shows monogenic causes of neonatal diabetes, and there are some important mutations, which we'll be discussing in the coming slides. Neonatal diabetes mellitus is rare with a prevalence of approximately 1 in 1 lakh. And in pediatric clinics, the prevalence is 1 to 3% of all diabetic patients. And majority of the patients will have a monogenic etiology. Again, prevalence of different subtypes varies between non-consanguineous and consanguineous populations. So mutations in KCNJ11 and ABCC8, they are the most common mutations in neonatal diabetes. They are dominantly inherited activating mutations in the ATP-sensitive potassium channels and account for nearly half of the neonatal diabetes patients in non-consanguineous families. Again, they are the second most common cause of transient neonatal diabetes mellitus. They are highly sensitive to glucose-lowering effect of sulfonylureas, and almost 90% of the patients can be transferred from insulin to sulfonylureas with improving glycemic control. The people here experience fewer hypoglycemic episodes, are able to relax their glucose testing regimens, and adopt more liberal diet and exercise regimens. Mechanism of action: mutations in either of the genes cause the potassium ATP channels to remain inappropriately open even in the presence of hyperglycemia. So without channel closure, the cell membrane is not able to depolarize effectively, and thus insulin cannot be released from the beta cells. They are usually present before the 6 months of age, but diagnosis can be present after 6 months also, and with the decay frequency at diagnosis varying between 30 to 75%. Intrauterine growth restriction, small for gestational age, and low birth weight are the common findings in these patients. Then, as these potassium ATP channels are also present in the brain, so mutations in the KCNJ11 can present with increased frequency of attention deficit hyperactivity disorders, sleep disruptions, developmental delays, seizures. And these symptoms may vary from mild disorders to more severe form with severe delays and seizures, that is Dent syndrome. Coming to treatment, while many patients are managed with insulin during the initial hospitalizations, majority of the patients can be treated later on with sulfonylureas, often in high doses. The sulfonylureas act on this potassium ATP channel to promote the closure, allowing for the insulin to be released from the beta cells. And this therapy may also improve neurological function in addition to improving glycemic control. So the effect of sulfonylureas is maintained for at least 10 years, and with more than 90% remaining on oral agent alone with no deterioration in HbA1c. So the more early we detect this genetic disorder and early we start sulfonylureas, the better is the outcome. And also the treatment in utero with glibenclamide has benefited both mother and neonatal offspring when prenatal testing has shown that the fetus has inherited a mutation from their affected mother. So now 6q24 related neonatal diabetes. So what you call the mutations in the 6q24 are the most common cause of transient neonatal diabetes mellitus. These disorders can occur through any of the 3 distinct mechanisms. The first one, most common being epigenetic, that is unilateral disomy of chromosome 6. Here, there are only 2 copies of chromosome 6q24, but both the copies are from the father. The second one is the duplication of the paternal 6q24 allele. Here, there are 3 copies, and the 2 are from the father and 1 from the mother. The third one is loss of maternal methylation, in which there is a defect in the, here you can see there's a defect in the methylation, defect silencing of the maternal allele, which can be recessively inherited. So they're usually present in the first few days or few weeks of life, usually without decay. The characteristic feature is the patient, children undergo remission at the age of 3 months and to relapse later in the teenage or young adult life. Severe intrauterine growth restriction, macroglossia, and umbilical hernia are common associated features. Again, treatment, this patient needs subcutaneous insulin in the neonatal period, but in case the disease relapse, they may respond to OHS or insulin. If they need insulin, the dose tends to be lesser than those required in type 1 diabetes. So insulin gene, the alteration in the insulin gene is again second most common cause of permanent neonatal diabetes. Mutations leads to misfolding of the insulin protein, and these proteins accumulate in various subcellular compartment and increase endoplasmic reticular stress and subsequent beta cell, resulting in the development of diabetes. Again, they appear similar to early onset type 1 diabetes. Most cases are diagnosed below 6 months of age, and 30% nearly present with DKA. Treatment is insulin therapy. So early and aggressive treatment with insulin may help to preserve some beta cell function. These mutations in EI, F2AK3 and PTFM, they are very rare. They are recessively inherited non-potassium ATA subsites, most common in some consanguineous populations, and more challenging to manage because diabetes is severe and does not respond to sulfonylureas. Again, mutations in GATA6 and PDX1, again rare. Mutations results in varying degree of pancreatic hypoplasia, including complete agenesis. Treatment with enzyme replacement therapy and insulin therapy helps in appropriate growth and glycemic control. FOXP3 mutations, again, this is very rare and results in autoimmune diabetes, monogenic autoimmune diabetes, part of IPEX syndrome, that is immune dysregulation, polyendocrinopathy, enteropathy, and X-linked syndrome. They are severe enough to cause death. Stem cell transplantation is often considered in these patients. GSK modi, this is something different. So heterologous loss of function in GCK is a more common cause of asymptomatic hyperglycemia in children and gestational diabetes in non-obese women. So GCK hyperglycemia, which is a subtype of MODY, is actually incorrectly labeled, since these individuals can be considered not to have diabetes, because here the beta cell defect is in glucose sensing and not in glucose regulation. So this patient usually maintain a higher set point of fasting sugars between 108 to 126, resulting in fasting hyperglycemia right from the birth, and their HbA1c target ranges in between 5.8 to 7.6%. And even with the treatment, there's no change in the HbA1c levels. So lowering GCK hyperglycemia is counter-regulated by the beta cell. So the treatment has no effect on lowering HbA1c. Several cross-sectional studies have shown that there is no difference between HbA1c in patients who were treated with OHA or insulin and those who are not treated. And even in the longitudinal studies have shown that there was no change in HbA1c after stopping OHA or insulin. And in this patient, there is no increased risk of any micro and macrovascular complication, even in patients who had hyperglycemia for every 50 years of duration. So once the diagnosis of GCK hyperglycemia is confirmed, all treatments, monitoring and follow-up are unnecessary and can be stopped. So this mutation's status of the fetus determines the fetal birth weight, macrosomia risk, and high risk status for delivery. So if the fetus inherits these mutations from the mother, the raised glucose set point of the fetus matches that of the maternal hyperglycemia, resulting in the normal levels of fetal insulin secretion and normal birth weight. So these mothers can be discharged from the high-risk antenatal care without the need for insulin or regular fetal growth scans. So invasive prenatal scans are not advisable because of increasing risk of miscarriage. Non-invasive prenatal tests by analysis of cell-free fetal DNA present in the maternal blood sample, which uses a high-sensitive digital PCR assay and is 100% accurate. It is advisable to be performed in the second or early third trimester, as the DNA levels are more abundant in maternal circulation during this period. Coming to HNF-A, 1A and 4A MODY, here the insulin secretion defect results in diabetes that requires good glycemic control to prevent micro and macrovascular complications. The first line treatment is usually low dose of sulfonylurea, which results in greater than 4-fold reduction in fasting glucose compared to metformin. So use of sulfonylureas in pregnant women in this population. Glibenclamide can cross the placenta and increase the risk of macrosomia and neonatal hypoglycemia. So here the aim of the treatment is to achieve excellent glycemic control during the first trimester to reduce the embryopathy and miscarriage or fetal loss, and avoiding the use of glibenclamide in the second or third trimester to minimize the impact on fetal growth. So the first option is to use glibenclamide in the first trimester to achieve blood control, and then later on shift to insulin in the second trimester, but accepting the fact that the transfer during the second trimester might be difficult. The second option is to start the patient on insulin pre-conception, with accepting the fact that the sugar controls might not be as good in the first trimester compared to OHS. So now systematic strategies for diagnosing MODY. So changes in the clinical management as a result of genetic diagnosis, like once we made a diagnosis of MODY or neonatal diabetes, where sulfonylureas are more important and have a better control than insulin. These are the drivers for identifying MODY in children misdiagnosed with type 1 diabetes, and also to maximize the response for sulfonylurea treatment. So the difficulty here is that there is no single criteria that can identify the majority of the MODY cases, and nearly half of all patients do not meet the classical MODY diagnostic or test criteria. So there is a requirement for improved MODY diagnosis criteria. And MODY diagnosis success rates can be significantly improved using a probability calculator that can be used as a tool to select patients for genetic testing. A model had been developed in the Exeter University, but again, it has limitations that it is less accurate, validated only for wide population, and does not contain biomarkers such as C-peptide and islet autoantibodies. And testing for all three antibodies like GAD, insulin antibodies, and zinc transporter 8 is essential, and also measurement of C-peptide at diagnosis in children less than 9 months of age to rule out any polygenic or type 1 diabetes. So excluding patients with severe presentations or no parent history of diabetes risk missing cases where a diagnosis would have huge impact on patient's life, because there are certain patients where there will be new de novo mutations, and in certain recessive disorders, the patients might not manifest. So the high sensitive strategy is to perform antibody and C-peptide testing at diagnosis, and genetic testing in all the patients that are antibody negative and have C-peptide, which have C-peptide levels more than 200. So this is a summary of testing in the patients with diabetes diagnosed below 9 months. Genetic testing for all the neonatal diabetes genes by next generation sequencing. In case if it is negative, then it can be very early type 1 diabetes or undiscovered monogenic cause. Here consider polygenic risk scores or whole gene sequencing. If the diagnosis is made more than in a patient more than 6 months or less than 30 years, and there are features suggestive of monogenic syndrome, then perform genetic testing. And if the patient is insulin treated, measure C-peptide levels. If the C-peptide levels are undetectable, then it is type 1 diabetes. If the C-peptide levels are normal or high, normal or low normal, then look for antibodies. If the antibodies are positive, likely to be type 1 diabetes. In case of negative antibodies, there are two options: whether to a high sensitivity option, so that is to do all genetic testing by next generation sequencing, or only for if the patient meets a specific criteria like BMI less than 30, HbA1c of 7.5% at presentation, or patient affected with diabetes. So this is highly specific, but here the chances of missing a monogenic diabetes will be slightly higher. So improvement in genetic testing. Earlier, there was a Sanger sequencing analysis for a small number of common cause genes, where the specific gene was tested based on the clinical features. Again, there were chances of missing it on many diagnoses of MODY, but with now next generation sequencing technology that enables rapid and cost-effective testing of all monogenic diabetes in a single assay, the reliability of diagnosis becomes more. So now with the next generation sequencing testing is causing a paradigm shift in the monogenic diabetes diagnosis. And earlier, the technology, like earlier, based on the strict phenotypic type of monogenic diabetes, again waiting for the clinical features to develop, and then testing genetic test based on the clinical features, and then confirm the diagnosis, until then manage clinically. But now with the era of next generation sequencing, the only question is whether there are features of any polygenic diabetes. If no, then go for early non-selective genetic testing of all the genes, make a diagnosis of genetic diagnosis, then look for the prediction of the clinical features and manage based on the genetic diagnosis. To summarize, Monogenic diabetes can be diagnosed in the neonatal period, childhood, or adulthood. Patients may have diabetes in isolation or as a part of genetic syndrome. And monogenic diabetes is uncommon but correct diagnosis is essential for clinical management, particularly in predicting disease progression and enabling the testing of other affected family members. All patients with diabetes diagnosed under 6 months of age and those with additional features suggestive of monogenic syndrome should be offered genetic testing, and genetic testing strategies utilizing next generation sequencing technology to analyze all of the known monogenic diabetes genes has led to a paradigm shift whereby the diagnosis is made genetically rather than clinically, and has made the older test, that is testing a single gene based on clinical phenotype strategy, obsolete. Thank you.
Thank you, Dr. Mohsin. And any comments from sir?
Actually, Aslam, I should actually commend you for giving a very good topic, a very good lecture on a difficult topic of monogenic diabetes, and you made the subject look very easy. And I think all the people who have heard it, I think it won't be such difficult to diagnose it. So I agree with him. I think lack of time, we will go on to the next lecture, my co-chair, if with your permission.
Yes, sir, please. So the next lecture will be from Dr. Ashish Saxena from Ludhiana. And Dr. Ashish Kumar Saxena is a fellow of Indian Academy of Echocardiography, fellow of Indian Society of Hypertension and ISCM. He is a consultant diabetes and non-invasive cardiology. And he is working at Delta Heart Center, Ludhiana. And he'll be talking about the secondary diabetes. And he is a recipient of many awards, including the Governor Award and the Chief Minister Punjab Award. And also he has been awarded the Best Diabetologist Award by the Health Minister of Punjab. So Dr. Ashish, over to you, sir.
Yeah, thank you, Dr. Ajay. I'll be sharing my slides. I think so I'm visible and audible.
Yes, sir, very much audible, sir.
Yeah, thank you, Dr. Arvinda, for getting all the great pearls of diabetologies and endocrinologies on your field at ADC International Virtual Summit. And Dr. Mohsin has done a wonderful job, and also Dr. Dhruvi. It is really nice, and the topic which I'll be discussing today is another topic on diabetes, but it is secondary diabetes. And believe me, for the past few days since you have given me the topic, I am seeing quite a few patients of secondary diabetes. I don't know how. Very recently, one lady came with pain abdomen, and ultimately her blood sugars were high, and found out to have acute pancreatitis.
Hello.
Hello.
Sir, kindly put your slides in the slideshow section, sir. It is not coming as slideshow. Dr. Ashish?
Yeah, can you see it now?
No, sir, in the bottom, there is a slideshow option, sir.
Actually, I'm doing it. I'll just try it again.
Yes, sir.
Is my slides moving? Are they moving now?
No, sir.
So slides are moving, but not in the slideshow mode.
Sir, you come to the full screen mode in the slide.
I'll just come. I never have this problem, but I don't know what happened.
If you are using a Mac, then this problem is very frequent, sir.
Is it visible now?
No, sir.
Can you see my slides now?
No, sir.
Now you come to the full screen, sir, in the slides. In the bottom, there are views are there, grids.
Yeah,
Yeah, full screen grid.
Can you see it now?
No, anyway, you can, Dr. Ashish, you can move.
You can continue with the same mode, sir. You can
yeah,
continue
same
with
mode,
the
you
same
continue this, no problem.
Yes, sir,
Yes.
there's no problem.
Is my slides moving then in the same
Yeah,
mode?
it is moving. You can continue.
Next, you go to the next slide.
I tried it, but over here I'm having the full screen, but maybe something is wrong. I'm not able to get. Is my slides moving anyway, Arvinda?
Second slide, you go to the next slide.
Yeah, I am going to my third, fourth slide. Okay,
No,
what
it's
I'll
not
do is
moving.
I'll share again. Wait,
Network
I'll share.
issue, sir. Network issue. Might be slow.
Okay, I'll share like this. Is it okay now?
Yes, it is okay.
Yeah.
You can continue with this.
Yeah. Correct. Yeah.
I think so that is better.
Yeah.
Let's continue not to waste time. So anyway, not wasting any time, we'll be discussing on secondary diabetes, which is a separate group, which actually includes the glucose metabolism disorders, other disease or medications which are causing this disorder. Now, secondary diabetes can be defined as a condition that develops after the destruction of beta cells in the pancreatic islets or the induction of insulin resistance by any acquired disease like endocrinopathies or others. Recently, diabetes has been divided into 4 distinct types: type 1, type 2, other specific types. We have got the gestational diabetes. With the expert committee on diagnosis and classification of diabetes in USA, the categories of what my previous speakers have also talked about was the genetic disorders of beta cell functions like MODY, mitochondrial DNA, insulin action, lipoatrophic diabetes, and other genetic syndromes. Common causes which we see in secondary diabetes, which we have to keep in our mind, is the main cause, which turns out to be the disease of the pancreas, because the islet cells of pancreas are destroyed. Other causes that we have are hemochromatosis, cystic fibrosis, pancreatic cancer, hormonal syndromes that can interfere with the insulin secretions like pheochromocytoma, other syndromes like which causing peripheral insulin resistance like acromegaly, Cushing's, pheochromocytoma, certain drugs like steroids which we have been using left and right during the COVID era, phenytoin, estrogens. So looking to the pancreatogenic diabetes, it's a secondary diabetes where the pancreatic disease with exocrine deficiency leads to the endocrine dysfunction, where what happens, there is a glucose homeostasis defect where you have increased blood sugars. Though it was felt over the last decades that patients who were suffering from this type of diabetes we call as chronic pancreatitis or cystic fibrosis or post-pancreatic states or pancreatic carcinoma, they behave in a different manner, not like the type 1 or type 2 diabetics, but recently a distinct entity needs tailor-made approach. Now, looking to the mechanism of altered insulin function and release that can lead to secondary diabetes or chronic pancreatitis, there is a lot of decrease in the hepatic insulin receptors. There is more of hepatic inflammation, pro-inflammatory cytokines, the interleukin, the tumor necrosis factor alpha, the beta cell apoptosis happens. There is decrease in the beta cell differentiation, and ultimately pancreatic beta cell function decreases and it causes decreasing insulin secretion, and this leads to secondary diabetes. When we come to the classification, the American Diabetic Association and the World Health Organization have classified it as type 3C diabetes mellitus. That is because of the impairment in pancreatic endocrine functions related to acute, relapsing, chronic pancreatitis, cystic fibrosis, hemochromatosis, pancreatic cancers, pancreatectomy, or rare causes such as neonatal diabetes due to pancreatic agenesis. Now, these are the various causes which we have to keep in our mind. Gallstone pancreatitis is also very one important cause of pancreatic diabetes, and alcohol is a very high cause, especially in my state of Punjab, where we see a lot of alcoholism and we have a lot of pancreatitis because of this. Another thing which we have to notice is in our patients who are coming, they have got lots and lots of hypertriglyceridemia. So this can also lead to pancreatic diabetes. So we need to be very, very careful. Autoimmune diabetes, duct stone, annular pancreas are other causes which we need to keep in our mind when we are treating these type of patients. Tropical calcific pancreatitis, like the genetic pancreatitis already said by Dr. Mohsen, drug-causing pancreatitis like estrogens, thiazides, incretin-based anti-diabetic drugs, drugs that cause pancreatic calcifications, gallstone pancreatitis, hyperlipoproteinemias, hyperparathyroidism, miliary tuberculosis, blunt trauma abdomen, tropical calcific pancreatitis, cystic fibrosis. These are the things which has to be kept in our mind while dealing with patients. When we come to the causes, the main causes that can be as a take-home message is for chronic pancreatitis, cystic fibrosis, hemochromatosis, and pancreatic cancer. Now, the history of patient is very, very important. And as per the guidelines and as per what Dr. V. Mohan has also written a paper, there should be a history of diabetes. There should be a history of pancreatitis in the past. Patients should present with pain, abdomen, dyspepsia, steatorrhea, symptoms of malabsorptions, weight loss, calcification seen on X-ray or a CT scan or an ERCP. These patients already have a deficiency of the fat-soluble vitamins, the A, D, E, K, and they may show these states of deficiencies. Initially, over diabetes or hyperglycemia may not be present, but only occurs during the period of stress, illness, surgery, and high-dose steroids. And these type of patients do not develop diabetic ketoacidosis, as the beta cell deficiency is seldomly absolute. Brittle diabetes is another feature of pancreatic diabetes, and 80% cases require insulin, but requirement is usually very low. Diagnostic criteria, if it should fulfill the major criteria: presence of exocrine pancreatic deficiency, pathological imaging either by CT, ultrasound, or MRI, absence of type 1 diabetic associated autoimmune markers, minor criteria like impaired beta cell functions like HOMA-B, HOMA-IR, impaired secretions, GIP, low levels of lipid-soluble vitamins A, D, E, K. Coming to cystic fibrosis, that can also be the cause of secondary pancreatitis. It's an autosomal resistant genetic mutation. GI tract and male reproductive tract is usually involved. Diabetes related to complications are similar to type 1, and a sweat chloride concentration of more than 60 helps in the diagnosis of this, and a DNA analysis for genetic mutation. Coming to hemochromatosis, this is basically a genetic defect in the chromosome 6, where we have thalassemia major and sideroblastemia, and this is a triad of cirrhotic liver, diabetes, and bronze hyperpigmentation. We have the classical Kaiser sulfur link on the eyes, which we can identify. Both insulin resistance and beta cell failure has been seen. High serum ferritin, transferritin saturation levels are seen in blood hematological processes. Liver transplantation is the main say. Phlebotomy, iron chelating agents are other things which are being used in this. Coming to pancreatic carcinomas, patients who present with abdominal pain radiating to the back with history of weight loss, jaundice, light colored stool, dark colored urine, itchy skin, newly diagnosed diabetes or existing diabetes or pre-diabetic turning out to be difficult in control, and finally becoming frank diabetic in 80% cases. This is mainly because of the IR destruction of the beta cell tumors relating to obstructive pancreatitis, and insulin is the mainstay of treatment for these type of patients. Patients coming with pancreatectomy because of blunt trauma abdomen or any other cause may usually present like 70 to 80% present with brittle diabetes, and the pump option, which has been said by Dr. Day in the previous lectures, also turns out to be very beneficial for these type of patients. Like Dr. Dhruvi has already talked about malnutrition related diabetes. It is a rare type of diabetes associated with long-term malnutrition. It is classified in two subgroups by the ADA as fibrocalcific pancreatic diabetes and protein deficient pancreatitis or protein deficient diabetes mellitus. In fibrocalcific pancreatic diabetes, it is uncommon form. Usually it is in the absence of alcohol abuse, and it is found in the tropical areas. Patients are generally lean, from poor socioeconomic background, present with history of intermittent or severe abdominal pain, and the ultrasound or the radiograph or the X-ray abdomen shows multiple dense pancreatic calculi, which clearly shows into this criteria. And this is the diagnosis or criteria which we usually refer to for these type of pancreatitis. Coming to acromegaly and gigantism, it is basically by the microadenoma of the pituitary, which is seen in 70% of cases. Gigantism, because before the closure of the epiphysis, the patients are excessively having the growth of the hands, feet, jaw, and internal organs. Amenorrhea in ladies. Hypertension, yes, this is very important, where we have patients coming with visual field defects. Certain patients are referred by the ophthalmologist or a neurologist for weakness and headache and hypertension. They have a soft, doughy sweaty handshake, and they have this elevated serum IGF-1, and MRI shows pituitary tumor, which is superior to CT scan, and these patients do benefit with the surgery. Thyrotoxicosis and diabetes is another thing which has to be kept in our mind when we come to think about secondary diabetes, where we have increased glucose production from the liver because of the induction of hyperinsulinemia, induction of glucose intolerance, development of peripheral insulin resistance, responsibility for worsening of subclinical diabetes and exaggeration of hyperglycemia in type 2 patients. Thyrotoxicosis, this form can lead to ketoacidosis due to elevated lipid action and increasing hepatic beta oxidation. Coming to patients who present to us with severe or drug-resistant hypertension, the thought process of primary aldosterone has to be kept in our mind, where patient presents with polyuria, polydipsia, muscle weakness, and we see a ECG, T wave, U wave inversion, and hypokalemia, patients having gotten low plasma renin as opposed to high levels of serum aldosterone levels, and elevated plasma and urine aldosterone. Pheochromocytoma and paraganglionoma are patients presenting with episodic headaches. These patients have been visiting a lot of neurologists and psychologists and psychiatrists for their continuous palpitations, anxiety, and headache. They have hypertension, which can be diagnosed by an ABPM. They have tachyarrhythmias, and finally the catch comes when the metaphenephrin levels are checked in the urine and they turn out to be very high. So these type of patients are treated very nicely if they are caught early. Central obesity, muscle wasting, hirsutism, purple striae, the classical features of Cushing's syndrome, presenting with osteoporosis, hypertension, poor wound healing. They have hyperglycemia, hypokalemia, and leukocytosis. Levels of serum cortisol are on a higher side, and the urine free cortisol is also high. So lack of normal suppression by dexamethasone test this diagnosis, and these are the patients also who are having secondary diabetes. Patients presenting with gluconoma is extremely rare when the tumor forms in the islet cells of pancreas, releasing insulin and glucagon. This type of tumors is usually cancerous. It spreads very fast over a period of time, influences the pancreatic islet cells, causing the production of too much of glucagon. And extreme thirst is one thing which the patient presents, and getting up in the night and urinating, and frequent diarrhea. Somatostatin reduction of insulin secretion results in diminished glucose use and hepatic glucose overproduction. Thus, the associated inhibitory syndrome leads to the development of diabetes in almost 90 to 95% of these type of patients. So this is a rare diagnosis, mainly malignant. Location is usually the head of the pancreas. Clinically, it is unpredictable. It is a chance diagnosis when you have an insight to look into it, where the patient has gallstones, mild diabetes. We think because it is a gallstone, maybe gallstone pancreatitis. So this is a diagnosis which has to be ruled out. It's a diagnosis of exclusion where we come to this. Drug induced. In the previous 2-3 years, we have been seeing lots and lots of patients coming with hyperglycemia secondary to the drugs which has been used, like steroids. Drug-induced diabetes can be caused by multiple mechanisms. There is this includes insulin resistance, that increases the hepatic glucose production, decreased secretion of insulin, intolerance, autoimmune destruction of beta cells is also seen. We see atypical antipsychotic drugs which are being using, leading to insulin resistance. Certain beta blockers, they inhibit the insulin secretions. Calcium channel blockers, which we are using left and right, inhibit secretion of insulin by interfering with the cytosolic calcium release. Steroids, as we already know, causes peripheral insulin resistance and gluconeogenesis. Fluoroquinolones inhibit the insulin secretions by blocking the ATP-sensitive potassium channels. Niacin can cause increased insulin resistance due to the increased free fatty acid metabolism. Phenothiazines inhibit the insulin secretions. Protease inhibitors, they inhibit the conversion of proinsulin to insulin, and thiazide diuretics. So these also cause increased insulin resistance due to the increased free fatty acid mobilization. So these are all the causes of secondary diabetes. Drug-induced diabetes post-transplant. Even if you do not have diabetes before, a patient can develop diabetes after an organ transplant, and this is called as NODAT, or new onset diabetes after transplant. New onset diabetes can occur as a side effect of the medications that we are using for organ transplant recipient patients to prevent the rejection. and mainly cyclosporin, tacrolimus, they impair the insulin secretion. Sirolimus principally increases the resistance of insulin. So in the end, I'll just say that hardly 1 to 2% of all diabetic patients turn out to be secondary diabetics. We need to have our eyes and ears open when the patient comes to us with the clinical presentations of atypical pain in the abdomen, steatorrhea, diarrhea, or sweating. Diagnosis is extremely important, as many cases of diabetes may be completely treatable. Screening for secondary cause may be very expensive, but if we have a clinical insight, certain strategies can be planned for a better yield. It is important carefully taking the history of patients when the first symptoms of glucose metabolism disorder, when we take a history, when the patient first presents to us. And it is vital to diagnose them as early as possible to formulate appropriate treatment diagnosis. Thank you for your patient listening. I hope I have met the criteria of the time.
Thank you, Dr. Ashish, and it was a very nice presentation. And any questions from anybody in the dais?
For Dr. Ashish sir, regarding secondary diabetes, particularly to pancreatogenic diabetes, yes, you have mentioned that diabetes is usually mild. That is in patients who have chronic pancreatitis. Yes, usually it is mild, and it is because of polypeptide response, reduced polypeptide response rather than insulin deficiency early in the disease. That we have already proven in one of the papers in AIG. So here, that is because of the polypeptide response, there is more of hepatic insulin resistance. So this patient respond very well to metformin and pioglitazone. But also patients we have, one more thing you have mentioned, DK incidence is very, very low. But maybe because I'm working in a gastro institute where there are only specific pancreatic patients come, every day we see 2 to 3 patients of acute necrotizing pancreatitis, maybe because of secondary to alcohol and biliary pancreatitis, they present with ketoacidosis. Every day 2 to 3 patients are there here.
See, Dr. Mohsin, I was talking about chronic pancreatitis. So the patients who present to an OPD, and when we think of secondary diabetes in for those patients who are of chronic diabetes, anybody with acute pancreatitis is definitely admitted in the hospital. And in the hospital, the treatment has to be insulin. We should not recommend, I don't think so, we will be giving metformin when the patient is acute. We have a lot of patients of acute pancreatitis. Like I said, there was one patient who came to me with pain abdomen, and I got an ultrasound abdomen which was showing bulky pancreas, got a CT scan, it was mild pancreatitis. And this patient was an OPD patient, so I just continued the patient on basal bolus insulin therapy, and she's doing with a very low dose of 8 units very well. So there are this is the secondary diabetes type of patients which we are talking, which comes to our OPD walking, not to the emergencies for ICU admission.
So on behalf of the committee, I thank all the speakers for their very nice deliberation, and I congratulate and compliment Dr. Arvinda for this conference. And he has created this memo task looking very easy. Means I don't think it is very easy to bring all the diabetologists and endocrinologists on a single platform, but he has somehow managed to do so. So my compliments from my heart, Dr. Arvinda, for this. And thank you for.
And he has brought in the best topics which could have been of interest.
Really, I was listening to all the topics yesterday also and since morning also, and this very good, very nice conference, Dr. Arvinda. I should compliment you again.
Thank you. On behalf of Dr. Arvind Diabetes Center and ADC International Virtual Diabetes Summit 2022, I thank wholeheartedly Dr. Sadashiv Rao, Dr. Ajay Kumar Gupta, Dr. Dhruvi Asnani, Dr. Mohsin Aslam, and Dr. Ashish Saxena for your valuable time and for being a part of our conference. Thank you so much.
Thank you all. Thank you very much.
Thank you.
Thank you and happy Navaratri to everybody. Durga
Thank you.
Puja.
Same to you all.
Same to you. Same to you.
Over to Dr. Shweta, please.
Yes. Thank you, sir. Thank you, speakers. It was a wonderful session, and happy Navaratri to all speakers. Let's move on to our next session. Dr. Shifali Karkhanis, consultant diabetologist, founder and co-director of Karkhani Super Specialty Hospital from Thane, a famous diabetologist, I would like to introduce our another chairperson, Dr. Manish Agarwal, founder and director of Medilink Hospital and Research Center of foremost diabetes centers. He is fellow of the Royal College of Physicians, Glasgow. Thank you, chairpersons. Welcome. Over to you.
Thank you so much, Dr. Shweta. And Dr. Arvind, I echo Dr. Gupta's words. Absolutely fabulous job. Excellent lectures. And I really enjoyed listening to them. We are now in an era where we are talking about only newer molecules. And I think this is one of the few conferences that is going back to old is gold. So to shed light upon the older molecules, which we have been using since ages now, I call upon our first speaker, Dr. Harish Darla. He is an endocrinologist, a renowned endocrinologist, consultant physician, working at Darla's Healthcare Center in Mysore. And he is going to shed a little light upon the most talked about molecule, let's put it this way, because it's not easy to talk about something which, is been in a kind of a controversy up and again. So we're going to talk about the role of pioglitazone in the era of newer agents. Over to you, Dr. Nari.
Thank you. Thank you so much, Dr. Shifali. Hope I'm audible and visible.
Yes, you are.
Okay, so let me just share my slides. Okay, is it in the full screen?
Yes.
Yeah.
Okay, fine. And at the outset, let me thank Dr. Arvind for an excellent conference he's done. And year after year, he's getting much better. And all congratulations to you, Dr. Arvind. So as you told Dr. Shefali, it's difficult to talk about an old molecule, which has always been under a cloud in the era of newer molecules. But definitely, yes, we are missing out somewhere. And this molecule is there to stay. Even the recent ADA and ESD guidelines has pioglitazone in its armamentarium, though lower down the order, but definitely it is still there. And we all know that this is a progressive disease, and how an Asian population would behave from a Caucasian one is entirely different. And that is where we are going to see as whether we as in South Asian benefit with pioglitazone more than other molecules. So anyway, at the outset, let me wish you all happy Dasara for all South Indians and happy Dashera for all the North Indians. Let's not divide between South and North, but definitely yes. So here there's a caption, there is truth is always victorious, and definitely yes, it holds good for pioglitazone as well, because the family itself has been cursed from the beginning when it started, but definitely over a period of time, pioglitazone has stayed there and is going to stay for a longer time. So it has fallen from the grace, but definitely is raising up. So we all look at this natural history of type 2 diabetes, and we all know that insulin resistance is one which is a major cause for Asian population being diabetic, and this is where we need an insulin sensitizer, and pioglitazone is the best insulin sensitizer compared to metformin. So here this molecule is here to stay, and everybody is seen this day in and day out about a thin fat Indian. And why do we need to talk is because of a lot of issues which pioglitazone does address. So we get diabetes at an younger age, we have a lower BMI, we have lesser mid circumference, but we have a lot of hip waist ratio, and there is a lot of subcutaneous and tricuspid fold fat is much more there, and the percentage of fat is much more higher in an Asian compared to a Caucasian. So this is where pioglitazone acts, and acts much better compared to a Caucasian population. So here we all know that almost about 83%, and in some studies they have shown that about 90% of all diabetic patients are insulin resistant. So here you need an insulin sensitizer to work better. And this is a study which is done, which shows that insulin resistance is proportional to cardiovascular disease and link. As I have told you that almost 80% to 90% of all type 2 diabetic have insulin resistance. And we know that diabetes is cardiac equivalence, so the chances of having doubling the dose cardiac event are very high in a diabetic patient. And it's implicated in insulin resistance, even in a non-diabetic patient, has an implication of stroke and cardiovascular disease. It's almost double the amount in a non-insulin sensitized patient. So this is a meta-analysis where almost 45.5 lakh patients were looked at. And in diabetes who had insulin resistance, they had a 32.2% chances of having a CVD. When you just break down, you can see that 29.1% would have atherosclerosis, 21% have coronary artery disease, 14% heart failure, 14.6% angina, 10% myocardial infarction, and 7.6% stroke. This again boils down to insulin resistance in a diabetic patient. So where do we fit pioglitazone as a protector? So you have two components here. One, you're going to look at glycemic component and the extra glycemic benefit. Basically, that is what again is being seen in SGLT2 inhibitors, where you have glycemic component, but now it is taken over by the cardiologist and nephrologist for nephro and cardio protection. So pioglitazone does have these two components. Now, if you look at the latest guidelines of 2022 of ADA, definitely they do consider pioglitazone in atherosclerotic vascular disease after GLP-1 analog and after SGLT2 inhibitor. And if still the HbA1c is high, pioglitazone does have a chance to be added. And again, when you look at hypoglycemia, this minimizes the risk of hypoglycemia. So pioglitazone can be considered, and it is very affordable and at low price. Though now with the off-patency of both a DPP4 and SGLT2 inhibitor, pioglitazone can be a choice if there are a lot of cardiovascular disease. When you look at the American Association of Clinical Endocrinology, where they divide based on the entry criteria of HbA1c, either at an entry criteria, though it is given under caution, but yes, it can be used as a molecule to start with, or it can be used in a dual therapy or triple therapy. Now, it is here very important for us to choose and pick our patients whom we can add pioglitazone or a glitazone. You can't choose and pick a patient with heart failure where you can start them immediately with pioglitazone. That's going to be deleterious. And let's look at our own guidelines, the RSSD and ESI guidelines. And again, you have to go from inside out, where lifestyle modification, then comes metformin. Again, metformin is coming down the line that it might not be the choice of treatment to start with as a monotherapy. Yes, it can be an SGLT2 inhibitor, it can be a DPP4 inhibitor. But again, when you look at this RSSDI guideline, pioglitazone fits into all the criteria, whether it is age, whether it's BMI, whether somebody has a CKD, established CVD or ASCVD. So here it fits all the criteria, but still it is the most underutilized molecule or most feared molecule, as Dr. Shefali did tell. Now, any guideline you take, whether it's American Diabetic, AAC, or RSSDI, pioglitazone does have a role to play. Now, let's look at what are the how does it act. We all know that it acts on PPAR gamma activation. Now, when you have a PPAR gamma activation, when you look at the direct effect on vascular, it reduces the inflammatory marker. That is very, very important. We obese Asians are having a high inflammatory marker. So pioglitazone or activation of PPAR gamma can reduce the inflammatory markers in a vascular, and it has an indirect effect on adipocytes, hepatocyte, and skeletal myocytes. So it reduces, it increases insulin sensitivity and also reduces triglyceride. This in turn reduces the inflammation. So this is where pioglitazone acts, and it is always better. So you look at the glycemic in type 2 with pioglitazone. Now, this is a study which was done when they compared metformin and pioglitazone to look at the insulin sensitivity indicators. Now, here you have 205 patients divided into two arms. In one arm, they started pioglitazone at 15 milligrams and then escalated to 45 milligrams. In the other arm, they started metformin with 500 milligrams, and the maximum dose was 2,250 milligrams. And this one was over a period of 32. So what were the insulin sensitivity index? If you look at the A1C and the fasting blood glucose, there were not much difference between pioglitazone and metformin. But definitely, yes, when you look at the fasting insulin level and the HOMA-S or sensitivity pattern, they were much better with pioglitazone compared to metformin. So here it shows that pioglitazone is an insulin sensitizer much more than metformin. Again, this is a durability index where it was done in Japanese study, multicentric study, where they had two arms, one with other diabetic medication, they added pioglitazone, and in the other one without pioglitazone. So almost about 290 patients were taken in both the arms, and this study was done for 5 years, and they were diabetic, were included between 2.5 to 4 years of diabetes. Now, what did they find? The dark black arm you can see is with pioglitazone. So you have a very good control of fasting blood glucose, even extending post-study period in patients who are on pioglitazone with other diabetic molecules. And when you look at A1C, yes, definitely, again, you could see a good reduction in A1C, though it increased over a period of time. but compared to other molecules without a glitazone, had a much more higher A1C compared to those on glitazone. So why is it so strong data? Yes, the mechanism, we know that it acts on PPAR gamma, and as I've shown you, why it is important. And then it is a insulin sensitizer and explains the durability of A1C. And it is very potent molecule. So when you look at pre-diabetic patient, again, you have a lot of studies with pre-diabetic patients with stop NIDDM and things. So when they added pioglitazone, it has shown that it reduced the onset of diabetes from pre-diabetic to diabetic in 72% of the patient. So this one is because of preservation of beta cell function. So there is a huge advantage even if it started in a pre-diabetic patient, and you can prevent them becoming from pre-diabetic to diabetic. Let's look at the extra glycemic benefits, what we get. Now, what better picture can you have with pioglitazone having so many advantages? When you look at the carotid artery atherosclerosis, it reduces the intimal media thickness. And that is one of the markers for atherosclerosis. It reduces the plaque inflammation and stabilizes the plaque. When you look at the coronary artery disease, yes, it prevents the stent restenosis, it prevents the neo-intimal new vessel formation, and it also reduces blood pressure. It has an effect on blood lipids. And most important thing is, yes, this is the problem. There is, it increases fluid retention, and it has to be cautiously or judiciously used or not used in a patient with acute heart failure. But again, it has an advantage on the renal parameters. It redistributes the fat, and this is where it is. From visceral, it redistributes into subcutaneous fat. So again, somebody who has more of visceral fat has insulin resistance compared to those who have subcutaneous fat. And when you look at the proactive study, which was done in 19 European countries, it was prospective study, where there were patients who had a major macrovascular complication, such as MI, stroke, or they've had a bypass surgery. They were divided into two groups, one with pioglitazone and one with placebo, so almost 2,600 patients. They looked at what was the primary composite endpoint and the secondary composite endpoint. So those in pioglitazone group, the one in the red bar is in the pioglitazone and the blue one is the placebo. So there was non-significant reduction in primary composite endpoint in patients with pioglitazone, but there was 16% reduction in a secondary composite endpoint such as all-cause mortality, non-fatal myocardial infarction or stroke in patients with pioglitazone. So here you have an advantage of reducing the macrovascular complication. Now this one was a trial which is insulin resistance in ischemic stroke. Now believe me, this is the patient here, they were non-diabetic, but who had an insulin resistance of HOMA-IR of more than 3. They were selected. Those patients who had an ischemic stroke with non-diabetic, when they looked at, when they added pioglitazone, they showed that there was a 24% reduction in non-fatal stroke or a fatal stroke at the end of 5 years. So even it can be used in a stroke patient with a non-diabetic patient. And this is in 2021 guideline from American Heart Association or stroke. The evidence is 2B. Here they have shown that anybody who's had a TIA or an ischemic stroke less than 6 months, A1C of less than 7, pioglitazone can be considered to prevent recurrent stroke. And this is a periscope trial which was done with pioglitazone. And here, anybody who had an extensive macrovascular disease, they were divided in pioglitazone and they looked at glimepiride. From 15 to 45, it was escalated in glimepiride from 1 milligram to 4 milligrams. So what was the outcome? They looked at the parameters which increase the atherosclerosis. You look at the HDL activity. The HDL improved in patients who were on pioglitazone, the round bar. The triangle one is with glimepiride. But here the inflammatory markers such as C-reactive protein was much lesser, significantly lesser in patients who were on pioglitazone compared to glimepiride. And again, when you look at the atheroma with intravascular ultrasound, definitely pioglitazone showed that all the markers were less and there was a regression in the atheroma in a coronary artery in patients with pioglitazone in periscope trial. And this one was a TOSCA study. It was either glitazone or sulfonylurea with cardiac accidents in an intervention trial. Again, this study was for 5 years. They had taken pioglitazone, escalated from 15 to 45, or glimepiride, 1 to 4 milligrams, and they looked at various parameters. And again, patients who were on pioglitazone and metformin showed a 4% reduction in all-cause mortality, non-fatal stroke, or an MI. So where all it can be used, definitely yes, you don't need a renal dose adjustment in patients with renal parameters. Hepatic, again, there's no dose adjustment required in hepatic impairment. So again, pioglitazone not only has an advantage on atherosclerotic cardiovascular disease, but there were a lot of studies which are seen in diabetic nephropathy. Either it reduced the urine albumin excretion or urine albumin excretion ratio. So there are various studies, and you can see that this favors thiazolidinones. And again, this one was to reduce microalbuminuria. When they compared pioglitazone with metformin, there was 19% reduction in urine albumin creatinine ratio in patients who were on pioglitazone compared to metformin. And this one was on those patients who were on hemodialysis. There was remarkable reduction of 35% of all-cause mortality in patients who were on hemodialysis on thiazolidinones. And again, they had divided between somebody who was on insulin or not on insulin. So somebody who was not on insulin, the reduction was almost more than 47% of all-cause mortality in patients who were on hemodialysis. Again, it has a lot of advantage on NAFLD or non-alcoholic steatohepatitis. It reduces the AST and ALT levels. And this is again a study which shows that there is a redistribution of fat from hepatic triglyceride. It reduces, and again, various non-alcoholic activity scoring was reduced in patients who were on pioglitazone in the yellow bar, if you can see in both the studies. So again, dose dependent, we use 7.5 to 45 also, but 15 milligrams is as good as full dose, which is seen in various studies. So the side effect with pioglitazone is edema, and that can be negated if you add an SGLT2 inhibitor. There is one study which is showing when they added with dapagliflozin, the edema was much less compared to a patient who was on pioglitazone alone. Again, as I told you, this is a cursed family. From the beginning, it has been cursed, and the most common cause was either cardiac failure, cardiac death, or bladder cancer. Again, it is shown that there is a potential effect of pioglitazone. It reduces the heart disease by 20% risk reduction is there. In stroke, there is 20% risk reduction. In diabetic, from pre-diabetic to diabetic, there's a risk reduction. Except if you see in the bladder cancer, there was a marginal increase in the cause of bladder cancer in patients who were on pioglitazone. This is FDA again has ruled out that there was no increased risk of or statistically significant risk of bladder cancer in patients who were on pioglitazone. This is an Indian study again which shows about 66 publications were taken. So association of bladder cancer with pioglitazone was not found to be significant. Again, can be used, but definitely not to be used in any active bladder cancer or who's had previous bladder cancers. So pioglitazone has to clear a lot of hurdles. Definitely, yes, it has a pathogenesis to play, and we Asians do have a lot of insulin resistance. So it is the best insulin sensitizing medication in a diabetic patient. And we know that it reduces the HbA1c by about 1.5%. You have other advantages of cardiovascular benefits. It also helps in reducing the inflammatory markers in NAFLD. It has increased the HDL levels. And yes, definitely we have to have a precaution with bladder cancer, heart failure, and bones. And practicalities, yes, Indian genotype, we will benefit with pioglitazone, and it is easily available. So my take-home message would be is take care of all skeletal muscle glucose uptake, and this is a very good insulin sensitizer. So use it judicially if you can use it. It is cheap and effective. Again, other molecules are now getting cheaper with the off patency. It has a positive impact on cardiovascular disease and liver. Now, believe me, there are studies which are showing that the cardiovascular benefit is as good as an SGLT2 inhibitor. So it reduces about 14% of cardiac mortality as compared to an SGLT2 inhibitors. It is recommended for NASH. With appropriate prescription and titration, this would make pioglitazone a cost-effective cardioprotective agent in the armamentarium of our treatment. So thank you so much.
Thank you very much, Dr. Darla. That was an excellent presentation. I think we can really take home a message that with the next the next tsunami that is hitting us is the NASH and the visceral obesity, especially in India. And I think pioglitazone is here to stay, as you've rightly put. Any questions from the no. Okay, so moving on to the next topic. I think as Dr. Darla exactly said that we use 7.5 and 15 instead of 45 as is the recommended dose used in the Western population. I think the Indian jugaad that we have, I call it common sense, works a long way. And to share his insights upon the intelligent use in the clinical practice, day-to-day practice of every physician, I call upon Dr. Akash Kumar Singh. He is an eminent diabetologist. He is a senior consultant. He is the president of IDCM. He is the vice president of Association of Physicians from Vadodara. He is a governing body member, executive body member of API of Gujarat. He has many accolades to his name, and he has published multiple research papers in international and as well as Indian journals, along with poster presentations in IDF, ACE. He is the author of a book, Management of Type 2 Diabetes, a complete practical guide, and he is. I call upon him to please share his insights on intelligent use of oral anti-diabetic agents in a day-to-day practice.
Thank you,
Over to you.
Shefali. Thank you, Shefali. I thank Dr. Arvinda for giving me this platform to talk, and I'm talking on this platform for the first time. So it gives a real pleasure to talk on this platform. I welcome all the doctors who have joined in to attend this session. I will be talking about the intelligent use of oral anti-diabetic agents in day-to-day practice, and my task has been made difficult by constantly changing guidelines, and even the ESD, again, we had new guideline. So the measure of intelligence is the ability to change, and we have seen this very well in our diabetic guidelines, which are changing by the day. Every year there is a change now, and there is a new excitement, new developments, new studies being reported, and the guidelines are changing. I will present my talk in the headings which are listed here. So first, the introduction and the global prevalence. You know that type 2 diabetes is a combination of insulin resistance and beta cell dysfunction. Diabetes is a global emergency with the diabetic cases going by the day, and it is estimated by 2045 we will have 700 million adults with diabetes. And of this, Southeast Asia is the epicenter because of the huge population, and the increase in numbers is very huge. India presently houses the second largest number of cases of diabetes across any country in the world, second only to China, and the cases in India also increasing very, very fast. Now we all know about the Omnis Octet, and these are the 8 players of the Omnis Octet, and as you can see that various drugs act on various pathophysiological mechanisms in this 8 pathophysiological mechanisms listed. And this makes it very clear that if you use a combination therapy, then you are likely to address more pathological mechanisms and reap a better result in the management of diabetes. Every 1% drop in HbA1c can reduce the long-term diabetic complications, which has been very, very clear in the UKPS study. And you can see that all the various micro and macroscopic complications are decreased with 1% reduction in the HbA1c. Now, the factors which are relevant to Indian context are the high prevalence of prediabetes and diabetes, onset of type 2 diabetes at least a decade earlier than in Western countries, high prevalence of diabetes-related micro and macroscopic complications, large rural-urban divide, sedentary lifestyle, physical inactivity, cost of diagnosis, treatment, monitoring, and prevention, which is affected by the limited resources which the patients have and the government has. Glycemic control is also poor among Indians despite availability of all the major class of OHAs, and this is the ICMR in their study, which you can very well say that across various countries, rural and urban areas, the HbA1c was 8 to 9.4%. Now, coming to the various OHAs which are available with us, and as you can see very well that we are getting more and more OHAs basically as the times go, and this is how the OHAs have evolved. And after the SGLT2, the excitement is that we are getting the oral semaglutide this year. It is available now, and we have a lot of oral agents to use. So it is vital for us to decide where to use which OHA, and their proper knowledge and proper patient selection is required. Now, coming to metformin, it is a efficacious drug with high efficacy, with least chances of hyperglycemia, weight neutral, and a potential benefit on the MACE. It can be used in DKD up to a certain EGFR, and available in oral form. Traditionally recommended as a first-line glucose-lowering therapy for type 2 diabetes because offers high efficacy in lowering HbA1c, minimal hypoglycemia when used as a monotherapy, potential for some modest weight loss, good safety profile, and low cost. And we have extensive experience with this molecule, rare hypoglycemia, decreased severe events, modest weight loss, overall good long-term safety profile. It also modifies the gut microbiota, clinical and preclinical evidence in the treatment of cancer, and the side effects are mainly GI side effects, which can be circumvented by gradually increasing dose, rare risk of lactic acidosis, and vitamin B12 deficiency. Coming to sulfonylureas, again, drugs with high efficacy. However, their efficacy is offset by chances of hypoglycemia and weight gain. On the MACE, they are weight neutral, as has been demonstrated by recent trial, comparison of linagliptin, and neutral on the DKD front, although hypoglycemia is a major limiting factor. So the glucose lowering efficacy is high, they are inexpensive, accessible, and a heterogeneous group of sulfonylureas with low risk of hypoglycemia. The newer sulfonylurea should be selected. No difference in MACE in high-risk individuals when used. So modern sulfonylureas can be used in CVD. You can use them in CVS, high CVS patients, in MI, stroke, stable CADs, peripheral artery disease, uncontrolled dyslipidemia. In other patients, you have to use with caution, especially if they are little unstable. Now coming to thiazoles, again, this topic has been alluded to by Dr. Darla in the previous lecture, so I'll not go much about this, but they are very efficacious and they are tailored to suit the Indian phenotype of diabetes because they address the insulin resistance, they improve the insulin sensitivity by 25 to 68%. The glycemic control is good basically, and they have effects in preserving beta cell function as has been demonstrated by various studies because they decrease the progression of conversion of pre-diabetes to diabetes by 60 to 70% in various studies. Coming to DPP4 inhibitors, intermediate efficacy, but highly favored drug because their tolerability is excellent. They are like plaque pants. You can wear them for any occasion. Can be combined with all the drugs except GLP-1 receptor agonists, and their effect on weight is neutral, on MACE is neutral, and on heart failure is neutral except for sexagliptin. So intermediate glucose lowering efficacy, neutral effects on weight, generally well tolerated, minimal risk of hyperglycemia. Early combination therapy with metformin has been demonstrated in verified trial, has led to longer duration of control of diabetes, which is very beneficial to have the legacy effect, and cardiovascular safety is demonstrated with many of these DP4 inhibitors. Coming to SGLT2 drugs, the master drugs, the metabolic drugs, intermediate to high efficacy, no hypoglycemia unless used with insulin and secretagogues, weight loss, MACE, benefit on MACE, heart failure, progression of DKDs, and they can be used, majority of them can be used up to AGFR of 30. That is the recommendations now available in oral form, OD dosing, and no dose titration. They lead to reductions in major adverse cardiovascular events, reduction in overall CV deaths with heterogeneity across the class, reductions in risk of hospitalization of heart failure, reduction in risk of kidney outcomes, and the only drugs to be approved for heart failure with preserved ejection fraction, empagliflozin already improved, and dapagliflozin in line to be approved, shortly to be approved. Now coming to alpha glucosidase, these drugs, although not favored in the Western countries, are the drugs in the Indian populations because of high carbohydrate in the Indian population, leading to increased postprandial hyperglycemia. So addresses the issue of postprandial hyperglycemia, the dual mode of action in which glucose absorption and increases the GLP-1 levels, no hypoglycemia, no weight gain, suitable for high consuming carbohydrates. The benefits are offset by GI side effects, frequent dosing schedule, and modest HbA1c efficacy. Now coming to GLP-1 receptor agonists, the new drugs basically, they're exciting drugs basically because now semaglutide is available in oral form. They have high to very high efficacy with no hypoglycemia, weight loss, the maximum weight loss we can achieve with these drugs basically. They have effects on atherosclerotic cardiovascular disease as had been demonstrated in the Rewind trial and in the LEADER trial and in the SUSTAIN 6 trial. Heart failure, on heart failure, it is neutral effect. There are benefits in the renal front, although not as massive as with SGLT2 inhibitors. And you can use these drugs up to age of 15, basically. So glucose lowering mechanisms, this is glucose dependent. They augment the insulin secretion, basically. Their clinical efficacy high to very high. Cardiorenal effects are favorable, and there is an increasing confidence surrounding areas of interest in these molecules. And as we have already seen, the first GLP-1 receptor agonist is available, and there is a higher dose of GLP-1 receptor agonist translates into incremental benefits in glucose and weight lowering efficacy, greater clinical expertise in anticipating and addressing GI effects, because with the prolonged use of these agents, we are very well aware of the how to use these agents, and we are very comfortable in using these agents. Oral semaglutide has low risk of hypoglycemia, no dose adjustment required for elderly patients, upper GI disease, hepatic impairment, or renal impairment. Oral semaglutide can be used in people with mild, moderate, and severe renal impairment. Exposure to co-administered drugs generally not affected by to a clinical relevant degree by oral semaglutide. Non-clinical studies indicate that semaglutide has beneficial effects on CVS. Semaglutide improves clinical markers of cardiovascular risk in patients of type 2 diabetes. The disadvantage is mild to moderate nausea. Cost is a huge disadvantage. It is contagious in patients of pancreatitis, MVN2, and medullary thyroid carcinoma can worsen diabetic retinopathy. So some studies have already been done with oral semaglutide, and it has been shown to non-inferior formulas compared to placebo. As you go on increasing the dose, up to a dose of 40 milligram, you can land up with a weight reduction of 5 kg, which is one of the best in class as far as the oral agents are concerned. Another agent which is available, which I have not mentioned, is the magletides, the ripraglutide, which has an intermediate efficacy and a short duration action, and mainly is used for addressing postprandial hyperglycemia and has a propensity to cause hypoglycemia. The combination therapy is very much favored because there is an increased durability of glycemic effect, potential to address therapeutic inertia, which has been very well seen in the VERIFY trial, simultaneously targeting of multiple pathologic processes characterized by type 2 diabetes, potential impact on medication burden, adherence, treatment persistence, complementary clinical benefits such as glycemia, weight, cardiovascular risk profile, and a combination therapy is the thing to go, basically, because it increases adherence and provides maximum benefit to the patient, as well as the adherence to therapy is improved, and a long time control of durable control of diabetes is achieved. Now, this is the newer algorithm of the EASD ADA released a couple of days back, and it clearly states that if a patient has atherosclerotic cardiovascular disease, or if there is indicators of high risk on the atherosclerotic front defined by age and comorbidities, then GLP-1 receptor agonist or SGLT2 inhibitors, or both of them, should be used. In patients of heart failure, current or prior SGLT2 is clear choice, followed by GLP-1. In patients of CKD, again, preferably SGLT2 inhibitors are the clear choice in these conditions, followed by GLP-1. They also defined drugs with very high efficacy, which is dulaglutide, semaglutide, and tirzepatide, with high efficacy, which they have GLP-1 receptor agonist, not mentioned above, metformin, SGLT2, sulfonylurea, thyrosinose, and intermediate would be DPP-4, and weight loss, agents achieving very high weight loss, semaglutide and tirzepatide, high weight loss, dulaglutide, liraglutide, and intermediate weight loss, GLP-1 receptor not listed above, and SGLT2 and neutral DPP-4 metformin. So they have classified the drugs very nicely, basically, in these guidelines, and they have presented a new perspective in the management of diabetes. Coming to the RSSJ USA therapeutic wheel, and we are very well aware lifestyle modification, metformin, and then you have to classify the patient as per the ABCD criteria, GF, accordingly institute therapy in the clockwise manner as mentioned this wheel. However, we are likely to get a new guideline in the next month in the RSSJ conclave, basically, because these guidelines do need some change. Now, decision cycle for now, the thing is that patient-centric approach has to be followed. You have to assess the key characteristics of the patient, consider specific factors that impact choice of treatment, utilize shared decision making to create a management plan. You have to talk to the patient in the language they understand, make them understand, and then institute therapy so as to have the patient as a co-partner in the treatment and improve adherence, agree upon management plan, implement management plan, provide ongoing support and monitoring, and review and agree on the management plan. You have to periodically review his progress. Preventing complications is a major component. We are no more glucocentric. We want to control everything apart from glycemic management. We want to give patient cardiorenal protection, weight management, and cardiovascular risk factor management. So age, BMI, CKD, duration of diabetes, established CVD, financial condition, glycemic condition, hypoglycemic concern. And this is how the NSSDF decision making is taken. And from 2000, where we had only a glucocentric approach, we have evolved in 2020 to a approach where you have to control, apart from glucose, all the other risk factors present in the patient. So first you have to have.
Pardon me, sir. Last few seconds left, sir.
Okay. Okay, so you have to basically decide on the HbA1c goals in the patient, individualize the glycemic goals in the patient, and hypoglycemia is a very, very major concern. So you say use those patient drugs which basically are likely to cause less hypoglycemia, and you also have to assess the patient basically to see which patients are likely to get into hypoglycemia, and the drugs which are causing least hypoglycemia should be used. If you are using as sulfonylureas, you should begin with the lower dosage and gradually come up, and not more than half the maximum dosage should be used. Consider the age, the sulfonylureas, glimepiride, glycoside in lesser dosages, DPP4, AGIs, SGLT2 inhibitors. In select patients, glitazones should be restricted, and the insulins are the drugs to be used. BMI, we already seen the SGLT2 inhibitors, GLP-1 receptor agonists should be used to lower the BMI. The other drugs are weight neutral, more or less. Weight reduction is very important because a weight reduction of 5% gives metabolic benefit, and if you achieve weight reduction of 10 to 15%, you may even be able to reverse diabetes. In CKD, we have this chart basically which shows the eGFR and the drugs, the drug modification basically, and so metformin should be stopped below eGFR of 30. All the SGLT2 inhibitors can be used up to 30 eGFR. Duration of diabetes, initial phase, you have to go for tight control. In long standing, you can relax your goals because initial phase UKPDS has clearly stated the legacy effect. Established cardiovascular disease already seen. Financial concerns, we should use the cheaper drugs. Glycemic status, we should use as per the potency of the drug. And to summarize, make the patient follow diet and ensure patient exercise regularly. Update metformin to maximum tolerated dose. SGLT2 preferred in the presence of heart failure, established CVD, CKD, and high CV risk in obese patients. Gliptins preferred in renal impaired and elderly with least side effects and moderate efficacy. Use modern sulfonylureas in the lowest effective dose to minimize weight gain and hypoglycemia. AGI is very good on add-on option. Glitazones, as already discussed, oral semaglutide is a good drug, but financial concerns remain. Prefer early combination therapy. Patient adherence to treat is most important. Focus not only on glucose, but also control other CV receptors. With this, I conclude. Thank you very much.
Thank you very much, sir. It was indeed an elaborate and perfect overview of all the OHAs that are available in the market. And with an array of OHAs that are AHAs, anti-hyperglycemic agents that are available in the market, I would now call upon Dr. Basab Ghosh to share light on the actual oral hypoglycemia, as we call it. So I invite Dr. Basab Ghosh. He is a senior diabetologist from Agartala, Tripura. He is the winner of a gold medalist from Professor M. Vishwanathan, Roypuram, Chennai, MDRC, and has won distinction and honor and diploma in diabetes from Annamalai University. He is on the scientific committee member, a nodal officer for COVID-19 task, and he has been a faculty on various government in various faculties as well, national and as well as international conferences. Over to you, sir.
Thank you. After the beautiful Sunday lunch in the name of ADC International Virtual Summit 2022, I believe everybody is feeling sleepy. So first of all, thank you, Chairperson Dr. Shefali, for your kind introduction, and special thanks to Dr. Arvinda Jagdesha for inviting me in this scientific feast. I'm glad to be part of this Old is Gold session, And my topic is there a place of sulfonylurea in type 2 diabetes management? That sulfonylurea is one of the oldest. It's the first reported in 1937, more than 80 years back. And in 1995, we got the third generation. In between 1946, we got the mechanism of action, then 1950, 1946, consecutively first and second generation. So it is one of the oldest OHA. And since 1995 to 2000, lots of molecules have come. Metformin was reintroduced in 1995. Then rapaglinide, rosiglitazone, pioglitazone, acarbose, and etaglinide all have come in this period. And DPP-4 ultimately sitagliptin approved by FDA in 2006. And so many drugs came to the market, and there was concern regarding the effect of those drugs on cardiovascular risk, particularly after the rosiglitazone incident, which was associated with a significant increase in the risk of MI. And that was published in NEJM in 2007 by Nissen et al. Given all this concern, in 2008, FDA came out with a recommendation that new glucose-lowering medications for diabetes are shown not to increase cardiovascular risk. So when you see the ADA 2020 guideline, that HbA1c, when HbA1c is above a target and cost is an issue, then sulfonylurea is of course there in all the blocks. And in nutshell, if we see what they wanted to say regarding sulfonylurea, choose later generation sulfonylurea to lower risk of hypoglycemia. Glimepiride had shown similar CV safety to DPP-4 inhibitor. And among the available second-line treatment of type 2 diabetes, sulfonylurea is the most economical. And this is the latest consensus report between ADA and ESD 2022. This ongoing ESD, it has been shown and published. And here, a specific point I want to highlight, they said consider specific factors that impact choice of treatment, that is regime choice, to optimize medication use and to reduce treatment discontinuation. Treatment discontinuation, very, very important for a lifelong disease like diabetes. Then access, cost, and availability of medication is very important, and those all are required, related with discontinuation of treatment. And sulfonylurea, I'll show it's is rather helping in that issue. ADA further said, that the ADA-ASD joint consensus recently, 2 days back, they further said regarding sulfonylurea, I made it in a list that they, in fact, did not downgrade sulfonylurea. Response to sulfonylurea is rather better than before in this joint consensus. Sulfonylurea mentioned as neutral to effect on MACE, heart failure, and progression to DKD. In fact, there are mentioned of both glipizide and glimepiride to be initiated conservatively in CKD to avoid hypoglycemia. So hypoglycemia is a huge concern in the consensus report, and glimepiride is further mentioned as safe, CV safe. So main concern for sulfonylurea is hypoglycemia, and advantage is low cost. Of course, Carolina also showed that hypoglycemia is highest in sulfonylurea than comparing with other drugs. We cannot deny science and evidence. Of course, hypoglycemia is related to hypoglycemia. This is why, because it increases insulin secretion by closing the KATPase channel on beta cell plasma membrane. This is the basic mechanism of action of sulfonylurea, and that exhibits lower binding affinity to sulfonylurea receptor and higher rate of association and dissociation from the receptor. And this is a unique characteristic of modern sulfonylureas. Modern sulfonylureas more selective to beta cell. And cardiac myocyte does not abolish the cardioprotective response because they only inhibit circulaminal KATPase channel. So modern sulfonylureas have better response to hypoglycemia. Let's see. That guide study published in 2004 showed that gliclazide XR formulation 60 milligram was 2 times less hypoglycemic than glimepiride. And in this study, same guide study, they have shown when there is strict glycemic control of less than 7 HbA1c, gliclazide responds better, 3 times less hypoglycemic than glimepiride. Why does gliclazide is having this particular effect on hypoglycemia? Because gliclazide is an intelligent sulfonylurea by technology. It releases the right amount of active ingredient at the right time, ensuring least risk of hypoglycemia. This meta-analysis published in 2019. A recently published model-based meta-analysis, hypoglycemia risk was significantly lower with gliclazide, that also shown in evidence. So sulfonylurea is time-tested, very potent oral anti-diabetic, and now we have better options in sulfonylurea. So what about monotherapy? In this meta-analysis published in 2013, there was 31 trials with a mean duration of 16 weeks, and sulfonylurea monotherapy reduced HbA1c by 1.5% as compared to placebo. And when glimepiride 1, 4, and 8 milligram all examined separately, and they were effective and well tolerated. This was published in 1997, long back. And glimepiride 80 milligram controlled HbA1c in a greater number of patients with high baseline HbA1c than did 4 milligram. So this higher dose might be beneficial for those patients who are difficult to treat. And this guide study 2004 showed that gliclazide modified release formulation is as effective as glimepiride, either as monotherapy or in combination. So what about when it is added to metformin as a dual therapy? They actually complement each other, because sulfonylurea facilitates endogenous insulin secretion, and metformin facilitates insulin uptake by peripheral tissues and enhances glucose utilization in adipose tissue and intestinal tissue. So we should not think glimepiride or any sulfonylurea alone. Better they should be together, because they complement each other. And in this meta-analysis, where glimepiride, metformin, and linagliptin were examined versus linagliptin, metformin, and published in 2020 in Lancet, reduction in adjusted mean HbA1c were similar to the linagliptin and glimepiride groups, and the predefined non-inferiority criteria of 0.35% was met. And in the same study, that STAR study, where glimepiride metformin was compared with sitagliptin metformin combination, it was published in 2017. A 12 weeks mean reduction of fasting and plasma significantly more there in glimepiride group. And in the same STAR study, at 12 weeks, both treatment groups demonstrated a statistically significant improvement in HbA1c from baseline. However, the mean reduction of HbA1c from baseline was significantly greater in the glimepiride group compared to the sitagliptin group. So what about the durability? When we have added regarding durability, the addition of sulfonylurea to metformin had a lower risk of treatment failure compared to adding DPP-4 to metformin. Sulfonylurea metformin combination maintained 0.5% greater reduction of HbA1c compared to metformin, and it was durable for more than 5 years. And recently in Carolina also, we have seen HbA1c dropped very rapidly in the beginning with the glimepiride group. And that explains great efficacy of glimepiride versus DPP-4 linagliptin in bringing the patients to target in early treatment period, and also explains good durability profile comparable with DPP-4. And here the median period was more, study period was more than 6 years. So what about combination therapy of sulfonylurea, metformin, and basal insulin? What we use very commonly in our practice. The combination therapy of metformin glimepiride with glargine insulin resulted in a significant improvement in overall glycemic control when compared with other combinations like glargine metformin alone or glargine glimepiride alone. This was published in 2020 in a reputed journal. And this particular study also showed in this combination, lower insulin doses were required. So sulfonylurea is time-tested, very potent anti-diabetic oral agent with great durability. So why there is weight gain? It's another blame of sulfonylurea. Weight gain of sulfonylurea correlated with reduction in glucotoxicity. This could be attributed to enhanced utilization of ingested glucose and subsequent lowering of glycosuria. also because of anabolic effect of insulin, which is secreted here, there might be some weight gain when there is no glucose toxicity. And this Zodiac 39 study has shown when sulfonylurea used in combination with metformin, weight gain is non-significant. So it's better always to use sulfonylurea in a combination with metformin. That's what we are doing in our daily practice. So are the beta cell friendly? Yes, in this study, it is shown that glimepiride resulted in effective glycemic control without beta cell exhaustion versus insulin glargine. And this study, another study, and both are published in 2014, showed that long-term 5 years glimepiride therapy had minimal effect on beta cell function and improved insulin sensitivity. So what about the CV safety of modern sulfonylureas? Advanced study long back in 2008 showed 10% reduction, relative reduction of primary endpoint with intensive glycemic control with gliclazide XR formulation. However, advanced did not, that was not a formal CV safety study. So TOSC-IT also shown in 2017 that incidence of CV events was similar in sulfonylurea and pioglitazone as add-on treatment to metformin. Now comes the Carolina CBOT. It seems Carolina done for well-being of linagliptide, but favored more of glimepiride. Here, 633 participants of 43 countries used, and those participants were typically seen in clinical practice. On metformin was 83%, had 42% has established CV disease, and 37% displayed more than 2 CV risk. And hypertension was in 90% cases, microvascular complication was in 28% cases, and more than 50% had EGFR 60 to 89, and 18% were having EGFR 30 to 60. And they showed in this study we have seen glimepiride is as effective as linagliptin for achieving glycemic control. Further, this Carolina demonstrated non-inferiority of linagliptin for 3-point MACE and 4-point MACE versus glimepiride in participants with relatively early type 2 diabetes and increased risk of CV. Trials results concerning the CV safety of sulfonylurea were inconsistent before Carolina. However, Carolina helped to resolve the decade-long uncertainty on the CV safety of sulfonylurea, especially glimepiride. Those all are listed here. Is cost is a factor in our practice? Yes. In the majority of patients, the cost of diabetes therapy is largely out-of-pocket expenses and contributes to catastrophic healthcare expenditures. The cost-effective approach with the use of easily available and affordable anti-diabetic medications in type 2 diabetes is crucial and need of the hour. This is in an Indian study. Here shown sulfonylureas were the second most commonly prescribing drug across all groups of participants with diabetes in India. And here in this graph, we have seen the sulfonylurea market globally is keep on increasing from 2012 to 2030. So it is not been sidelined. It has always been there in our practice, sulfonylurea. And this is the UKPDS post-trial, which is published in the ongoing EHD 2022. The post-trial follow-up data of median follow-up period of 17.4 period showed that legacy effect of 43 years, 1970 7 to 2021 is still there, that legacy effect. Here, impact of intensive glucose control with sulfonylurea and insulin. And here in this study, 20-year intervention trial on newly diagnosed type 2 diabetes from 1977 to 97, when published in 1998 in Lancet, it is shown that microvascular complications and all disease-related endpoints are very much significant, but myocardial infarction and all-cause mortality was not favoring sulfonylurea treatment. But when legacy effect, we have seen that first follow-up study report has come, 10-year post-trial monitoring from 1997 to 2007, with the 16.9-year median follow-up period was published in 2008. in NEJM, we saw that myocardial infarction and all-cause mortality both are significant because of the legacy effect, and that legacy effect is continuing even after 43 years with a median period of 17.4 years. So, is there a place of sulfonylurea in the type 2 diabetes management? Yes, of course, it's there. So, key points are: it's very inexpensive, allow once daily oral dosing, reliably reduce glucose, and well tolerated and durable, and rarely cause symptomatic side effects other than hypoglycemia. But lesser hypoglycemia, I have shown there with modern sulfonylureas. We cannot deny science. Sulfonylureas are secretagogue and they're causing hypoglycemia. And we know that hypoglycemia is causing more cardiac mortality comparing its hyperglycemia. But for that purpose, we cannot deny our old friend. We require just extra few minutes counseling for diabetes education and hypoglycemia management education to our patients, and require correct patient selection, which is very, very important. That also emphasized in this consensus, that is ADA-EHD joint consensus. So here in the same ADA-EHD joint consensus, they have shown 5S approach to lifestyle is adopted. There is sleep, stepping, sitting, sweating, and strengthening. I believe in future, they will make it 7S approach. We will be adding stress management and self-care, particularly hypoglycemia management. It's very, very important. We just need to pay extra 1 or 2 minutes with the patient to explain what is hypoglycemia and how to manage. Why to blame sulfonylurea? We must blame ourselves. We are not giving time to our patient. Thank you. And this is the spectacular main key in my place, in my state, Tripura. So please come here. I am not a very good organizer. I cannot organize like Dr. Arvinda and all of you. Please be my guest. Come to my Tripura. Thank you.
Thank you so much, Dr. Ghosh, for an elaborate overview of the sulfonylureas. And I think all our speakers have clearly established that where the newer molecules are here to stay, the older generation molecules, in view of the epidemic of NASH, as well as obesity, as well as legacy effect, I think what we need to do is, as we are changing from glucocentric to patient-centric approach, we need to really incorporate our age-old Indian values of a joint family, where we need young blood, but with the blessings of our older generation. So with that, I think we can conclude this session in view of time.
Thank
Dr.
you.
Shweta?
Thank you.
Yes.
On behalf of Dr. Arvind Diabetes Center and ADC International Virtual Diabetes Summit 2022, I wholeheartedly thank Dr. Shefali, Dr. Harish, Dr. Akash Kumar Singh, and Dr. Basab Ghosh for being a part of our conference. Thank you so much for your time and presence. Thank you so much. Thank you so much.
Thank you. It was a
Thank
pleasure.
you, sir. Thank you. It's a pleasure, really. Thank you.
Thank you so much. We'll move on to next session. Over to Dr. Shweta, please.
Yes, sir. Thank you, sir. Thank you, speakers. It was a wonderful session. Thank you. And let's move on to our next session. Session 6, which is the chairpersons here are slides. Okay, I would like to introduce the chairpersons of the next session. And very good afternoon. I would like to introduce the chairpersons of the session. Dr. Kirti Suta, MBBS, DHA Fellowship Diabetes, Consulting Diabetologist, Physician at Dr. Marcus Diabetes, New Delhi, famous diabetologist. Welcome you, ma'am. And I would like to welcome Dr. Amit Nagate, Chief Diabetologist and a food care expert at Nagati Diabetic and Food Clinic, Life Multi-Specialty Hospital, Aurangabad. Welcome you, sir. Over to the chairperson.
Kirti ma'am, you can proceed further, please.
Kirti ma'am, your voice is not audible. No, ma.
Am I audible?
So you're audible, sir. Ma was not audible.
Fine. We'll start the session.
Yes, sir. Please, sir.
Yeah.
Yes, sir.
Good afternoon. First of all, on the offset, I would like to thank Dr. Arvinda, sir, for letting us be a part of this prestigious conference. And we'll start with the session. We won't waste the time because we are already 10 minutes behind the schedule. We'd like to introduce our first speaker, Dr. Abhijit Bhojraj. He's a DM endocrinologist, 15 years practice in rural area, which is really a big, what we can say it as an asset, like practicing in a rural areas. He's a chief consultant endocrinologist at Padma Shri Dr. Dr. B. Ramarao Clinic and Manipal Hibli. Then he's a co-founder of 7 Sugars diabetes management platform using IoTs sensors. Conducted over 400 free diabetic camp in Belur, the village. Over 3 lakh diabetic free patients have been he has diagnosed and treated. He's a faculty trainer for Abbott AGP Academy. Over to you, sir.
Thank you so much, Amit sir, and thank you, Dr. Arvinda sir, for giving me this opportunity. It's always a pleasure to see you, and it is an honor to be part of such a great program. So I'm starting off my topic for today, and this is a very interesting topic because thanks to the pharma industry, we are now dealing with so much of competition when it comes to this particular molecule, and it's I think now when SGLT2s have taken a kind of a backseat right now, and the focus now is on DPP4 inhibitors. So my main concentration today is to talk about what we don't talk about when it comes to DPP4. And we are part of today's kind of like a debate. The nation wants to know what the DPP4 brings to the table. So this is my agenda. I'll be looking at the pathophysiology, and I'll concentrate briefly on the metabolic actions. But my main focus on today will be what is the aspects of what this molecule brings to the table when it comes to durability, variability, and A1C. And I'll end with the CVOT outcomes. Well, this slide has been shown multiple times, and why it is important to all of us when we manage diabetes is because the concept of pandemic is now very, very imprinted in our minds. And when you talk about what learnings we have as a country and how we are managing our diabetes, it is going to become a big, big burden and a big, challenge for all of us. And if we are all not putting our minds together and focusing on this problem, the problem being A1C control, it is going to become a big issue from a financial aspect for a family and from a country perspective. When you look at on the left, it is data that is coming in from multiple labs. So this DCI index taken the HbA1c data from all over the country from different labs, and they've calculated the average A1C according to location. And you can clearly see none of any part of any part of the country we are not hitting our targets. And on the right, this is data which is done by a study, ICMR India B study, which is looking at self-reported data. Here, in this self-reported data, almost around 60% of our country is not in the targets that we need to achieve. So all in all, when you look at multiple studies, it is anywhere between 60 to 80% of where we are dealing with this burden. And now to set the stage for the molecule. So we all know DPP4 is basically a serine protease, which inactivates the incretin peptides, the GLP-1 or the GIP. And by doing so, it it modulates postprandial hormone secretion and regulates the glycemia. They also have non-glycemic effects which control the progression of inflammation, which is mediated through direct protein-protein interactions. And there are non-catalytic activities also which kind of regulate non-alcoholic fatty liver disease, obesity, and in diabetes. So the main crux of these problems are inflammation. And when you have a molecule that is looking at regulation and suppression of contributing factors to this disease, it is an important point. And what we fail to look at is, we don't address this chronic subclinical inflammation that is happening in our journey of diabetes. And most of the time, this is happening even before the onset of diabetes has been recognized. So when the DPP4 activity can be seen widely and in multiple organs, and such as the kidney, spleen, heart, everywhere, even the skin as well. So it is expressed in high levels in endothelial cells. It is differentiated epithelial cells and immune cells such as T cells, dendritic cells, and macrophages. So not only are we looking at it from an organ standpoint, we're also looking at it from a molecular standpoint. And present in plasma as a soluble form, and this soluble form can be released by proteases, or it can be released by means of vesicles. So that is how this molecule is released. So to concentrate on this very, very important slide, and I'm sure today it had been presented multiple times, but my main point of what I want to show in this slide is the role in which we are choosing the molecule and the role it has on multiple pathophysiological processes. When you're looking at the famous Omnis Octet study by DiFranco, clearly defined all these problem areas that lead to hyperglycemia. And what we want to show here is we want a molecule that affects multiple processes and non-seen processes. So in the next slide, I will tell you about the non-seen processes which lead to inflammation and other challenges that we see in diabetes, which is definitely cardiac disease. Now we are seeing NASH as a big component, and other dysregulatory factors that happen to multiple organs because of hyperglycemia. So when you have this DPP4 expression on multiple levels, almost 6 out of 8, when you include metformin also into the mix, it is giving you that kind of added benefit, whether it is direct or indirect, when we are talking about the pathophysiology of diabetes. When we talk about the metabolic actions, again, this is usually not seen or spoken much about when it comes to the DPP4. It can be protein interactions or catalytic actions that this process has on multiple tissues in the adipose tissue, macrophages in the liver, with regulation of insulin resistance, fibrosis, and lipid metabolism, pancreatic hormone release, T lymphocytes, macrophages, again, directly affecting the inflammation chemotaxis in the kidney, directly affecting hematopoiesis, the NK cells, eosinophils, and basophils. Again, we are seeing this action of this molecule. To start off a little bit about the immune cells and how it is regulating by DPP4. When we look at the in human subjects, the DPP4 is expressed predominantly by the T cells. And what we have seen in animal models, it is expressed in the dendritic cells, B cells, as well as the NK cells as well. So when the DPP4 is, when they did a study with the treatment of TNF alpha and insulin, they found in this study, the atherosclerotic plaque, which were already in this high-risk group, identified the DPP4 elevation in on the monocytes. And again, these level of DPP4 was directly correlated with the plasma TG and cholesterol levels. The significant portion of circulatory DPP4 is seen in the bone marrow, and it's derived by, it is considered to be an essential reservoir of soluble DPP4. So on a molecular level, with regard to the immune system, we are seeing all these changes, and our learning are from animal and mouse studies. So when we're looking at severe cases of immunodeficiency, when in the studies that were done, or irradiated mice, the number of lymphocytes in circulation also were directly correlating with the DPP-4 levels. And RNA sequential data that identified DPP-4 as one of the factors produced by the adipogenic marrow cells. And again, this is also giving us, the basis of where and extent this molecule can go. When we're looking at sitagliptin studies that were done, 90-day studies, there was a shift towards osteogenic progenitors in the tibia. Again, they were looking at directly from the marrow to see the changes in the immune cells with relation to DPP-4. When moving on to the adipocytes, and here the expression activity have been consistently associated with obesity. And here it is directly linked to the body mass index, excess adipose tissue, what they saw increased expression. Leptin concentration with the size of the adipocytes in both visceral as well as subcutaneous deposits of DPP-4, they negatively correlated to the DPP-4 levels. And when you're looking at mouse models where they eliminated adipose tissue, DPP-4 triggers had a beneficial effect on tissue remodeling, improved hepatic insulin sensitivity, and diet-induced obesity. In addition, and these were mouse models which were fed with high cholesterol diet. So recent DNA and RNA sequencing, they showed that the presence of this intracellular addition molecules and in the pre-adipocytes, and the decreased expression of DPP-4 was seen in early steps in adipocyte differentiation. So this is again directly linked to the whole aspects of obesity, and what point we are trying to say when they were studying the expression or of DPP-4 in multiple levels and in multiple animal and mouse studies. Obesity is rampant, and again, when we are not addressing these factors, these subclinical factors that are happening consistently in most of us, then the disease progression is definitely going to be on a higher level. Same with even studies when they did with sitagliptin. 100 mg of sitagliptin was studied in multiple patients for over a year, and the biopsies done in such cases showed reduced steatosis, ballooning, decreased AST, ALT, and overall histological scoring in NASH. So we need a molecule that is looking at it from inflammation, looking at it from the progression of prevention of obesity, and improving other metabolic parameters apart from glycemia. So the focus has to shift, and a molecule should be able to do all of these things in order for us to address the vast complexities what we are seeing in our diabetic population. So comparing now the top 4 DPP-4 inhibitors, how does it act? And so the interaction it's a substrate in Saxa and in a competitive inhibitor in Lina. So how does this affect the molecule? The way the binding sites, again, when it is fast or in fast and tight, like in vildagliptin, the binding is for a longer duration, even though the half-life of the molecule is much less. And so the dissolution is much more slow in Vilda, Saxa, and Lina, and it is fast in sitagliptin. So we all know the overall half-life, around 8 to 24 hours of 100 mg. Now we have Vilda in a sustained release 100 mg as well. So this is also giving us almost 8 to 24 hour effect. But the main point in what we want to highlight in this slide is the amount of DPP-4 inhibition that we see. And you see most of the molecules in a 24-hour period has greater than 80% what we are seeing in all these molecules that we are looking at over here. So and when you look at glycemic efficacy, that is all that is required. You need around 80% over 24 hours. You do see that similar kind of overall A1C control, even though we are dealing with it. So as a class, it is all of it is relatively the same. Now moving on to the next part of why this molecule makes a difference, I'd like to present a particular case. This is a 48-year-old lady. Duration of diabetes of 3 years, presents with history of weakness on and off. Her A1C over the past 3 years is around 7.5 to around 8.3 is what we are looking at. She is obese, almost BMI of around 27, higher levels of cholesterol also seen. Poor glycemia, again, indirectly linked to multiple aspects. So she is a classical example of what we want to address on a multiple molecular level as well as glycemic level when we want to use this molecule. And the main point I want to now start to establish is the concept of glycemic variability, durability. So when we talk about glycemic variability, it's basically defined as the variations, the highs and lows that we have in a glycemic profile. And the challenge with HbA1c is half the time we are not getting the complete story. And when you look at an early diabetic population of anywhere between 5 to 10 years duration of diabetes, we are dealing with anywhere depending on glycemic control. But if they have A1C of 7.5 or 8, most of the time they tend to ignore their levels because they are often asymptomatic. And that is the exact point. When we are trying to fight diabetes, we need to be addressing this variability right from the start. So when you look at these 4 profiles of these individuals, pretty almost similar A1C except for this variability. Here you're seeing higher glycemic exposure with minimum variability. Here you're seeing high glycemic exposure with high variability as well. Here you're seeing a normal A1C. So these are 2 profiles with the same A1C of 8, and here there are 2 profiles with the same A1C of 7. Here in this 3, there is highs and lows which are consistent, and here it is a more stable profile. So amongst all the profiles, we would like to choose somebody with 4. And the next point that we need to say, we need to start to look at technology more differently. We need to start using CGM more importantly in our in every diabetic population, because this is what we are going to be missing. We'll think that the A1C is good at 8, but the variations are quite high. So the point here is the changes, the story is not told with only the A1C. So this is a profile.
Adam, sir? Yeah. Adam, sir, last few seconds to conclude your slides, sir.
Yes, madam.
Yes, sir.
So the point here in this particular case is the amount of variability. And before we started, so this is her 15-day profile, estimated average around 7.9. Variability again 30%. We need to be hitting at around 20, and time in range around 70% is what we need to achieve. So higher glycemic exposure, chronic sustained hyperglycemia, acute fluctuations again are leading to complications. When we talk glycemia, the hypoglycemia, the set points in which we feel hypoglycemia is much more challenging in most of our cases. And with high glycemic variability, definitely inflammation, oxidative stress is on the rise, and that is the reason for any variation that we are seeing with the diabetic complications. So we need to address this early, and with what data that we have with DPP4s, we have seen data with regard to the variability, and all of it is in favor of a DPP4 than any other molecules. Here we're looking at a study which looking at diabetes variability, looking at combination of non-glucose dependent and glucose dependent mechanisms of treatment. Here we see much better overall A1C control from baseline, reduction of hypoglycemia. They're in a euglycemic state for a longer duration, lesser nocturnal hypoglycemia in such therapies which are incretin based, and glycemic variability from not only from a day, but also from a day-to-day profile, but also for a longer duration, it is much better. Next point is durability. Again, the Verify trial gives us all the evidence that is there for us to see the benefit of what we are looking at from a DPP4 molecule, and almost 49% risk reduction for treatment failure greater than 2 years of variability. And even the subgroup who didn't achieve control after add-on therapy, almost 26% risk reduction. Same with even sitagliptin. Are we seeing the same results of durability? The answer is yes. Here it is with monotherapy, almost 41% of patients achieving the goal. And with metformin combination, almost 66% of patients achieving their goal of good A1C control of less than 7. When you look at overall comparison head-to-head, pretty similar all in all with regard to all the DPP-4s, we do have good A1C control. And when you look at the main aspects of cardiovascular safety, all the CVOT trials that we have seen from TCOS, Carmanilla, and Examine, all of it gives us the confidence that this molecule does not contribute to heart failure events. Even though severity gave us that little bit of a scare, but there are enough and plenty of evidence for us to look beyond. So now moving on to the same profile of our patient, after 6 months, her levels have averages around 120. Variability is much better. Time in range is 99%. So when you have a molecule that can give you all these advantages and you have the technology to assess what is required, that is where we need to move the focus of our treatment management. So this is a compilation of around 20 cases who are from our center, and all of them have been on different DPP-4s. The main advantage point is having a time in range of greater than 80%. If you can achieve 90% with lifestyle modification, that is where we are going to make a shift in this whole fight against, diabetes. And in a pandemic, we need to be on a war footing. And that is what we need to achieve. Using the right molecule, using it early is the key point, and is my final statement for this presentation. So thank you all for your patient listening, and over to the organizers.
It was a great lecture, sir. You have pointed out rightly on the timing range, what exactly is to be there, what kind of shifts has to be there. The four figures which you have shown, the glycemic variability and this thing was really a very good, interesting talk. And the concept of your immunological modulation was really a great one. Nice to hear it, sir. Thank you for your presentation. Hand it over to Kirti ma'am, please. Ma'am, you are not audible.
Ma'am has messaged us saying that since there is a heavy rain, so there is a signal problem, she said. So would you like to take over the thing, sir?
Yeah, fine. I would like to introduce our next speaker for today, Dr. Arundhati Dasgupta. She is MD, DM, FAP. She has presenting designation as Senior Consultant Endocrinologist. She has done. She has received AV Gandhi Award in 2012 for Best Thesis. Diabetes Awareness Initiative Award in 2018, Young Achiever Award 2022 National Congress of Diabetes, course coordinator for PHFI and several other teaching institutes, other national and international training programs. Over to you, ma'am, for today's lecture.
Thank you so much. So good afternoon, and thank you to Dr. Arvinda for inviting me over for this wonderful conference. It's a mammoth conference with so many topics. And I'm also very happy that he chose this particular topic for me. It's a very interesting topic and something that I was really thinking about. The concept of CVOTs in diabetes. These days, we're only talking about CVOTs. But we have also understood that CVOT concept has changed over a period in time. And the question today being that do we really need these CVOTs for our, the molecules in the diabetes treatment armamentarium? So we'll start off with this, and I would like you to have a look at the figure. This is where I stay in Siliguri. That's at the foothills of the Himalayas, and this is a picture taken from Darjeeling. And we'll talk about this picture later on after the end of the presentation. So when we talk about CVOTs, let us look at what was the traditional FDA specification for anti-diabetic drug approval before the CVOT era, right? So we had a number of molecules come up after, as you can see, from the sulfonylurea stage, and then we had the AGIs, the thiazolidinediones, the cholesevelam, bromocriptine, and others. And that's where, over a period of time, we were getting a number of molecules, right? And because of the growing prevalence of type 2 diabetes and the awareness of its cardiovascular consequences, that led to a significant increase in the number of drugs that were getting approved for the treatment of hyperglycemia. Now, these drugs were granted regulatory approval on the basis of small studies, and that usually these studies were based on the reduction in HbA1c concentration. So the improvement in terms of the microvascular disease were there, but these were just surrogate areas, and they were generally underpowered and of insufficient duration to show any particular effect on microvascular and macrovascular complications. Here, what the sponsors had to do was that they had to submit the phase 2 and the phase 3 trial data on at least 2,500 subjects, of whom at least 1,500 should have been exposed for more than a year, and at least 300 to 500 should have been exposed for more than 18 months. The endpoint was HbA1c reduction, right? And after these were, inculcated in the study, they were used as investigational agents as monotherapy or add-on therapy. But then gradually we were seeing some things for which we were not prepared. Instead of a reduction in the cardiovascular risk because of the reduction in the HbA1c, we started seeing trends towards increased risk of cardiovascular events. So that was seen with the tolbutamide, and then it was seen with the miraglitazar. But it was only after the identification of an increased cardiovascular risk with rosiglitazone post the study that the general regulatory reassessment to the industry sponsors was started. And once that was done, there was a new guidance for the industry now, which was adopted by the FDA in 2008 and the European Medicine Agency in 2012, where they said that every drug that was used for glucose lowering would have to be evaluated for cardiovascular safety. So now we had a new era. And what were the salient points in the FDA guidance issued in 2008? So they said we must have a trial outcome that must exclude the hazard ratio by 1.8 if you got the study done pre-approval. If you could not prove 1.8 hazard ratio, then you would have to prove at least 1.5 and have another post-approval study which would exclude a hazard ratio of 1.3. Number 2, patient selection would have to be a high-risk population, those with advanced cardiovascular risk and elderly. Duration at least 2 years, and they would require cardiovascular events like mortality, MI, stroke, or other cardiovascular events like hospitalization for ACS or urgent revascularization procedure. And it would be in a blinded independent process. After doing this, once they started off with this, what were the differences with the original, the older trials like UKPDS or ACCORD or ADVANCE? Now, if we try to understand about any trial which is reporting a composite of cardiovascular points, that's called a CVOT, right? CV cardiovascular outcome trial. That can be a trial which is reporting cardiovascular outcome according to the treatment goals, depending on an intensive arm and a less intensive arm like ACCORD or VADT, or as a part of the total outcome like UKPDS or DCCT, or looking at HbA1c goals and specific drugs like ADVANCE and BARI-2D. Or you could have, in these trials that we just quoted, the cardiovascular events would happen, that would occur during the course of the trial was seen. They were not pre-specified. They were not centrally independently adjudicated. So naturally, the subjects were younger. They were of low CV risk. The study period was shorter. And the number of CV events accrued during the course of the trial would automatically be low. So because of the low events and the lack of independent education, therefore the estimates of the CV safety was poor. Now we had the next category where we had the trials looking specifically at cardiovascular safety. We start from SAVOR, TEAM, TCOS, EXAMINE, ELIXIR, LEADER, EMPAREG, and all the others, CANVAS, SUSTAIN, and all the others. Or you could have CV outcome of 2 different agents like Carolina, DEVOTE, and TOSCA-IT. So because these are specifically for cardiovascular safety outcome trials, they can be called CVSOT as opposed to the CVOT of the previous trials. So how do they generally differ? Number of patients are much higher. Duration is higher. The background glycemic therapy is flexible here, but it was not flexible in the glycemic efficacy trial. The comparators are usually placebo here, excepting for Carolina, Devote, and Tosca-IT. And inclusion factors were people with high CV risk factors, unlike the glycemic efficacy trial, where they were mainly including patients with low CV risk factors. And primary outcome, very categorically here, was the composite of the major adverse cardiovascular events, or MACE. So what information can be got from these CVSOTs? They're basically to prove non-inferiority and later superiority if the non-inferiority criteria is met, establish the cardiovascular safety of the drug. Events are pre-specified, centrally adjudicated, uniformity of reporting, and event capture across multiple sites. Apart from the cardiovascular safety, what are the other tangential benefits that we got? These studies, because there were a large number of patients who were being studied, so there was an opportunity to study the rarer adverse effects of these drugs. Beyond the CV outcome, some of the trials, like say TCOR or SAVOR-TIMI or Examine, they gave us insights about pancreatitis, pancreatic cancer, renal outcome, fracture risk, malignancies, or we also saw certain other exploratory endpoints like calcitonin levels in leader, NT-proBNP in SAVOR-TIMI, and fracture in CANVAS. We also started looking at glycemic control with important consideration on minimization of weight gain and hypoglycemia. Overall, these CVSOTs basically have sensitized us diabetes care providers to the opportunities for multifactorial and comprehensive diabetes care while bringing the sugar levels of the HbA1c down. So we have had that many trials in the period from 2008, and then from Examine and SAVOR-TIMI to the Deliver. We've had that many trials here. But while we were in the process of doing these trials, we had this trial results, the EMPA-REG, which completely changed the way we started looking at these trials. So we were looking for CV neutrality, and this was a trial which was telling us about CV benefits and huge CV benefits in terms of 3-point MACE, cardiovascular death, all-cause mortality, hospitalization for heart failure, and even nephropathy. So after this, what started to happen was, while we had started off like, they were wondering, the investigational drug, will it pass the test or not? Now the entire family of these investigational drugs now were like looking at something completely different. They were talking in a different term altogether. So not only are we neutral, we are giving you so many other benefits. So once they did that, we saw the CV safety to CV efficacy in atherosclerosis. We saw it in heart failure with so many of the trials, from EMPA-REG to DAPA-HF and Credence and Emperor preserved and Emperor reduced versus CV, all of this, and even the renal parameters across so many trials, as you can see, has been shown out here. So this was a complete paradigm shift in the way we were looking at the CV outcome trials today, which is why this old, the guidelines, the flow chart completely changed to become what it is today. Completely individualization, differentiating people based on their cardiovascular risk and deciding on the therapy based on that rather than a common flow chart for everybody. But these cardiovascular safety outcome trials also have drawbacks. Remember, because they have strict entry criteria, elderly people, high-risk people, they are not studying a population similar to the spectrum of subjects that we are seeing in our practice. Not every patient that we see belong to that category, right? So therefore, translating the results of these studies to the general community is something that, well, whether that should be done or not is something that has to be thought about. Secondly, some adverse effects have surfaced after post-marketing surveillance. For example, the diabetic ketoacidosis with the SGLT2 inhibitor, that was in the post-marketing program. So we were not aware of this earlier on. Also, because the comparison is to standard of care, and standard of care is not something that has had CV, track records, neutral CV track records, say sulfonylurea. Sulfonylurea, of course, now it has, but say the other drugs, because prior to this we did not have CV neutrality trials. So is it you're comparing it to standard of care where they did not have the trials done? So is it the right way of going forward? The true CV benefit of bringing down the HbA1c is not delivered by CVSOT. And as we said, the possible beneficial result cannot be applied to a population. I am using empagliflozin based on the EMPA-REG trial in a younger group of type 2 diabetes patients. This population is not the population which has been studied, which we just said. Sometimes potential mechanisms cannot be explained to be are not available to explain the results, say in EMPA-REG, the benefits. We did not really understand what was the potential CV benefit coming from. We have hypothesized, but we don't really know. Very importantly, we see the composite outcome. Now, when we look at the composite outcome, there could be one point which will be driving the composite outcome much more than the others, which, for example, happened in EMPA-REG. The CV death point was, the benefit was much more as compared to the non-fatal MI and non-fatal stroke, which was increased. But all in all, when we said that the primary composite outcome came down. So, for example, in the EMPA-REG Preserved, you had the hospitalization for heart failure driving the results in the primary composite outcome, whereas the CV mortality benefit was not there. But when we're looking at the result, we're looking at it as a whole. So is that the right way of looking about it? Also, very importantly, remember there are operational and technical challenges, huge ones. Cost, the major factor being cost. Taking a new therapy from discovery to market may exceed $2 billion in total, and the phase 3 registration trials alone cost hundreds of millions of dollars. So this money will have to be paid by somebody someday, right? So who is ultimately paying this? And because it involves such a lot of cost, this is a disincentive to the development of newer treatments. So thus, ultimately, there'll be fewer options for patients with diabetes mellitus. And what has been seen is that there has been a 50% decline in the trial initiation for type 2 diabetes over the past decade as compared to the oncology finding. And that is partly because of this. So draining of resources, delaying drug development and approval, the escalating costs of the CVSOTs are leading us there. This also involves large number of subjects, investigators, lab shipments, randomization, temperature control, and that's why the sponsors selectively choose trial-friendly countries. But where these drugs are being eventually used are not necessarily the countries where these have been studied and might not translate into actual results for that population. Ethnic variation, very importantly, not studied. And because there are such long duration studies, patient retention, changes in investigator staffing, these are very, very important logistic areas which are of problem. Now the question, given the absence of any convincing signal of increased MACE in all the trials conducted since 2008, do we need to continue conducting CVOTs for anti-hyperglycemic agents anymore? For this, what was done, the questions were asked, is there any signal of harm? Generally, we did not see any signal of harm in doing these tests. We saw benefits. Are the current CVOTs generalizable? We know the answer to this. They are not generalizable to the type 2 diabetic population. Is it ethical to withhold EMPA, LIRA, CANA from the control arm who are equally at risk for because they are the high risk cohorts? So are we doing the right thing and holding it back? And if we decide not to hold it back, what is the impact of allowing, say, I want to study EMPA in one arm and I'm putting LIRA in the other arm, so both having benefits, and then I'm going to compare it. What happens? The sample size goes up threefold. The cost and everything logistic involved with it also goes up threefold. What is the impact of allowing the use of proven effective therapy in the comparison arm? That is what happens. And should they be undertaken for primary prevention? We know that a number of trials have failed when you looked at the primary prevention, like LEADER, like SUSTAIN, like EXCEL, So where should the FDA go from here? Should we go back to the pre-2008 approach? Should we demand outcome trials only whenever there is a safety signal involved in phase 2 or phase 3? Or if the sponsors want to put a label indication that this is for heart failure, only then prove it? Is that what should be done? So the 2018, there was a lot of talk about this. And because of this, the advisory committee met again. And there was a 2018 think tank. So they discussed whether an unacceptable increase in cardiovascular risk any longer needed to be excluded for all the drugs to improve glycemic control. So the voting was, as you can see, 10:9. It was a very marginal voting, but it was voted 10:9 to continue the guidance recommendation to exclude unacceptable increases. And in fact, the think tank said recommend at least one powered CVOT with outcomes that will include others like heart failure, kidney disease, to ensure absence of unacceptable increase in cardiovascular risk. So rather than stopping the requirement for this, what they have done is they've changed the pattern. They said do a longer study, consider study drug therapy as monotherapy, expand to include heart failure and renal outcomes, not 1.8, keep it at 1.3 non-inferiority. Put an active comparator head-to-head. Instead of the traditional RCTs, do a pragmatic design, with clinical event education reporting. Instead of the homogeneous study population, go for a heterogeneous population, women, minorities, elderly. And because of the low usage of the study drugs in the real world, implement programs to improve the care broadly. So can there be any improvements? A lot of suggestions have come forward. Number one being, please add something to the 3-point MACE, add others. And that has been done also in some of these. Say, look at reversible ischemia, look at urgent revascularization procedures, look at the echo findings. But the increasing components of composite will again increase the event rates, shorter trial, but reduce the precision of the study. CV biomarkers, again, have been put forward, have not been taken up because they might not always translate into positive heart outcome. Longer follow-up, again, resource intensive, regulatory sponsor, financial, technical collaboration. So all in all, where do we stand today after, from 2008 to 2018, where a rethought was given to where we stand today, 2022? Where we see it is and how we see it is that CVSOT is definitely gold standard for establishing cardiovascular safety, but they are not done to evaluate the glycemic efficacy of a drug just to understand whether there is an increase in the cardiovascular outcome. They are multi-centric, involve significant logistic and operational challenges. However, we must also acknowledge that they've given us extremely valuable information much beyond CV safety. So probably a more cost-effective approach to cardiovascular safety, assessment of these agents, balancing costs and benefits would be the ideal way forward. But this is just a statement. How do we go about it is something that would need to be planned. And again, thought and rethought by the bodies who take the decisions in these regards. So I'll end it with this. Last week, I was in Darjeeling and I was just looking out through my window and I looked at this sky and it was looking so beautiful and bright with the clouds and the blue sky there. And I moved my curtain a little more and what I saw was, wow, that was Kanchenjunga, that was visible. And as I opened the entire screen of the window, this was what came out. And it's very much like the CVOTs today. We were looking for a little bit. We've got so much more. But even now, the peaks of the Kanchenjunga are blurred by the clouds. We are hoping that the clouds will also go away and we'll be able to see the entire picture in its totality with future benefits, which will be even better than what we have seen today, so that we will ultimately be able to give a fruitful treatment to our patient, which takes care of not only the HbA1c, but also all the other microvascular and the macrovascular aspects. On that note, thank you so much.
Excellent talk, ma'am. Thank you. Thanks a lot. It was really very good insights regarding various trials which have been conducted, the guidelines which have been there, the odds and evens, and what kind of things has to be come up, which the doctor which is going to prescribe, what kind of thing he has to keep in mind while he reads the trial, the approach, what he has to be there. Because sometimes what happens is the pharma says something and the doctors just accept it and write it across. So the guidelines has to be very clear. The understanding of the papers, the presentations has to be very crystal clear. And thanks a lot for ma'am. It was a really insightful lecture. Thanks a lot, ma'am.
Thank you.
We'll move on to our next lecture.
Yes, sir.
Yeah. The next talk is really another an interesting talk, really a unique topic to come upon. To present that talk, I would like to call upon Dr. Dinesh Agrawal. He is head of the Department of Medicine in Marwari Hospital, member secretary, Hospital Ethics Committee, Marwari Hospital, chairperson elected, RSSDI Assam chapter, the course director, advanced certificate course in diabetology, Then he is a scientific member for Northeastern Diabetic Society, Honorary Treasurer, All India Association of Advanced Research in Obesity, Assam chapter. He has got he's a faculty in both national and international, regional and national fields in various diabetes as well as medicine. Awarded a best time in Interest and Diabetes Association. I would like upon Sir to start his talk, please.
Thank you, Dr. Amit. Good afternoon, one and all. I thank Dr. Arvind for giving me this opportunity for this topic. And this is, as you said, it's a wonderful breaking. Once when I received this talk to give, I wondered, and I have to search a lot of things for this. My topic is sitting is the new smoking. This word phrase is first coined by Dr. James Lewis when he was interviewing himself to the Los Angeles Times. Now, let me paint a picture. We are in this conference room. The meeting is for more than 4 hours, and you have been sitting there for the whole time. You spend time crossing and uncrossing your legs, swiveling around, adjusting your positions, maybe a neck roll or two. Your muscles are getting stuck. And you are thinking, when will this meeting end? This usually happens to all of us. So why do we probably feel exhausted when we are not doing anything but sitting? That's because our bodies are not made to sit all day long. Usually, if we start from the morning, we sit at breakfast, then we land up into the office, we sit there to commit our work. We sit an average of more than 7 hours at work. We sit at dinner in front of the TV. So we sit a lot of time. A study conducted in 2017 by the American Heart Association has found that sedentary jobs have increased by 83% since 1950, a huge jump. And the employees in their office spend more than 89% of their time in sitting. The COVID pandemic has added to this increasing trend. Many people now work from home. They are very difficult. They do not require to get up from their couch to do their works. So this is increasing day by day, the sitting increasing. This is a study which was published in 2010 in Exercise and Sports Science Review, where they say physical inactivity and its risk. It leads to the higher rate of morbidity and mortality in various studies. We possess the unique health risk factors, which we discuss in subsequent slides. There are changes in physiological effect on our metabolism, physical functions, and health outcome. And more of sitting and less of physical activity are associated with the all-cause increase in mortality, increase in obesity, high blood pressure, elevated risk of type 2 diabetes mellitus, along with various adverse metabolic profiles. Now, question comes, what evidence do we have? This study, a meta-analysis by Dr. Vishwas et al. Says that, and which was published in Annals of Internal Medicine, says that prolonged sedentary time was seen to be associated with deleterious health outcome regardless of physical activity. No amount of marathon helps. Thus, if you do only limited marathons and do sitting all the time, this will not help. This association, which has seen all-cause mortality, type 2 diabetes, and CVD incidence, and these were adjusted for physical activity. What we can see, majority patients who are on sitting, they are at the high risk for the all-cause mortality, type 2 diabetes mellitus, and CVD incidence. This is another study which was way back published in 2012, where more than 2 million Australian adults were seen, and they have compared sitting time with the all-cause mortality. The study concluded that prolonged sitting remains a risk factor for all-cause mortality. They suggested that public health program should focus on reducing sitting time in addition to increasing physical activity levels. These cartoons compare the physical activity in minutes per week versus days per 1,000 persons. Here, they're divided into 4 groups. Persons who are sitting from 0 to less than 4 hours per day, 4 to less than 8 hours per day, and 8 to 11 hours per day, and persons who are sitting in the black more than 11 hours per day. What we can derive from this, inactive participants with higher level of sitting had the highest mortality rate. Just a minute. With the highest mortality rate, there is a strong relationship of the increasing sitting time to the mortality persists even among participants with relatively high levels of physical activity, like those who are in between 4 to 8 and 8 to 11. Those who are less of sitting have more benefit. So higher sedentary time is seen to be associated with the greater risk of cardiovascular disease. It was a meta-analysis by Ambrish Pandey et al. Moving to the. So this slide again, which are the pooled estimate of the hazard ratio for the cardiovascular diseases, say with the studies from 2000 to 2010, and it's found to be the higher risk when the sittings are high for the cardiovascular disease. The study concludes that excessive sitting time has almost double the risk of type 2 diabetes mellitus. It has also shown the increased incidence and the mortality with associated with the other chronic common illness by 10 to 20%. And in terms of the absolute risk difference, this corresponds to an excess of around 33 CVD related deaths, 27 cancer related deaths, and a huge 610 incident case of diabetes per 1,000 persons per year in persons with the highest volume sitting compared to those with the lowest volume of sitting. Now, the sedentary behavior is also related to the risk of depression. A meta-analysis by the Long Jai says reducing sedentary behavior should be advocated for the primary prevention of depression. These are the pooled estimate from the 2003 onwards that shows that it is anxiety and depression is associated with the more of sitting pattern, more in female in comparison to the male. Now, what actually happens when we excessively sit? It causes muscle abs. Like if we don't engage our core muscles by sitting all day, they become weak. It also affects the brain. Moving muscles, as we all know, pumps fresh blood and oxygen through the brain and trigger the release of catecholamines and endorphins and all sorts of brain and mood enhancing chemicals. If you don't move, the spine do not move, and it becomes inflexible and susceptible to damage the back strain. So we have a spine problem. The weight bearing, the hip and the lower body bones, to grow stronger, it needs to move. So inactivity does not promote bone growth. So there is a weakness in the long bones. And if you don't move, we all know muscle burns less fat, and there is a less blood flow from the heart disease, leading to the more of the heart disease. This episode, this was the media headlines in 2012, and there is a new stories with new smoking or the bad as smoking has increased by 12 to 13 folds from 2012 onwards. So, is sitting is really the new smoking? How do we quit? It's very simple and logical solution. We should need to get up and move. For better health outcomes, to reduce stress and improve productivity among workers, we should program like this that should be more of walking than sitting. It has been seen that the study again conducted by the American Heart Association, which said that physically active jobs now make up less than 20% of the US workforce, down from half the jobs in 1960. This shows how compared to older generation, most Americans no longer works job that requires them to be active. The population is increasing, become less active, and it has been seen that a study conducted in 2019 by the American Heart Association, they says that in between 2001 to 2016, there is a 25% increase in sitting by the Americans, and there is a reduction of around 35 to 45 minutes of active life by the Americans. And there are studies where it has been seen that if we increase our sitting or reduce our activity by 45 minutes per day, or we increase in the reverse way, our life expectancy, if we do it for 7 years, the life expectancy may increase by 2 years. There are some tips to reduce inactivity at our workplace. We can use stairs instead of elevator. Breaks should be encouraged. Utilize our established channel of communications and existing support network to interrupt prolonged sitting. We should walk around office building during works. We should prefer walking meetings. Talk a walk to communicate with fellow employees. Like suppose you are waiting to board at airport, your flight has been delayed by 30 minutes. Most of the time we keep sitting there waiting for the flight to announce their boarding. That time we can walk around, we can be our fellow colleagues, we can have a walking meeting, we can have discussion, and that time you will see in half an hour, you can have a 2 to 3 kilometers of walk. The editorial in Building Research and Information 2015 says that people need to sit less, move around more, and preferably more energetically, ideally in all aspects of their life. There are a few tips. We should identify an activity that we will enjoy. It's not like that somebody has to go for the morning walk or evening walk. We should find out the activity that gives us the enjoyment. We should consider doing exercise in group or with partner. Should prevent boredom, and we all know it is important to warm up before start, and it is very important to cool down at the end. These are the simple rule before starting exercise. Drink adequate amounts of water. Ensure that footwear is appropriate. If somebody is diabetes, they should have a bracelet or carry an ID card. Ensure that exercise partners should recognize your hypoglycemic symptoms. Always carry some carbohydrate food for the diabetes patients. We all recommend that 30 minutes, 5 days a week is very much needed exercise. There are a consensus physical activity guidelines for Asian Indians where they say preferably daily or moderate to vigorous intensive aerobic exercise, preferably daily 60 minutes per day, or muscle strengthening exercise at least 3 times a week, or bone strengthening at least 3 days in a week. This is for coronary artery disease. It's a busy slide. I will not go into detail, but it's available. We should do for most patients with the cardiovascular disease, one set of exercise consisting of 12 to 15 repetitions for each muscle groups. For overweight and obesity, the guidelines that moderate intensity aerobic exercise 60 minutes daily, vigorous intensity exercise 60 minutes, 3 or more days per week. So in our current day-to-day life, there is a significant room for improvement, because if we see the data, only 5% of adults usually seem to be participate in 30 minutes of physical activity, which has been recommended. Out of 3, only 1 adult receives the recommended amount of physical activity on a weekly basis. If we talk about the new generations, the adolescents, 80% do not do enough physical activity to meet the suggested guidelines for youth. Out of 3 children, only 1 child are physically active every day. And if we talk about the screen time, children now average more than 7.5 hours of screen time, whether it is a television, video games, or computers. So in summary, prolonged sitting is harmful effect on our body, similar to smoking. Hence the phrase, sitting is the new smoking. The serious health problem linked to the long sitting hours, including obesity, as we are consuming less amount of energy. We are wasting less amount of energy and utilizing less amount of energy. Increase in cardiovascular disease or heart disease, type 2 diabetes. There is also data, there is an increase in the cancer, whether it is uterine cancer or prostate cancer. And there are more in the premature death, which may be premature preventable death, that maybe counts for around 6% of the total death. Sedentary behavior also lead to other health problems like neck and back pain, weak leg and gluteal muscles, deep vein thrombosis. There are data where they have compared by MRI the temporal bone mass. It has been seen that the persons who are sitting more, they are a thin temporal mass than compared to those who are active, suggesting that there are more chances of Alzheimer's disease. And we have also seen there is an increased level of anxiety and depressions when you sit for a longer period of time. It's likely that the future generation will look back, when they look back at our sedentary working practice, with the same incredulity that we now regard the idea of a smoke-filled office or aeroplane. With physical inactivity, stress, burnout, which is a very real problem in general practice, it is now time to prioritize and research activities that enhances rather than deplete our health and well-being at work. There are a concept of the working desk to be used to increase the standing and activity and to reduce the sitting postures. Exercise is the most potent and underutilized antidepressant, and it's free. Thank you very much. Over to
Really an exciting talk. Really appreciate it. A must need our talk. What I personally feel from my end, which I am not practicing, I'm also sitting couch. So I need now to start walking.
Some exercise has to be done.
Some exercise has to be done. Some kind of exercise has to be
Dinesh,
done.
my good friend, beautiful presentation. Really.
Thank you, Dr. Basa.
Excellent. Really great.
It's a nice and topic by the Dr.
Yeah.
Arvind. I'm grateful to his student this topic, which is very much need of the day. In our day-to-day practice, we don't see. And we doctor, I think most of the time we also do practice sitting all together and we don't move around.
तो कल सुबह से मॉर्निंग वॉक शुरू कर देना तू भी
मुझे करना है भैया
मुझे क्या लगता है कि हम लोगों ने अपने केबिन का जो एग्जामिनेशन टेबल है वी हैव टू कीप दैट टू अ डिस्टेंस सो दैट पेशेंट को जाते समय जाके उठ के देख के आते इसमें हमारी वॉक और ये शुरू हो जाए दैट थिंग कैन बी डन दिस इज व्हाट आई फील
this is true.
So when selection, if you see closely observe Amit in this session, the three topics are totally of different, out of the box. The first one is everybody talks about DPP4 inhibitors and all those things. We don't know the untold facts actually. So that is the reason the first topic that Dr. Abhijit spoke. And the second, Dr. Arundhati, like you tell every cardiac drug CVOT is that this is non-inferior, this is superior. We talk so many things. Does it really need it actually? That whether it is killing the new molecule innovations and all. That was the talk. So in fact, we discussed with Dr. Arundhati and we said this with the thought process. Why can't you present in this way? Where what is the real fact? Then when I was looking into what else we can give, so sitting, this is the common thing. As a doctor, we do. We advise so many things, but as a doctor, we keep sitting and doing all this clinical setup around 7 to 8 hours per day. So that is the reason we thought this topic would be good. Is sitting is the new smoking. So I should say, but all the three speakers did a wonderful job in the sense the topic and the scientific evidence, what they got it, and all those things was an excellent talk, was it?
Absolutely true, sir. Absolutely. Out of.
Thank you.
So on behalf of
part of this session, thank you.
Yeah. On behalf of Dr. Arvind Diabetes Center and ADC International Virtual Diabetes Summit 2022, I wholeheartedly thank Dr. Kirti Sutta, Dr. Amit Nagate, Dr. Abhijit, Dr. Arundhati Dasgupta, and Dr. Dinesh Agarwal for your wonderful presentation and discussion. And thanks for your valuable time and being a part of our conference. Thank you so much.
Thank you. Really appreciate it. Thank you.
So we'll move on to next session. Over to Dr. Shweta.
Yes, sir. Thank you, sir. And the previous session was really a thought-provoking. And thank you, speakers. Thank you so much. Let's move on to our next section. Dr. Ami Sanghavi, MBBS, DIA B. Director and Consultant Diabetologist at Sangavi Eye and Diabetic Care Center. Welcome you, ma'am. The another chairperson, Dr. Shankar Sen, MD, Medicine Gold Medalist, FACP, FICP, FIAMS, Fellow Diabetes, India, Siliguri. Welcome you, sir. Over to the chairperson.
Yeah. So a very, very good evening. Really enlightening sessions. Congratulations, Dr. Arvinda. And moving on to this part of the session 7, I take the privilege of introducing, it's my absolute honor of introducing Dr. Benny Neglur, who has been an inspirational figure, at least where I'm concerned, and for most of us. Ma'am is the director at Dr. Neglur's Diabetes and Thyroid Specialty Center and at Jupiter Hospital, Thane. She's a teaching faculty for Fellowship in Diabetes and Public Health Foundation of India. She's the founder, president, and organizing chairperson of WordCon Women in Diabetes conference since last 5 years, where I have also had the privilege to be in her team, founder and executive committee member of Association of Diabetes Educators in India since 2006, editor of Awakening Diabetes newsletter for patient education, speaker at various regional and national conferences. She's been an associate professor in the Department of Medicine at Terna Medical College, has written several chapters on diabetes and reputed textbooks of medicine and diabetes, and has been the scientific chairperson of RSSDI Maharashtra chapter 2005. I invite you, ma'am. Ma'am is going to be speaking on women, CVD and diabetes, a very relevant topic. Ma'am, over to you, ma'am.
Yeah. Thank you so much. I just share the screen. Yeah. Yes, thank you so much, Dr. Arvind, for this very wonderful conference, and the deliberations have been carefully picked out, and they're really excellent. I heard some of them. This is my very close topic, which is very close to my heart: women, cardiovascular disease, and diabetes. Not because I'm a woman, but because diabetes behaves differently in women compared to men regarding cardiovascular disease. And you can see the picture here, that is Yentl. It is a musical picture way back in 1983. This was Barbara Streisand, where she had to disguise
Madam, please
herself.
share your slides.
Oh.
It's not visible till now.
Just a minute. I share screen. Okay, is it seen now?
Yeah, make it full screen.
Oh, sorry, I was just speaking.
No issue.
So,
Please take your time.
this was Yentl, the musical film, and you
fine.
can see Dr. Bernadine Haley. She was a cardiologist, and in 1991, she wrote an academic paper known as the Yentl syndrome, where she showed that heart disease is more common in women and it is underdiagnosed, and especially in diabetes. We know that cardiovascular disease is the leading cause of death in women, much more than breast cancer and stroke as it was thought before. And more importantly, it is a younger people now who have high mortality, and you can see 29,126 between the age of 45 and 64 in USA, and this is very alarming. And you see the cardiovascular mortality trends here. Somewhere in 2000 was the Go Red program, which was an awareness program in the USA. And you can see the red line, which was right on top, much above the mortality that happens in men, with slowly going down because of the awareness program, and also further going down. But you can see later that it is also trending upwards. And we all know that estrogen is a protective hormone, especially in the reproductive years of a woman's life. And that pushes the presentation of CVD 10 to 15 years much later compared to men. So we are protected actually. But what happens when estrogen goes down and there is premature menopause or menopause? You see even what is happening physiology. The women are having a higher blood pressure compared to men, and there is more LDL and there is more HDL compared to men. And women are actually having a life course, unlike the men. So you see the weight gain that happens in the first pregnancy itself, the fat mass increases, visceral fat mass increases, the BMI increases, and a lot of it is retained. And the same thing happens in the second pregnancy and much later in life. So obesity is a big challenge for women. And here in the Nurses' Health Study, it is shown that more obese the woman, the more the risk of coronary heart disease. And if you add hypercholesterolemia and hypertension, the risk increases several fold. So BMI is an issue. And besides this, you see, we have the traditional atherosclerotic cardiovascular risk factors for men and women: diabetes, smoking, obesity and overweight, physical inactivity, hypertension, dyslipidemia are in both. But what is happening in women? The risk factors are many more, and they are new and non-traditional, which we have to be aware of. The preterm delivery, hypertensive disorders of pregnancy, gestational diabetes, autoimmune disease, breast cancer treatment, and depression are the new risk factors seen in women, and therefore women have double the risk factors compared to men. And if you look at the triglycerides, this was in the Framingham study presented in 1988, they found that women had higher triglycerides compared to men, and for every increase in serum triglyceride of 89 milligrams per deciliter, the risk of coronary heart disease increases by 30% in men, but at women, it increases by 69%, almost double. And this was the lipid study, the Lipids Research Clinic Prevalence Study, and they have shown that the lipids in diabetes in women are more powerful determinants of cardiovascular risk. They are more atherogenic, and although low HDL and high triglycerides are seen both in men and women, the women have a more atherogenic dyslipidemia that has its impact on cardiovascular disease. Even hypertension, women between 65 and 74, the prevalence is more than 58%, and more than 2/3 of treated hypertensive women have uncontrolled blood pressure. But what I want to drive home the fact is that the disability that happens in women heart attack survivors is almost double compared to the male survivors. It means, therefore, that women's heart are getting weaker, and if they're attacked by a heart disease, they go down very quickly, giving rise to complications and congestive heart failure. Even smoking reduces the estrogen levels. Menopause occurs earlier in smoking women. Women smokers have a high risk of early heart attack. And for women less than 50 years, the majority of coronary heart disease is attributable to smoking. And the risk increases with the number of cigarettes. The risk also increases if the woman who's a smoker is also on the oral contraceptive pill. And so you see that women have greater stress factors and risk factors for cardiovascular disease. Even mental stress. The mental stress is a trigger for ischemia in women, which is more often than men. So if you see the EKG, it documents that mental stress documents ischemia in women, but in men, it is the physical stress that brings about changes in the ECG. And women report chest pain more often during the daily activities of work and when they have increased mental stress. But men experience chest pain more during exercise. And this is the broken heart syndrome, also known as Takotsubo syndrome. Takotsubo syndrome is a syndrome where there is acute stress, which releases a large quantum of neurotransmitters, namely adrenaline, which has its impact on the heart. It weakens the left ventricle, and the person goes into cardiac failure. It can happen due to mental stress. It can also happen due to acute illness or physical stress. But in women, the Takotsubo syndrome is seen much more than in men. But what I want to show you, which is also, I mean, it was news to me, that psychosocial stressors in women with coronary heart disease, this was the Stockholm Female Coronary Risk Study, which shows that marital stress or cohabitating with a male partner is associated with nearly 3-fold increased risk of recurrent coronary heart disease events in women. But if they live alone, and work does not significantly stress them. So marriage or partnership benefits men and maybe not in all women. Also, there are challenges in recognition of heart disease. The traditional and the conventional chest pain, which is precordial or substernal, may not be perceived by women. They have very atypical symptoms, and therefore they themselves don't realize that they have heart disease. And even if they go to the healthcare practitioner, it is kind of treated as functional, not related to heart disease, because these atypical symptoms may be just unusual upper body discomfort or shortness of breath or breaking out in a cold sweat or unusual or explained fatigue, just acute fatigue, or just nausea, feeling sick in the stomach, or lightheadedness. So we have to be aware of these unusual or atypical presentations of heart disease in women, especially in diabetes. And the reason why is that in the women, in diabetes, there is a dysfunction of the coronary micro blood vessels. So it's a microvascular complication for women. And it's a macrovascular complication for men, because in men, in diabetes, there is obstruction of the epicardial coronary arteries. Whereas in women, when they do a coronary angiogram, they see a diffuse atherosclerosis. And you see the difference in men. Men have a focal stenosis and they are immediately taken for stenting. Whereas women, because they have a diffuse atherosclerosis, they might be sent back saying that your coronaries are normal. And this is a study in 2006 that shows there is the less obstructive coronary artery disease in women undergoing angiography compared to men at all ages. And this was the WISE study, the Women's Ischemia Syndrome Evaluation, which was sponsored by the NIH and the National Health Lung and Blood Institute, where they said that 50% of the women were sent back with normal coronaries, but they continue to experience disabling symptoms. And possibly coronary microvascular or macrovascular endothelial dysfunction is seen. And you can see that persistent chest pain should not be taken as a benign condition in women. And those who had persistent chest pain actually had twice the number of CV events than those who did not. So that is an eye-opener for us. What happens is there is a gender difference in atherosclerosis. In men, they suffer more plaque explosions or plaque rupture, whereas in women, they suffer from more plaque erosions as a cause of acute coronary syndrome. So they kind of have a very slow and low and subtle chest discomfort compared to the men who have an acute chest pain. Besides, women in diabetes have more endothelial dysfunction. They have more inflammatory biomarkers, and they have greater comorbidity compared to coronary artery disease in men. It's not only that, even there are differences in heart failure. Women are more likely than men to develop heart failure with preserved ejection fraction. So what you see them having stiffer hearts, whereas men are most likely to have heart failure with reduced ejection fraction. So they have weak hearts. And if you do an echocardiogram, you will find maybe a normal left ventricular ejection fraction with a diastolic dysfunction in women, whereas the left ventricular ejection fraction is reduced in the echocardiogram in men. So kind of women may not even be treated for heart failure because of this. And then coming back to pregnancy, which is kind of that shapes the rest of your life. It is said, David Barker was the one who said that the uterine environment actually modulates the genes. And also the epigenetic modulations can happen in the uterus itself. So when the baby is born, the baby and when the baby grows up, they are susceptible to all the non-communicable diseases if the uterine environment, whether it is malnutrition, whether it is overnutrition or undernutrition, that can affect the genes and make the person susceptible to chronic diseases in later life. We know of what happens in dysglycemia. If there's a female fetus, you see the female fetus bathed in this dysglycemic environment, and the female, when born and grows up, can get type 2 diabetes much earlier. So it is a kind of a transmission of diabetes or intergenerational programming that happens in a diabetic woman. Even the hypertension, when it occurs during pregnancy, they also produce later cardiovascular aging quicker and cardiovascular disease. You can see in this study done in 2019 by Honigberg, coronary artery disease, heart failure, aortic stenosis, mitral regurgitation are higher in women who have had hypertension in pregnancy. And why does this happen? Because there is subclinical inflammation and vascular dysfunction in women who have hypertension, and also in women who have gestational diabetes mellitus. And for those who have GDM, you can see there are increased levels of CRP, PI inhibitor, interleukin 6, adiponectin is low, while the others are up. And that makes the vasculature of a woman with a prior case of GDM permanently altered, predisposing them to cardiovascular disease. And this was the latest study, 2021, the Cardia study, where you can see from the graph that women without previous GDM showed a graded increase in the risk of coronary calcium associated with worsening glucose tolerance. But women with a history of GDM had a twofold higher risk of coronary artery calcium across all the subsequent levels of glucose tolerance. And they actually present this in midlife. And this presentation of atherosclerotic cardiovascular disease risk among women with previous GD is not diminished even if they attain normoglycemia. So this is another eye-opener. Menopause itself is a risk for coronary heart disease. And you can see here, if the menopause is premature, you can see the red bar here between the age of 40 to 45, it is almost as tall as those who attain menopause later. So premature menopause is a very high risk factor for development of cardiovascular disease in women. And this was a study that was shown where there's hypertension, hyperlipidemia, and type 2 diabetes. All high risk factors for cardiovascular disease are increased if the woman has a premature menopause. And now a new risk factor, breast cancer or cancer. Women who have cancer and are breast cancer survivors are more likely to have heart disease and die of heart disease rather than breast cancer. Even the chest radiation increases the risk of heart disease. And even the chemotherapy, anthracyclines and Herceptin, increase heart failure. So you see the risk factors are much higher in women compared to men. Does hormone replacement therapy prevent heart disease? You see 2 major clinical trials have been conducted to see the effect of HRT in CVA, but both of them have concluded that there are no significant benefits with hormone replacement therapy. So where heart disease is concerned, for prevention, we do not give hormone replacement therapy. What about aspirin? There are 3 large studies, the ARISE study, the ASPRI study, and the ASCEND study, each of which had more than 10,000 women, but it has not shown much benefit in primary prevention between the age of 40 to 70. But in a given patient, we have to weigh the benefits and the risk and decide whether aspirin should be given or not in primary prevention. But yes, it is given in secondary prevention. And here is data showing that even treating lipids for secondary prevention and treating them early does help in reducing the cardiovascular risk in women. And now they have also included risk enhancing factors which are woman related, like pregnancy complications and early menopause in the cholesterol clinical practice guidelines 2018 by AHA and the ACC, which is kind of women have, even if they have a lower risk, we have to treat them early if they have the history of sex-specific risk factors. And you can see the number. This is my last slide. Prematurity, age of menarche, polycystic ovarian syndrome, hormone-based contraceptive use, recurrent spontaneous pregnancy loss, gestational diabetes, gestational hypertension, preeclampsia, preterm delivery, and delivery for small for gestational age infant, and early menopause. All these are very high risk. And if these risks are present, we need to screen the women early, begin aggressive risk factor management, their blood pressure, cholesterol, blood sugar, ask them to stay active, eat healthy, lose weight, and stop smoking. This is the AHA's Life Simple 7, and estimate the cardiac risk with consideration of sex-specific risk factors. And even if the risk is lower than 10, between 5 to 7.5 and between 7.5 to 10, if they have all these risk factors, we need to treat them early. Thank you very much.
Thank you, ma'am. Thank you. That was a wonderful talk regarding the women, cardiovascular disease and diabetes. Thank you so much. Over to the chairperson.
Yeah. Thank you very much, ma'am. You really touched upon very subtle points of, and every point in a woman's life beautifully. I think we are moving on to the next talk. I request the other chairperson, Dr. Sain, to kindly introduce.
Thank you.
Thank you, Benny Madam. That was a wonderful
It was
talk.
an excellent talk by Dr. Nagalur, and we were very much enlightened. So the next talk today is very important, probably the most dreaded complication of diabetes. It's not DK, it's not HHS, but it's hypoglycemia. And we need to emphasize upon the importance of hypoglycemia on each and every visit of our patients to our clinics. So to talk on this, an overview, none other than Dr. Sujoy Majumdar, who is from the GD Hospital and Diabetes Institute, Kolkata. And he is also an endocrinologist at the Peerless Hospital. And he has one chapter on acromegaly and diabetes. And in Diapedia, the online textbook of diabetes of EASD, there is his articles. So he will be talking on an overview of hypoglycemia. The stage is yours, Dr. Sujoy Majumdar. Your time is 20 minutes, and please try to stick to it, and we'll be enlightened on your talk.
Thank you for the kind introduction, and I would like to really start my session by thanking Dr. Arvind, our dear old friend, whom I have known at least for the last 10 years, for inviting me for this wonderful meeting. I've been attending the sessions in brief sessions for yesterday, and I must say it has been a fantastic meeting. So without wasting much words, let me move on to my topic, that is an overview of hypoglycemia. Now, it's just like, as you mentioned, it's a 20 minutes time, and it's 20 minutes, I feel it's probably a little bit inadequate to basically talk on this issue of hypoglycemia. What I'll try to do, I'll try to play it in a T20 style so that everybody can have a chance to say something at the end of the day. So this is a basic fact of physiology, which we are all familiar with, that there are two major hormones, that is insulin and glucagon, which control the blood glucose levels. And insulin tries to bring the blood glucose down, glucagon tries to bring the blood glucose up. And also there are other hormones like corticosteroids, adrenaline, and growth hormone, which also have got a significant role in countering any tendency of the body to get the blood glucose low. Or in other words, when the body goes into a stage of hypoglycemia, all these hormones, including the glucagon, the corticosteroids, adrenaline, and the growth hormone, they all are fired at sequential intervals to prevent the hypoglycemia from happening. So this, in summary, is basically what the basic physiology is like. The glucagon basically stimulates the glycogen breakdown to increase the blood glucose levels, whereas insulin leads to glycogen formation. So basically, it affects the process by which there is a glycogenesis, and in that process, by that way, it tries to reduce the blood glucose down. Now, whenever there's a low blood glucose, there is a stimulation of the pancreas. There is a stimulation on the pancreas. Hypoglycemia stimulates the pancreas to release more glucagon and suppress the release of the insulin. So that is the standard mechanism. Now, if we look at the way what happens when blood glucose falls down or hypoglycemia happens, what happens? There is stimulation not only of the pancreas, but also of the brain. And when this hypoglycemia is acting on the pancreas, as I mentioned earlier. It reduces the insulin and increases the glucagon, and this balance basically has got its effect on the liver to produce increased glucose in the blood. Now, what happens? What about the effect on the brain? Brain, as we all know, depends to a large extent on the glucose for survival, and brain actually does not need any insulin for the glucose to permeate into the brain, except one or two areas, including the hypothalamus pituitary. And what happens is that when the brain is affected, there is actually a stimulus. When there's a brain undergoes a hypoglycemia, there is a stimulus. There's a stimulus of the sympathoadrenal system, and it affects the adrenal medulla, leading to the rise of epinephrine release. At the same time, there is stimulus on the pituitary to cause a growth hormone release, and also stimulus on the ACTH to produce a rise in the cortisol. So this, in summary, this slide in summary, basically explains what happens when the blood glucose drops down precipitously low levels. So, to summarize, in the fed state, it's insulin which dominates, whereas in the fasting state, the glucagon dominates. So what happens is that in the fed state, the glucagon actually increases the glucose oxidation. It increases the glycogen synthesis, it increases the fat synthesis and protein synthesis. And in the process, the insulin brings down the blood glucose, whereas with glucagon, just the reverse happens. There is more glycogenolysis, there is more gluconeogenesis, and more ketogenesis. So with that basic physiology at the back of our head, let us try to analyze what we mean by hypo. By definition, it means any blood sugar that is lower than usual, but it can also be a manifestation of a relative reduction of glucose compared to the values in the tissues. Traditionally, our definition of hypo is that the blood glucose should be less than 60 to 70, ideally around 65 to 70. But at the same time, patients can experience symptoms of hypoglycemia even at 200 if their usual ambient plasma glucose is running at 300. This is known as relative hypoglycemia. And hypoglycemia is typically characterized by the Whipple's triad. That is plasma glucose less than 2.2 millimoles of 40 milligrams per deciliter. And it is associated with the symptoms of neuroglycopenia. And the symptoms reverse with glucose administration. Whipple's triad was first described in patients with insulinoma. Insulinoma, as we all know, is a rare islet cell tumor, and it is characterized by symptomatic hypoglycemia and inappropriately increased plasma insulin during an episode of spontaneous hypoglycemia. Whipple first tried this glucose therapy to correct that, and that's how hypoglycemia initially was defined. Now, if you look at the etiological origin of hypoglycemia, it can be broadly classified into two headings: a fasting hypoglycemia, or postprandial hypoglycemia. If it is a postprandial hypoglycemia, it usually occurs in two conditions, that is type 2 diabetes or post-gastric surgery. A fasting hypoglycemia is usually due to a non-diabetic cause, and that includes exogenous drugs, pituitary insufficiency, liver failure, Addison's disease, islet cell tumors, and non-pancreatic neoplasms like bronchogenic and the pancreatic neoplasms. But also, this sort of a fasting hypoglycemia can happen in diabetes patients because of, say, insulin or sulfonylurea overdose, increased degree of activity, missed meal, or accidental overdose. So this, in summary, is how we classify hypoglycemia according to the etiology. Now we can again sub-classify them according to the level of hypoglycemia. So level 1 hypoglycemia is when the plasma glucose is less than 70 milligrams per deciliter. So that value is sufficiently low for treatment with fast-acting carbohydrate and dose adjustment of the glucose-lowering therapy. The next level is the clinically significant hypoglycemia. Level 2 is when it drops below 54. That time it is sufficiently low to indicate serious clinically important hypoglycemia. Now, why this distinction between level 1 and level 2? Because when your blood glucose is below 54, your sympathoadrenal system is starting to kick in. And how it happens, we are going to discuss it later on. But beyond that, there is a severe hypoglycemia when the patient is unable to help himself to correct hypoglycemia and needs a third-party assistance for recovery. This hypoglycemia can again be further sub-classified into documented symptomatic hypoglycemia, which is a typical hypoglycemia that we are all familiar with. But patients can also have asymptomatic hypoglycemia, where the measured plasma glucose is less than 70, but the typical symptoms of hypoglycemia can be missing. This usually happens in a large number of non-diabetic, non-pregnant individuals the conservative lower limit than diabetes. So this may not actually be a true hypoglycemia. Some people, non-diabetic individuals, may actually have a normal blood glucose up to as low as 45. So this is an asymptomatic hypoglycemia. And this also happens in people with long-standing diabetes, where because of the hypoglycemia-induced autonomic failure, the patient is unable to perceive the symptoms of hypoglycemia. Then we have got the probable symptomatic hypoglycemia, where the patient has got symptoms of hypoglycemia, but actually did not measure the plasma glucose levels by the glucometer. So basically, this is one of the most common examples of misdiagnosed hypoglycemia, because similar symptoms can actually happen. For example, with an ongoing cardiac ischemia, where the symptoms can be very similar, but the plasma glucose is higher. But unfortunately, most of the time, what people tend to do, they tend to treat it with oral carbohydrate without testing the plasma glucose. And lastly, the relative hypoglycemia that I talked about. Symptoms of hypoglycemia can be brought about by the degree of fall of the plasma glucose levels. So, for example, if somebody's plasma glucose is falling from 300 to 150, the symptoms will be very similar to somebody whose blood plasma glucose is falling from, say, 150 to 50. So what are the common causes of hypoglycemia in diabetes? These are the three common causes: wrong dose of the glucose-lowering therapy, wrong timing of the food, and unplanned exercise without food. There are certain predisposing risk factors like advancing age, hypoglycemia unawareness. This is something which happens in long-standing diabetes with very good control. And the most common of hypoglycemia is medications, as we mentioned, and particularly insulin and sulfonylureas, and especially long-standing insulin therapy. Risk is greater in diabetics who have eaten less than usual, exercised more than usual, and have drank alcohol. And other conditions which can precipitate hypoglycemia in diabetic patients include a renal impairment, insulinoma, liver disease, hypothyroidism, prolonged starvation, certain inborn error of metabolism, and certain drugs. Now, this is the list of drugs. Again, this is a big list which can actually predispose a diabetic individual to hypoglycemia. Common groups include the gatifloxacin, pentamidine, and the quinine. Some lesser amount of evidence with the chloroquinoxolin, sulfonamide, and the artesunate, artemisinin, the antimalarials. And some of the ones, very rare ones like the ACE inhibitors, ARBs, they have also been associated with hypoglycemia. But those things are extremely rare. So these are the clinical features of hypoglycemia, which I'm pretty sure I do not really need to explain before this audience. We are all familiar with the autonomic symptoms, which happen primarily because of the release of the catecholamines, the sympathoreinal system activation. But on top of that, when the blood glucose drops even lower, there are other features of neuroglycopenia, which happens because of a lesser delivery of glucose to the brain. And these are actually the more dangerous ones. The patient finds difficulty in concentrating, is confused, complains of weakness, drowsiness, and can even become unconscious. And if not attended, this can ultimately lead to death. Now, this is exactly how our body reacts to hypoglycemia. So when the plasma glucose drops below 80, endogenous insulin production stops. When it drops below 17, the glucagon release occurs. When it drops below, say, 65 or 66, at that time, the adrenaline and the growth hormone release occurs. Cortisol release occurs below 57, and autonomic symptoms are started at the time. Cognitive dysfunction occurs below 50, ideally around 45 or below. And if it is severe, that is less than 25 or less than 30, then it can result in coma or seizure. In certain ways, hypoglycemia can present typically, particularly in the extremes of age. In young children, for example, hypoglycemia can present just with vomiting and ketosis. In older children and adults, moderately severe hypoglycemia can resemble a mania, a mental illness, a drug intoxication, or a drunkenness. In the elderly, hypoglycemia can produce focal stroke-like effects or hard-to-define malaise. They can even present with focal convulsions. And in newborns, hypoglycemia may produce irritability, jitters, myoclonic jerks, cyanosis, respiratory distress, apneic episodes, sweating, hypothermia, somnolence, hypotonia, refusal to feed, and seizures. Hypoglycemia can resemble in newborns asphyxia, hypoglycemia, sepsis, or heart failure. So these are some of the atypical ways by which hypoglycemia can affect patients at the extremes of age. So what are the consequences of hypoglycemia? Well, first of all, is a Somogy phenomena when a hypoglycemia is followed by a post-hypoglycemic hyperglycemia. But recurrent hypoglycemia leads to a wide glycemic variability, wide fluctuation of glucose. And this is something which ultimately leads to diabetes. Recurrent hypoglycemia is also seen in association with hypoglycemia unawareness or hypoglycemia unawareness autonomic failure. And this is primarily because of a sustained low blood glucose, so that the sympathoadrenal system cannot react properly to a fall in the blood glucose. The other effects which we all know, the seizures, stereotype neurodeficits, coma, and cardiac events. These are all very well-known consequences of hypoglycemia. So let us look at them one by one. So hypoglycemic events can trigger a parasympathetic stimulation. It can trigger an adrenaline release. And this adrenaline release is comparable to what we find in an acute MI. And it also can lead to dysrhythmias. And this is basically the different ways by which hypoglycemia brings about the changes in the heart. So there can be a release of the inflammatory factors like the CRP, the vascular endothelial growth factors, and the IL-6. There can be neutrophil activation, platelet activation, and release of factor VIII. So there is a distinct alteration in the coagulation profile because of hypoglycemia. The sympathoadrenal response we're going to discuss in detail later on, but there is an increased release of adrenaline and increase in the oxygen consumption and the heart workload. So there is also at the same time the hypoglycemia affects the endothelial function, and there is reduced vasodilation, thereby producing a significant amount of myocardial stress. Now, severe hypoglycemia has been shown to prolong the QT interval in patients with type 2 diabetes. And we all know that if the QT interval is prolonged, there is an increased risk of arrhythmias. And this is what a typical ECG change in hypoglycemia looks like. We can see here on your left-hand side of the panel, the QTC was something around 456. And here, after the hypoglycemia, it has gone up to 610, which is definitely a significant evidence of QT prolonged. Let me show you a series of cases here. This is a real-life case which I had collected. So this was a patient who has admitted with a hypoglycemia. And you can see on admission, the QT interval was 363 milliseconds. Immediately after the hypoglycemia, the QT corrected QT was 467 milliseconds. And 2 hours after the hypoglycemia had been corrected by then. Still, you can see the QT is still prolonged at 452 milliseconds. And after 48 hours of the hypoglycemia, still there is some degree of QT prolongation at 428. So the important take-home message here is that following an hypoglycemia, these QT changes take a long time to come back. So it is not surprising that arrhythmic agents, particularly the R1-2 phenomena, which happens with the QT prolongation, can happen in the setting of a hypoglycemia and can lead to a sudden ventricular tachycardia and ventricular tachyarrhythmia. The other important point is that when hypoglycemia happens in the daytime, the cholinergic symptoms predominate, so the patient gets more of a bradycardia. Whereas when it happens at nighttime, the sympathoadrenal system is dominant, leading to what is known as more of a ventricular tachycardia and tachyarrhythmia. And not only that, as I've explained for the reasons I've just touched about a little earlier, hypoglycemia may be associated with an increased rates of chest pain and ECG abnormalities. In other words, angina can be precipitated by hypoglycemia. This is a typical description of what happens following hypoglycemia. As you can see here, you can see the baseline ECG and see how the ECG has changed following hypoglycemia. So ECG manifestations of ischemia can become very much manifested following an episode of hypoglycemia. And severe hypoglycemia contributes to an increased mortality in CCU settings, particularly diabetes patients, where there is a nearly 3-fold increased risk of mortality and increased risk of patients, particularly on mechanical ventilation and septic shock. These people, they have got a high risk of severe hypoglycemia, particularly those on mechanical ventilation. If they have got severe hypoglycemia, the risk of mortality is increased by nearly 2.5-fold. What about the long-term consequences of hypoglycemia? Recurrent hypoglycemia leads to cognitive impairments, impaired mood, impaired reaction time, and verbal fluency. There can be an information processing problem, so the patients cannot analyze an information passed on to them. They lack the attention. There is a defect in the pattern recognition and memory. They have got declarative memory. In other words, there is some cognitive dysfunction taking place so that they cannot recollect recent events. And last but not the least, it can lead to suicidal depression and road traffic accidents. So hypoglycemia and dementia, this particular study way back in 2009 showed that more the frequency of hypoglycemia, more the risk of occurrence of dementia. And this is irrespective of the age, sex, ethnicity, BMI, duration of diabetes, additional comorbidities, the background mean HbA1c over the past 7 years, and insulin use. Either way, the more frequent the hypoglycemias, more is the risk of dementia. This was the DEB-DAB study conducted by us. I was one of the authors of this particular study. This is the largest study in the whole of Asia on assessing the prevalence and predictors of depression in type 2 diabetes. We had a cohort of nearly 1,300 patients, and this paper was published last year. Now, what we showed there, that depression was noted to be more common in patients with hypoglycemia, and the incidence of hypoglycemia actually increased the risk of depression by nearly 1.6 times. But surprising as it may seem, insulin use was not significantly associated with depression. So how do you manage the hypoglycemia? Basically, we have to take the decision whether this patient can be managed at home or whether this patient needs hospital admission. This is the list of patients who basically needs a hospital admission. For example, patients on long-standing sulfonylureas like glibenclamide, which we of course do not use to that extent right now, frail or elderly patients more than 60 years, patients with significant renal or liver impairment, patients who have recurrent episodes of hypoglycemia within the last 2 weeks, and patients who do not have a good home care system, who are unable to self-care and unable to be discharged because they do not have an adequate or competent caregiver. These patients, they need to be admitted, and also patients with a previous history of severe hypoglycemia. The treatment of hypoglycemia, I think all of us know, it's either oral glucose or IV glucose to start with, but there are certain other agents which we can use like glucagon, octreotide, and diazoxide. The last one, I'll leave it out because that is restricted only for the use of patients with insulin. In the normal diabetes patients, these diazoxide is never used. So the treatment protocol is in a fully conscious patient with a mild to moderate hypoglycemia, where the should be able to self-treat. The patient should be given 15 grams of simple carbohydrate. It could be 1 tablespoon of honey, 3/4 cup of juice, fruit glucose-containing juice, or 3 teaspoonfuls of table sugar. So remember, this is the rule of 15. You repeat the blood glucose after 15 minutes. If after the 15 minutes the level is still less than 4 millimoles or less than 70, give another 15 grams of carbohydrate in the form of oral glucose. What we always advise is that have glucose, do not have candies or chocolates. Why? Because candies and chocolates contain a fatty layer that will prevent rapid absorption. In severe hypoglycemia, where the individual is still conscious, it should ingest 20 grams of carbohydrate, and the above steps should be repeated till the plasma glucose has crossed 100. When the mental function is impaired, for example, patient is confused, the patient should be given IV 50% dextrose, 25 to 50 ml over 1 to 3 minutes, followed by saline flush. And then after that, as soon as the blood glucose comes back to normal, other oral glucose supplementation should be carried on. And once hypoglycemia is reversed, the patient should have the usual meal and snack that is due at that time of the day to prevent repeated hypoglycemia. When hypoglycemia is due to an overdose of a long-acting insulin or a long-acting urea, like chlorpropamide or tolbutamide, 10% dextrose drip should be continued at least for 24 to 40 hours. Patients receiving anti-diabetic agents that may cause hypoglycemia should be counseled about strategies for prevention, recognition, and treatment of hypoglycemia. Individuals may need to have their insulin regimen adjusted according to their self-monitored blood glucose level. Now, when the patient's also got mental function impaired, and this patient is particularly just on insulin, maybe a basal bolus insulin, if available, glucagon 1 milligram IM or dip subcutaneous can be given to treat the severe hypoglycemia. And again, as soon as the patient regains consciousness, he should be allowed to eat and drink, and the hyperglycemic action of glucagon lasts for only 10 to 15 minutes. If the patient has taken a long-acting insulin, then maybe this oral glucose replacement has to continue for a long time. Patients who remain unconscious after prolonged hypoglycemia may need to be given a treatment for cerebral edema with IV dexamethasone, 4 milligram 6-hourly or IV mannitol, and other causes of coma like stroke and drug overdose has to be excluded in such patients because often a stroke or a drug overdose can present with a hypoglycemia. If the patient,
pardon,
yeah,
sir, few seconds.
I've just got 1 or 2 more slides.
Yes, sir. Yes, sir.
So somatostatin analogs basically are used very rarely, not readily used in India, but abroad they use this for sulfonylurea-induced hypoglycemia. It's a safe and effective treatment for refractory sulfonylurea-induced hypoglycemia. and it provides more potent inhibition of the growth hormone glucagon and insulin as compared to the endogenous somatostatin. The dosage is written down there, and it may reduce the recurrent hypoglycemia with dextrose alone therapy. It should be used with IV dextrose and oral carbohydrate. So this, in summary, is how the.
Can we wind up in a couple of minutes, sir, please?
Yeah. I'm winding up. This is the last, second last slide. So this, in summary, is the slide for how you treat the patient in hospital setting, depending on the mild, moderate, severe. And also after this, the next bit is most important. We have to adjust the drug therapy, we have to adjust the diet, and educate the patient on hypoglycemia nutrition. And for patients who do not have diabetes, if it's a spontaneous hypoglycemia, patient should be referred to endocrinologist for the formal work on it. And subsequent treatment plan is basically patients are prohibited from driving, riding, or cycling, or operating heavy machinery. Patients must be educated on symptoms, and hypoglycemia unawareness should trigger a re-evolution of the treatment regimen. And in patients with hypoglycemia unawareness and those with concomitant cardiovascular disease, the glycemic target should be loosened. So the final take-home message: that hypoglycemia is an important but potentially negotiable barrier in the management of diabetes that can affect the long-term outcome. Though commonly iatrogenic, other causes should not be missed out, particularly if this is a case of recurrent hypos. Current guidelines also recommend the use of agents like incretins and SGLT inhibitors as first to second line agents of treatment of type 2 diabetes to minimize the risk of hypoglycemia. So thank you very much. Sorry for the overshoot of it.
Thank you, Dr. Majumdar. It was an excellent talk on hypoglycemia, and it was very well elaborated by you. Thank you, sir. So, most important thing,
topic. You did a good job, Dr. Sujay.
Yeah. So we can move on to the next talk on diabetes and mind, and it will be spoken by Dr. Raja Selvarajan from Bangalore. He is a physician and diabetologist at Kaveri Healthcare and visiting consultant to the Motherhood Hospital. And he has various accomplishments to his credit. So without wasting any more time, in 20 minutes, you are requested to talk on diabetes and mind. Dr. Selvarajan, it's your time to talk.
Thank you. Am I audible? Is my slate visible? Yeah, thanks at the outset. And it's my great pleasure to be at ADC, and sincere thanks and gratitude to Dr. Arvind Jagdisha for giving me this opportunity. Well, over the last 2 weeks, last 2 days, you have seen that the topics which he has coined us for the speakers has been really not only tongue twisting, but also mind twisting. Certainly, diabetes and mind is one such topic, I think, which is less spoken. Probably it's a huge, varied spectrum where things can be spoken for hours. We wouldn't be making justice limiting this talk to 15 minutes or 20 minutes, but let me stress upon certain few facts which we could possibly use in our daily day-to-day practice to make sure our patients are benefited with this. Most of the things, one second, is the slide moving? I'm not able to see that.
We can see your slides.
Yes,
it's
sir.
moving. Yeah,
Yes, sir.
it's absolutely fine.
Okay, so we all know that we have various thoughts, various feelings, various attitudes, which probably runs across our mind, and there's something which connects between the mind and the body. The mind and body is composed of so many other factors apart from what we learn or what we have learned to understand how this makes an emotional connect between what we feel, what we think, and what is the attitude towards a particular condition. And endocrine disorders are such ones which have been known to have multiple neuroendocrine regulatory dysfunctions associated with the emotional disorders. So diabetes is one among that which we commonly see, and we all understand it's one of the most commonest or the largest group of metabolic disorders, which has been characterized by hyperglycemia, probably as a result of a defect in the insulin production or action or possibility of having it both. The people with diabetes, we just will see on a practical basis when a patient walks into the clinic and the first time to diagnose type 2 diabetes, there's a lot of mental dilemma. He is not ready to accept the condition itself. So there's a lot of emotional breakout. There's emotional instability in terms of patient's mind to accept that he's almost in that denial mode. So these psychiatric disorders are something which are this shouldn't be called as a psychiatric disorders is probably a denial mode which the patient gets through when he first learns to know that he is probably a diabetic. The other psychiatric disorders which are very prevalent in diabetes, which we all know, depression is something which has been very, very highly associated. And specifically when you have a very poor control of diabetes, then the rates of depression and the incidence and prevalence of depression-related comorbidities, depression-related complications are also on a rise. Well, mood disorders have been an independent risk factor for type 2 diabetes. If a patient is well motivated, then probably the attainment of targets, sustaining of the targets, probably adherence to lifestyle, adherence to the dietary practices are much, much better. But when a patient supposedly has a mood disorder, he is not interested to do any of the activities which he normally does as well. So this itself imposes a great risk factor for either developing diabetes, or probably the worsening of diabetes becomes more when a person with the mood disorder has been associated with this. And more so, if you look at the medications which have been associated for the management of certain psychiatric illnesses or certain mental disharmonies, these have been associated with a direct incidence in rise in the incidence of diabetes itself. That is, a new onset diabetes itself has been noted to be seen. And also we see that certain of these drugs are more sedative. They put the patient less active. They are not less, or probably they're less motivated. They also causes increased sedentariness and probably resulting in a higher worsening of diabetes. Well, if you look at a person with diabetes is probably surrounded with the multiple. Yeah, a person with diabetes is surrounded with multiple emotional factors associated with him. So primarily the mood shifts are the first thing which comes into the play. It's followed by an irrational behavior. The patient is whether irritated or he is not in a harmonious way to accept, understand things. The irrational behavior leads to a lot of hormonal changes which gets associated, and this leads to mental confusions, weight gain. There is a problem in learning, memory. All this contributes individually or as a network. They all are present in a patient with diabetes or who's having a multiple mood shifts in the day-to-day experience. So there are disproportionately high rates of mental health problems which have been seen, especially the depression, anxiety rates have been very high. Eating disorders have been known to be associated with people with diabetes and depression. And there's enormous amount of nervousness, vulnerable to mood swings, and this results in the fluctuation of blood sugars, and either it's a too high, too low, is all associated with this. Sometimes we do get mesmerized, or we do get hidden with the underlying a panic disorder versus probably a hypoglycemia. So a person with hypoglycemia, probably a patient who's been having a panic disorder and tries to and has symptoms similar to a hypoglycemia, we probably tend to think that it's another nervous attack or it's nervous breakdown, and we probably try not consider hypoglycemia to be the first thing. So there is enormous amount of interchangeable nervousness, and these people are vulnerable to a lot of blood glucose level situations. Well, an increased level of dementia, the Alzheimer's, and depression is seen on the whole, enormously rising in the day-to-day practice. Let's look at this one of these interesting studies. I've quoted out 2-3 papers to understand how does hyperglycemia relatively acts on our brain networks and what does it do in our effective functioning. So there's a paper probably published in 2016. Here, it was a study where almost 20 to 21 middle-aged young adults with diabetes and without diabetes were studied. So what did we study? We did look at the network analysis of the axonal fiber tactography and tract-based spatial analysis to see how this blood glucose made a difference in terms of white matter network characteristics. So on the left-hand side, if you see, this is the normal healthy control where there are good amount of networks, there is good connectivity among the various topographical representation of the brain. And on the right-hand side is you see the patient with type 2 diabetes or the patient with hyperglycemia, where you see that the networks are not that very highly interlinked. So the segregation done, the network segregation done did reveal that patients with diabetes have probably a lesser amount of segregation as compared to the controls or the healthy type 2 or the healthy individuals. And the overall study concluded saying that a prolonged hyperglycemia did result in reduction of efficacy of brain networks in patients with type 2 diabetes or patients with severe hyperglycemia. So this is the result. It did show that chronic hyperglycemia in people with diabetes may have disrupted the brain's topographical integration and lead to mental slowing and cognitive impairment. So this is probably one among the basic and skeleton or the roots to understand why people with diabetes get into the slowing mode or get quicker cognitive impairment. Let's look at another study where it was again tried to look at the oxidative stress, inflammation, and the autophagy with diabetes. We all know that hyperglycemia does reduce antioxidant levels, and therefore it concomitantly increases the production of the free radicals. And the free radicals are those which contribute to the tissue damage to diabetes, leading to alteration in the redox potentials of the cell and probably increasing the activation of redox sensitive genes. So in simple, both have been invariably tried to alter the mitochondrial electron transport chain, reactive oxygen species formation. There is a disturbance in the mitochondrial energy metabolism and the oxidative stress, which are the main players which have been related to diabetes-related complications. The autophagy is, again, we all know that it is probably the cleanup of the defective proteins or the damaged organelles, which should happen regularly. But when there is an accumulation of such oxidized or glycated protein, this results in common protein modifications, which are seen with people with diabetes. And this could be attributed to the defective autophagy. So there is not much of clearance. A regular cleanup doesn't happen. And as a result, there is a blockage of autophagy, which can probably relate to the pro-inflammatory signaling with the wide oxidative stress pathways. This probably increases the NF-active mediated inflammatory process. This is again another study which did collaborate, showing that the people with diabetes had a higher risk of developing Alzheimer's, vascular dementia, and probably Alzheimer's plus vascular disease or vascular disease, which are more high in particularly cerebrovascular disease, and probably we've had higher hypertension, hypercholesterolemia, and diabetes. These were a common chunk of people who did probably have an interrelated possibility of developing one another. This is an interesting code where it says that almost 60% of the people with type 2 diabetes had probably a greater development of dementia compared with people without diabetes. For vascular arteries, for people with atherosclerotic vascular disease or coronary associated dementia, where the non-vascular dementia was an additional risk factor, and probably it was found slightly higher in women rather than in men. Type 2 diabetes is a risk factor for both Alzheimer's and vascular dementia based on pathology and glucose utilization, demonstrated in persons with having high risk of developing Alzheimer's, vascular dementia, and mixed type dementias, which have been already noted and seen with multiple other cerebrovascular disease, hypertension, hypercholesterolemia have been associated with that. Diabetes and depression is something which is very common in our daily day-to-day practice. Majority of the patients get picked up. Some people are subtle, but it is our duty to probe them to identify whether they are in depression, probably adequately give them the support. So there's enough evidence and prevalence to show that depression is moderately increased even to a stage of pre-diabetic individual and to the undiagnosed. So it's not only a person who is probably having pre-diabetes or diabetes who probably would be in depressive signals, but even in undiagnosed versus a pre-diabetic diabetic, there's enormous rise in the prevalence of depression. And it's so more so it is increased when a patient is on hyperglycemic mode, when the patient is on multiple OADs or probably have insulin, then the level of depression is certainly on a higher side. It's been reported that the mean prevalence rate of depression in individuals with diabetes is 14% by diagnostic interview, and it's almost 32% by self-reported symptom scale. So what it means that we are probably picking up less, but when they self-report, it is much higher. Probably even these numbers are even more higher, scaring that the prevalence of depression is significantly high, and we need to probably look in carefully to identify these individuals and give them the ideal psychosocial care. Depression has been an individual risk factor with type 2 diabetes. I think this is again some repeat of the same content, but it does says that when a person is depressed, there is a lot of anxiety in patients, which makes a probable worsening of the prognosis of diabetes. This is because of this increase in non-compliance to medical treatment, decrease in the quality of life, and increased mortality. The patient loses interest in, he doesn't self-care himself. He's not bothered about his own medical condition. He's not interested to take his medications on right time. He is left out. Such are the patients who need adequate psychosocial care from the immediate family members or from a psychological counselor who need to prompt in and probably give them the adequate psychosocial care, which will enable them to motivate and probably gain the major doables to in a right thoughtful way. So subjects with the depressive symptoms had been shown to have 2 to 3 times a higher risk of type 2 diabetes, followed with who are not depressed by the depressor. So in simple, people with diabetes have been supposed to be increased, showing the risk of depression as compared to people who have not been having diabetes. Diabetes distress, we see a lot of this running through, especially in our COVID time, people who were or regular diabetic patients who failed to maintain the targets because they were lacking either the medication supply or there was enormous amount of anxiety, psychosocial disorders, and the stress of COVID, not going out. All this had led to enormous amount of stress, which probably led to negative psychological reactions and emotional burdens, which probably led to a very, very more demanding chronic disease management. So what do we do? Probably try to monitor these patients more regularly, see why they are distressed, or particularly target them and make sure that the adequate psychosocial care in terms of counseling, motivations, group clearance, all this can be held so that they have a self-esteem developed and probably they are more competent enough to develop their own diabetes care in a much better way. So what do we do? What are the components of psychosocial care? Psychosocial care should be provided to all people with diabetes with goals of optimizing the health outcomes and the quality of life. So what are the major things which we have to influence upon is attitude towards the illness, improve the quality of life, and probably look at the resources, financial resources, social resources, emotional, probably try to find out a balance between all these things. Expectations of medical management outcomes. A patient feels that he just started on insulin, he would want to be out of insulin within 3 months. You should be able to get that reality versus the fact check and probably make them understand what is the current status and what are the outcomes which is expected. Also speak about their assess about the effect, mood, how they have been able to get across. And also, apart from this regular psychosocial screening, if the patient has a history of psychiatric illness in the past or is a family history of psychiatric illness, this all could contribute some amount of giveaways or points to look in what could be the possible reason behind this psychosocial or the distress related to diabetes. And psychosocial care is not a single point care. It has to be a more collaborative approach. It has to be more patient centric. People with all diabetes should be going through it. Nowadays, the newer diabetes centers do have this as one among the essential component of the diabetes care team, where they have a psychosocial counselor who tries to motivate the patient and gets across the disease of the journey of the disease of the patient, and so that it helps the patient to probably optimize the goals, optimize the health outcomes. Once the health outcomes are better, the quality of life gets even better, and this itself is a good motivating factor for the patient himself. And if you look at the other screening which may or may not be included is the attitude about the illness. This is something which has got a lot to play. If you have attitude to get over the illness, and if you write the strike balance, then possibly you can get over the condition. If at the start it's you give away, yes, I may not be able to do, then this is certainly going to be a challenge, and this would probably get into a diabetes related, a lesser quality of life, which all interrelates to have a more and more challenging way to get across.
Adil sir, last minute to conclude your slides.
Yeah, another 3 slides, I think I shall finish. Referral conditions, I think this is very much available, but yes, we know that if a patient has lost self-care, if a patient has lost more of positive screen for validating for depressive symptoms, or if you're suspicious about eating disorder or any other abnormal symptoms which have been noted, yes, they should be referred to the psychosocial care team to probably set out the recommend things. So let's get ready to set our mind sights. What is the step 1? Know your current situation. Explain the patient that his blood glucose or more. Make sure that this high blood glucose has been the reason behind this high insulin resistance. Probably try to avoid foods which probably increase exercise. De-stress yourself. Maybe tell them what not to do as well. Probably tell them not to do everything at one go. Probably tell them not to talk to a person who doesn't have expertise. Speak to more people who have experience in this particular field to help them to come out of these conditions, and let them not sit alone. Let them speak to people who have been experienced or people who have come out of these conditions to get a more positive goal. And the third step is thriving people with type 2 diabetes and medical experts are ready to help me to this week. A few simple steps at a time. That's my path to success. You don't have to jump one go. You make small steps and make sure that the steps are consistent, and surely things will probably change. This is the mindset thing and just not a menu thing. You have to keep constantly tuning and making sure that you are getting better and better day by day. I'm not alone. This is not my fault. I'm not alone. This is not my fault. This is something which you have to keep repeating and make sure that there is some amount of reassurance which is built from the patient end itself. Setbacks and roadbacks will always be there. You should always have a strong reason to come back when you have a committed challenge to come back and get a better health. I will refine my personal reasons every 6 months and make sure that each and every time I make myself better and better. It is the self-talking which makes it more relevant and more tuning to make sure that we achieve to what we achieve to want to be, which we want to achieve. Learn how to see, realize that everything connects to everything else. There's nothing without learning to see and learning to realize that everything is connected with each other. Thank you.
Thank you very much, sir, for such an enlightening and talk on diabetes and mind. I think in the interest of time, we move on to the next session. I hand over to the organizers. Thank you, Dr. Arvinda, for having us for today's session. It has been a wonderful experience. Thank you so much, sir.
Thank you, Dr. Arvinda, for letting us chair this session, and it's a pleasure to be in this program. Thank you, co-chairperson.
Thank you, everybody. On behalf of Dr. Arvind Diabetes Center and ADC International Virtual Diabetes Summit 2020, I wholeheartedly thank Dr. Ami Sangvi, Dr. Shankar Sen, Dr. Benny Neglur Madam, Dr. Sujay Majumdar, Dr. Raja Selvaraja for a wonderful deliberation. All these things were a unique topic. Like women CVD was a unique one, very aptly delivered by Dr. Benny Neglur Madam, and overview of hypoglycemia. I know it's a big topic. Sujay did a wonderful job covering in 20 minutes. It was a tough ask actually. And Raja had a wonderful mindful talk. I should say it's a mindful talk. I know it's a unique, different topic for you, but it was not much discussed. That's the reason I gave this particular talk. So thank you all for your time and wonderful deliberation and being a part of ADC. Thank you so much.
Thank you, Dr. AJ. Thank you. Thanks for having me.
So moving on to the next session, we over to Dr. Shweta, please.
Yes, sir. Thank you, sir. Thank you, speakers. It was a wonderful session. As Dr. Arvind sir said, let's move on to our session. I would like to call upon the chairpersons, Dr. Arvinda GM, MBBS MD, General Medicine, Assistant Professor, Department of the General Medicine, Chairman of Hospital Infection Control Committee. Welcome you, sir. And Dr. Jimit Vadgama, Fellowship in Endocrinology, Diabetes and Metabolism, Mumbai, MD Medicine, Consultant Endocrine Diabetes and Metabolic Physician at Surat. We welcome you, sir. Over to the chairpersons.
Thank you so much. First of all, let me thank Dr. Arvinda for this opportunity and organizing this wonderful conference. Dr. Arvinda, sir, my co-chairperson.
Yes, hi, Dr. Ramkumar.
Good evening. Good evening, sir.
Good evening. Yeah, please go ahead. Yeah, please go ahead.
So let me introduce our session. We are moving toward the last session in this hall. This is the out of the box session. And we have wonderful 3 topics ahead. And it's my pleasure to invite our first speaker, Dr. V.B. Ramakumar, sir. Sir is Diploma in Diabetes from Croatia, FIDF from Sweden, Mary James May Scholarship from IDF also. He has done many fellowships, and he has been awarded from RSCS for Best Innovation in Diabetes and our awareness also. He has a faculty in RSSDI, Deep Sea and Diabetes India, and many conferences. Sir is also a magician, winner of stand-up comedy IMA Andhra Pradesh. Sir has been a certified laughter yoga leader. He has been founder Doctors Comedy Club of Guntur also. He is heading SVR Diabetes Care and Research Center in Guntur from last 27 years. And it's my pleasure to invite sir for his topic, diabetes, laughter and yoga. Over to you, sir.
First of all, thank Dr. Aravinda for giving me this opportunity to be with you all. And my topic is related to the last topic about mind and diabetes. So I will tell you how relaxation will help you or help our patients. Am I audible?
Yes, you are audible.
Okay, help our patients to control with some evidence. Okay, let me share my screen.
You can put in the PowerPoint mode.
Yeah, I'll do that. Okay. Okay, can you see my slides now?
Yes, sir.
Yes, sir. Yes, sir.
Perfect. Okay, thank you very much. And after so many lectures, let us laugh for a while. So today I'm going to discuss about laughter therapy in diabetes with particular reference to laughter yoga, as I got trained in this laughter yoga. So there is a term called as gelitology. Gelitology refers to the study of laughter, which examines that laughter relieves bodily stress. As you know, last speaker told us stress-related problems in diabetes. And we conducted first national meet on gelitology in diabetes last year. As you know, smiling makes us attractive and smiling relieves stress. Then smiling elevates our mood. Smiling is contagious. And smiling boosts immune system. There is evidence for that, particularly laughter yoga. They say that it prevents the infections by improving your immunity. And smiling lowers your blood pressure also. There is evidence. There are some Indian studies which show that laughter yoga reduces blood pressure, and smiling makes us feel good. Not only you, but the other person opposite you. If you smile, everything is better. Smiling makes you look younger. I tell this particularly to my lady patients, because if you say you look younger, then they will do anything, right? And smiling makes you seem successful, and smiling helps you to stay positive. These are all the benefits of smiling. And I will tell you what is laughter therapy. Laughter therapy is known as a psychotherapeutic technique or strategy intended to produce mental and emotional benefits through laughter. It is important to laugh at yourself. That is the best thing we can do. And laughter therapy helps to dramatize the life situations, developing competitive spirit and optimistic view about life. How you classify the laughter therapy? The classification were optimized, operationalized as following. There are two ways. there's whether you are using humor or whether you are not using humor. So there we can use some jokes and other things and make the patient laugh, and that is we are using an intervention. Or if you're not using any intervention like jokes or some other thing, humor thing, then the perfect example is laughter yoga. So let me give some evidence how to show that laughter lowered the increase in postprandial blood glucose. This is a study done in Japan. I think this is the first study which showed that laughter is useful in reducing postprandial blood sugar. It was published in Diabetes Care in 2003. Okay. Then what happened in this study is, in a study on non-insulin dependent users of type 2 diabetes mellitus, exposure to a comedy show along with many others co-participants in the audience, postprandial glucose was shown to be lowered by 46 milligrams due to laughter. So let us remember that if patient can laugh, then his postprandial sugar will be lower. So in conclusion, they write that present study elucidates the inhibitory effect of laughter on increase in postprandial after meal, that is postprandial means after meal, blood glucose, and suggests an importance of daily opportunities for laughing in patients with diabetes. So even if they don't do laughter yoga, if they're laughing, then their sugar will be lower. And there is another study from Slovenia, which shows that the inhibitory effect of laughter yoga on the increase of postprandial blood glucose in type 2 diabetic patients. So the aim of the present study was to determine the impact of laughter therapy on blood glucose level in type 2 diabetic patients. For this purpose, they used laughter yoga, which includes respiratory laughing and fun exercises. So what happened in this study is, the study involved 211 participants, of which 110 were involved and 101 were involved. Means 110 patients were given laughter yoga. In both groups, the level of blood glucose was measured at arrival after they had standard brunch, a total of 250 kilocalories, a 90-minute lecture followed by 30-minute intense workout or laughter yoga were given. In both groups, the level of blood glucose was measured after 120 minutes, and they found that inhibitory effect of laughter on the increase in postprandial glucose was significant. So their study says that importance of daily opportunities for laughter patients with diabetes. And let me tell you about laughter yoga. So what is laughter yoga? Laughter yoga is an unique concept where anyone can laugh for no reason without relying on humor, jokes, or comedy. I told you how they classify the laughter therapy, with intervention or without intervention. So laughter yoga is without any intervention. Laughter is initiated as an exercise in groups, but it will turn into real laughter with eye contact and childlike playfulness. So when you laugh together, it is contagious and the other person will also start laughing. So what are the principles of laughter yoga? It was named laughter yoga because it uses laughter exercises and yogic breathing. Laughter yoga was started in 1995 at Bombay by a medical doctor. We should be proud of that. Dr. Madan Kataria and his wife in a Mumbai park. But now there are thousands of laughter clubs in more than 130 countries. So what they say is, laughter should be sustained at least for 10 to 15 minutes to get health benefits. So it's not possible to laugh alone, or they can do it in the laughter club. So natural laughter lasts for only few seconds. As laughter yoga is done as an exercise, we can have prolonged laughter, which brings physiological, hormonal, and psychological changes in body, which are beneficial. And laughter should be deep, that is belly laughter using the diaphragm to bring all the physiological benefits, which is possible in laughter yoga clubs. Laughter should be unconditional. So you should laugh unconditionally, and it should be deep. It should be coming from belly. Then only we will get all the benefits of laughter. Okay, let me demonstrate you the laughter yoga. So for that, I will be closing my slides, and then I will show the demonstration. But one condition is you should all laugh with me. You are very serious, sir, Dr. Arvind. You are looking very serious. You are not laughing at all. So let us laugh together for a few minutes. Okay. Thank you. And what I will do is I will stop sharing my slides and we'll laugh together. Okay. Then. Okay. Okay. So what is laughter yoga is, what they do in laughter yoga is, we all stand together and clap together. So clap with me. You should clap. Ha ha, ho ho, ha ha, ho ho, ha ha, ho ho, ha ha, ho ho. So if you clap, then you will have the mood to laugh and to enjoy with your friends. So laugh. For beginning, we will clap together. Let us clap again. Ha ha, ho ho, ha ha, ho ho. Right. Then what we will do is we will do some breathing exercises. Because laughter yoga means we will do some breathing. As you know, every breathing, what they will do is they will exhale normally, inhale normally, but exhale slowly. That is the breathing. So what we will do in laughter yoga is, so please do with me. Take a deep breath. Hold it, breathe out slowly. Another time I'll show you. This is what they do in all the yogas. But in laughter yoga, what we will do is, Dr. Jimit, you should do it. Okay. Okay. What in laughter yoga we'll do is, we'll take a deep breath. Okay. Take a deep breath with me. Hold it. And while breathing out, you will just laugh. Very good. So next time we will do it again. Take a deep breath and hold it. And while exhaling, you will laugh. So this is what they do in laughter yoga. We will do it for some more time because we believe that if you inhale quickly and exhale slowly, we will be taking out the stale air and we will have more oxygen supply to the brain. So you try that whenever you are somewhere stressed or something, your patient is boring you, take a deep breath, hold it and laugh it off. And next what we will do is, as you know, when we were children, we were laughing for no reason and we laugh many times. And children, they just laugh for fun. What we will do now is, even if I say, let us laugh together, I put a laughter class, people don't laugh. They think, why should I laugh? Okay. So please leave this. Why should I laugh? Okay. Please leave that and take all the opportunities to laugh. Then you will have, as I showed you in my earlier slides, you will have better BP, better sugar, so many advantages. And immunity also is increased. And your postprandial sugar will come down also. So what we will do is, for childful play neck, we should be doing like this. Very good. Hey! Very good. Hey! Very good. Hey! That is how we should be like a child. Because everyone has a child in ourselves who is trying to come out of, but we won't allow them to come and enjoy. Okay. So you be like child for some time in a day, then you will be having better stress, less stress in life. And I will show you some laughter exercises. What we will do is, first we will do is namaste laughter. So what we'll do is, you put namaste to your neighbor or your friend and just laugh. Very good. Hey. Very good. Hey. Next is shake hand laughter. So when we used to have the live meetings, we used to have people. So you shake hand to your neighbor, look into his eyes and laugh. Very good. Hey. Very good. Hey. Now, Dr. Aravinda asked me to give you all coffee. So let us have coffee. That is South Indian filter coffee. It's available as Madras coffee in my place. So let us have coffee. So you take milk and take decoction. A, and drink while laughing. And thank Dr. Ravinda for the coffee. Thank you, Dr. Ravinda. Okay. Very good. Very good. Hey. Very good. Very good. Hey. And next thing is called as now the shopping festivals are going on. One is Flipkart and another is Amazon. The best way to save money is to delete both the apps, they say. But even if your wife or the son or daughter buys, when you get a bill, what you have to do is see the bill and don't get angry, just laugh it off. Very good, very good. Hey, very good, very good. Hey. And another next item is called as argumentative laughter. Suppose if you want to argue with your someone, particularly your spouse, if you laugh, if you argue like this, you will be successful. Dr. Madan Kataria says that. Hey. Very good, very good. Hey. And next thing is, we should start appreciating people. I did a course on how to be happy, and the best thing to appreciate someone, then you will be happy. So let us appreciate Dr. Aravinda Jagadisha for this wonderful program. Or you can do in Indian style also, or Western style. Thumbs up, thumbs up. Very good, very good. Hey, very good, very good. Hey. And we are all now sensitive to Wi-Fi. So we have Wi-Fi here, and we will laugh only when Wi-Fi is available. So Wi-Fi is there. When Wi-Fi is down there, we'll laugh. So we are too much addicted to this Wi-Fi. Very good, very good. Hey. And the thing is, Dr. Madan Kataria says, the best way to laugh is laugh for no reason. Okay, but don't do it in public. People will think something wrong with you. But the best thing is to laugh without for no reason. So you are laughing, and if someone asks what is the reason, you will say no. Okay. Why you ask? No reason. Very good, very good. Hey, very good, very good. Hey. And my last one is laughing heavenly or wholeheartedly. So if you laugh like this, you will be very happy. So just laugh with me. Very good, very good. Hey, very good, very good. Hey. And my last thing is, let us laugh together for 1 minute. This is called as 1 minute laughter challenge. So whoever successful in this, Dr. Ravinda is going to send some prizes. So let us start and let us laugh together. Okay, start. 1, 2, 3.
Sir, I
Very
think,
good, very good.
the
Thank
prize,
you. Yeah,
prize
yeah,
you only,
yeah.
you are the number one, sir. And I think in the paucity of time, this can continue the day long.
I know. Yeah.
We are very happy to have you here, sir. It was a
Fantastic.
wonderful, wonderful, fantastic talk, sir. And we had a great time. We have learned so many things. Few of the tips definitely we are going to use in our OPD also, with our patients also, and with our family members also. Definitely an excellent, excellent talk, sir. Thank you so much, sir. Thank you. Thank you very much, sir.
Yeah, you are welcome, and I
Thank you,
thank
sir.
you all for being a patient laughter. Okay, and what we did was, if you start laughing with your patients, you will have better relations. Me and Dr. Sanjay, we wrote a paper together, and I'm writing another paper with Dr. Sridhar from Visakhapatnam about gelitology. When they are available, I'll send you all. Thank you very much. Thank you, Dr. Arvinda Jagadisha. He says I am a magician, but he is the real magician. I learned so many magics from him. Thank you very much.
Very different presentation, sir. Very different presentation. Awesome. Thank you.
Thank you very much. Thank you very much.
So, thank you, sir. We are moving forward, and let me introduce our next speaker. Can we have the slides, please? We all know Dr. Vijay Neglur, sir, from the city of Mumbai. Sir is a very senior endocrinologist from the city of Mumbai. Sir is consultant physician and fellowship in diabetes from UK. We know sir is co-founder and medical director at Dr. Neglur's Diabetes Thyroid Specialty Center at Thane, Mumbai. Sir has also been an honorary associate professor in medicine since last 20 years at Rajiv Gandhi Medical College and Shivaji Hospital, Kalwa, and he has served as an MBBS examiner also at Maharashtra University also. Sir is currently one of the leading teachers in PHFI also, and currently teaches on variety of subjects, including diabetes, thyroid, and cardiology also. He is on the advisory board of various Indian and international pharmaceutical companies also. And sir has earned the title of Syndrome Man or Gentle Giant in Diabetes by students and colleagues on account of his impressive diagnosis and treatment. His colleagues and teachers have given him the rather befitting title. Today, Dr. Neglur sir is going to discuss the chrononutrition. The time matters or not. So I'm very happy to invite Dr. Neglur sir for his talk on chrononutrition. Over to you, sir.
Thank you. Thank you, Dr. Jimit. Thank you, Dr. Arvinda, for this great opportunity to discuss about the chrononutrition. Let me share my slides. Yeah. So I hope my slides are visible and I'm audible.
Yes, sir.
Right?
Perfect.
Right.
Perfect, sir.
Right. What we see now across the globe, there is a rising incidence of type 2 diabetes and obesity. And the lifestyle recommendation has really gone haywire. And not surprising because we have the energy dense food available all the time. So excess for the food is available all time, which has disturbed the chrononutrition, the chronology. Chrono means time, the time that is necessary to eat food, and when not to eat food, it has disturbed completely. So therefore, the innovation of chrononutrition is very important to acrophase the metabolic rhythms and therefore get the body under control of various metabolic disorders like diabetes, obesity, and hypertension, and so on and so forth. So it's important to realize way back 300 years ago, Jean-Jacques Ordaz-O'Marin, for the Frenchman who first described the changes in the position of the leaves when in the sunlight and in the dark. And he went ahead and designed a clock based on the position of the leaves and therefore could decide what time of the day it is. So time was very important based on the position of these leaves. And 300 years later, in the year 2017, Nobel Prize was given to the physiology of medicine for these three scientists like Michael, Jeffrey, and again Michael, for identifying the molecular mechanisms and genetic control of this chronobiology. And therefore they were awarded the Nobel Prize, which they have to wait for 300 years. So we all know that in India, of course, the life expectancy has gone up. If you look at 1980, 48 years was the expectancy of life. It's gone to 62 in 2000, and now it is 69 or 70 around by the 2022. And this 1/3 of these patients who have this long life above 60 years suffer from a non-infectious disease, and the lifestyle contributes to it. And there the cure is very uncommon, and you have to live with the disability of this disease because of the lifestyle nature of the disease. And what is this lifestyle you talk about? And this lifestyle, people will say that you have the fruit, you have the exercise, you need to have some sports, life activity, motivation is necessary, food. But I feel lifestyle is what, when, and how much we eat, sleep, and move on a daily basis. So when I put in capital, so when is the most important, what and how is not really important. So I'll explain to you how that is important as we go along. So this is the circadian rhythm that we know, that as soon as we get up in the morning, the melatonin level drops, the corticosteroid levels keep on rising, the bubble movements occur like that, and there's a high alertness around 10 to 12 a.m. So if you have to take a lecture in any session, take a lecture at 10 to 12, when people are extremely alert. The muscle performance is best around 4 o'clock in the afternoon. So that's a time you perform exercises, because that's a time when you get the best benefit of exercise if you do it at 4 o'clock. Then as the evening drops in, the melatonin level rises, the body tends to cool down, you have a deep sleep, and again in the morning, the temperature rises and melatonin drops. So this is a circadian rhythm which is maintained during the day and night matter. Now, what is the important point to understand is that there are 10,000 neurons located in suprachiasmatic nucleus in the brain, which regulates this biological clock. And this biological clock is a central clock, and it gets it also activates the peripheral clock, which is located in the heart, liver, muscle, and kidney, and therefore they have the understanding of physiology and behavior. What is the cues for all these activities to the central suprachiasmatic nucleus is coming from the feeding schedules, from the light and dark, and the activity. As you see here, during daytime and nighttime, different genes are activated. And we know the food is a very important cue for the biological clock. Now, what happens is when this cue gets skewed up, for example, if you have a good rhythm, and if you synchronize with this particular rhythm, like for example, you have a bright light during the daytime, you sleep during nighttime, eat only during daytime, versus when you have light in the nighttime and sleep during daytime and eat at night, what happens when you do this kind of dysrhythm, when there's a malalignment or misalignment of the circadian rhythm, you get disturbed sleep, obesity, diabetes, depression, cardiovascular disease, cancer, and impaired immunity. So therefore, these are the problems are created by the misalignment or non-alignment of the biological clock, which is controlled by suprachiasmatic nucleus, which has a very important role in the regulation of bodily function. Now, how it is done? It is the retina which takes part in controlling this. Retina has about 5,000 blue light sensing neurons, which are located in retina. And this produces what is called a melanopsin. And this is very sensitive to blue light. So blue light is one which stimulates melanopsin. And in the bright day, it activates this particular hormone, melanopsin, and that synchronizes the brain clock, raises the alertness, reduces depression. And in the nighttime, the melatonin starts rising up, and the light which can not stimulate the melanopsin is the candlelight or the orange light. Therefore, all across the globe, people have changed the screens of the television and of the mobile phones and tablet to the orange light, light orange light, and the blue light is removed because blue light stimulates these particular neurons, and therefore you have the activation of melanopsin. In night, we don't want melanopsin to be activated. We want melatonin to be activated to have a better sleep that occurs at night. Now, what is happening in reality today? We see most of the people working indoors. They have a gloomy indoor days, which misalign circadian rhythm and reduces alertness, promotes depression, and reduces performance. And what happens in night? Night, there's a bright indoor nights color, especially the blue light. And this is the blue light LEDs, and even if it's dim in nature, and a lot of screens and tablets have this activity of blue light, and therefore the melanopsin is stimulated, that disrupts circadian rhythm, reduces sleep hormones, and therefore keeps us awake at night. So morning, you are gloomy and performance less, and night instead of sleeping, you're awake. So for light for vision is not light for health. That's what's happening today in day-to-day practice. And we have these houses which is stocked with a lot of food available and plenty of fluid now available, which is now kept like this in the house. And that also important Zeitgeber. It's called Zeitgeber because this is again a kind of a stimulus to the eye, and therefore it affects the circadian rhythm, and therefore there's a disturbance in all the organs, whether it's muscle, liver, kidney, intestine, and heart, and so on and so forth. So that's how the daily rhythm, physiology, metabolism, and behavior is altered by on eating at odd hours. What happens to people who work in the shift, in the various shifts, especially working in night shift, the firefighters, the doctors, nurses, all those people who work around the clock, and therefore they have the high incidence of cardiovascular disease, neurological disorders, mental health, metabolic syndrome, and gastrointestinal disorder. Now, what is the night shift definition? As per the International Labour Organization, Geneva, we say the shift worker is a person who spends more than 3 hours awake between 10 p.m. and 5 a.m. 50 days or more a year is called as a night shift worker. So I think all doctors, most of us come in this category. So we tend to keep awake longer in night and therefore invite various metabolic diseases. And therefore 21st century lifestyle disrupting circadian rhythm is what is that you eat in the morning hours, eat in the afternoon, eat in the evening, eat in night. So eating all the time. So this is the New York Times publication which says when we eat or don't eat may be critical for the health. You eat during nighttime and daytime. And therefore Sachin Panda from the Bay Areas in California has written a very good book of Circadian Code. I think one must read it. It's a wonderful masterpiece and one should read. He carried out the experiment in rats where he gave the rats the isocaloric food both in the daytime and nighttime. This just to remind you, the rat is a nocturnal animal, so eats at nighttime. Here you can see the rat eating at nighttime and at daytime. And here the rat is given only food at nighttime, nothing at daytime. They followed up for a period of 18 weeks. What did you see? The rat that ate only at night did not gain weight, and the rat that ate in the day and night gained weight. Mind you, the both of them had identical food. It's isocaloric food. Increased the body fat by 70% and increased body weight by 28%. And furthermore, had also evidence of steatohepatitis in the liver. So therefore, this very important point to understand that biological rhythms are very important. And here how it is explained that if eating during the daytime and nothing in the nighttime, the calories which is obtained from the carbohydrate are stopped at this particular point, and there's a switch of burning fat which occurs here, and you start burning fat here. When you start burning fat here, of course, normally you lose body weight. At the same time, the burning of carb is stopped, and therefore eating before 6 p.m. is definitely advisable. If you continue to eat beyond that, this is what happens if you have eating time of 10 hours, the fat burning has become less. And if you eat for 15 hours of the day, the fat burning hardly occurs. And therefore you develop obesity, hypertension, diabetes, and so on and so forth. So therefore there is a time restricted feeding, which is an important concept in the metabolic disease. And you have a rat which had ad libitum diet had resulted into increased adiposity, glucose intolerance, leptin resistance, liver pathology, and inflammation. That time restricted eating definitely helped all these situations, and therefore it's important in the rat experiment that time restricted eating is very important. You would ask me the question that this is, you are showing the examples in the mouse and the rat. What about men? Yes, I know that the men and mouse are different. Mouse uses the energy stored in the blood. Mouse is primarily nocturnal animal, and mouse is of course is very active, unlike human being, which is sedentary and work during the daytime and use energy stored in the muscle, and therefore they have a lot of genetic changes which can occur in these human beings, which also alter the DNA function. So therefore mouse and men are different. To answer this question, the study was done by again Sachin Panda, who take a keen interest in studying this aspect, and he developed a smartphone app to reveal the erratic diurnal eating pattern. And this is what he have to load. This app is available. Anybody can load it. It's free of charge. And all that you do is whatever you eat food, before that take a picture and send it on this particular app to that particular designated site. And that has been captured. And therefore it tells you exactly how much calories you are consuming. That can be seen here. So here he did, can I please mute others? Chairperson, can you please mute others? Thank you very much. Thank you. So this is the study done on the 8 workers which worked in his own labs. These are the subjects with obesity. He had the data collected on 3 weeks with the baseline of 8 subjects with more than 14 hours of eating duration. And he did intervention for eating them less than that particular time. And of course, no monitoring was done. And then at the end of 36 weeks, he collected the data. What did he see? These are the 8 people data, which is shown here. The red bar is the one which is before the intervention. The blue bar is after intervention. You can see them that they have reduced the restricted time of eating quite significantly. And you can see them, they lost weight significantly. Mind you, they ate almost the same thing they were eating earlier, but they only restricted the time, not food. It was only time restricted eating, not food restricted eating. And what you see here also, this is a basal weight, and you can see here at the end of 16 weeks, there's a drop of the weight quite significantly. And this weight was maintained for 1 year period of time, though they did not, I mean, it was not studied, but these patients were happy with this kind of diet weight time restriction, and they could get the same benefit even at the end of 1 year. This is the Elizabeth study done in USA. She looked at 8 patients of pre-diabetes, all male patients, and she told them to have either a 12 hours eating window, between 8 a.m. to 8 p.m., or a 6 hours eating window, between 8 a.m. to 2 p.m. This is only early time restricted feeding. There's no restriction on calories. And you can see here the response in the prandial sugars, prandial insulin, blood pressure, insulin sensitivity, and so on and so forth. If we can see that the weight also reduced significantly, body composition improved, the microbiome also improved, and the triglyceride also improved. It's a very important study. Though the number of patients are small, this is a mechanistic study which proves the point that time restricting eating helps. How do you get this benefit? By just restricting time. The most important thing you should remember that the adipose tissue is the sink. And when you have a healthy people, the branch and amino acids are sunk into the adipose tissue, and therefore that absorbs all the branch and amino acids. In patients who do not follow time restricted eating but eat every time ad libitum, then these branch and amino acids are shunted into various organs, and there's enough data now to suggest that increased consumption of branch and amino acid at odd time has impaired glucose tolerance and diabetes new onset. Though we know branch and amino acids are very important for the growth of the muscle, for the protein growth, but if that is given ad libitum, then you have abnormalities like insulin resistance and diabetes. This is the heat map which looks at various organs, and you can see here that the transcriptional burst and the quiescence is known with different kind of diets. So therefore, diet definitely at different time plays a role. This is unpublished data, and therefore one has to remember that this is very important. The question people ask quite often is whether this is feasible in patients of type 2 diabetes. You can restrict the eating. And this is a study which is still unpublished, done by Evelyn Parr and Sachin Panda, who looked at the restriction of eating only to 8 hours feeding and 16 hours no feeding, again taking the pictures and sending them on using the app. And then they could find out that at least 60% of the patient could adopt this particular lifestyle without any problems of hypoglycemia in these patients. So it's quite feasible in patients of diabetes. This adoption is possible. This is the monumental study, which looked at delayed morning breakfast and earlier evening food. How does it change the pattern? Which looked at randomized controlled trial of 11 male patients with a sedentary lifestyle, and they're given 3 free food diary, and then they were given restricted food eating. And then they also had CGMS testing and also blood sugar testing every 1 hour in the daytime and every 2 hours at night time. They also estimated blood sugar, and they also take multiple biopsies of the muscle at this point of time. And they looked at both the patient with the extended feeding time and the time restricted feeding time, what exactly happens. And what you can see clearly here, when you look at the venous blood sugar samples, you can see that the end of the A, the sugars really normalize very well. The excursions are reduced, and therefore they could get a good fasting sugar and also drop in the prandial sugar. This is the venous, and this is the interstitial fluid sugar seen on the CGM, which also shows there's a better control of these patients when you have time restricted eating. A lot of people mistake the intermittent fasting, chronic energy restriction, and time restricting are similar, though they are not. The intermittent fasting actually involves 12 hours or longer or little or no food, and it has the restriction of calories. But in time restricted eating, there is no restriction of calories. You only restrict your time, not to restrict your feed. You only have 8 hours eating time and 16 hours non-eating time. So this is again a study by Gad Asher from Israel, which looked at what happens exactly, the benefit you get by restricting the eating time. And here they've said There are beneficial metabolic effects, reduce insulin resistance and increase glucose sensitivity. And it is driven by a clock which is located in intestine, which also change the microbiome. And this microbiome also oscillate exactly the same way as the central chiasmatic nucleus in the brain, and the food intake and the brain and the microbiome, all of them oscillate in the same direction as is shown in this picture. And therefore, it's the microbiome also which also contributes interestingly for this control of the metabolic state. And there are a lot of studies now on the way. There are plenty of them. In the interest of time, I can't go in details about all these, but suffice to say that it is the microbial change which occurs because of time-restricted eating that is driven by the intestinal clock, which has the connection to the central clock. So therefore, time-restricted feeding or eating is a novel strategy to combat lifestyle-related metabolic diseases. And you can see that all the benefit, not only in the animals, but also in the human model, you can see there's a decrease in the body mass, the glucose homeostasis improves, the insulin sensitivity improves, so on and so forth. So you get all benefits by restricting it. So what to do then? What is the advice from my side? It is always better that you wait for 2 hours after getting up before you have breakfast and practice time-restricted eating. You can begin with 12 hours, start shrinking to 11 hours, 10 hours, 8 hours, try and get as much as possible, as short as possible eating time. That's the very important first message. Second message is do not have coffee after 2 p.m. because that tends to have a little longer action. So therefore, avoid having coffee after 2 p.m. Third, you try and exercise around 4 o'clock. That's the best time to have exercise because that time the muscles are most active. And see that you don't have anything at night. So night should be no food at all, and finish your meal as early as possible. If it's 6 p.m., it's much better. Can go max up to 7 p.m., nothing before that. And even if you're hungry, do not have anything else because that can be ignored for some time and you can get all the benefits. So important is that when you do all this, what you get a disrupted clock to a healthy clock. So you can get back to healthy clock. You can have the improved metabolic status and dyslipidemia, hypertension, diabetes in the right rhythm. So therefore, I do not understand.
The last few seconds to go.
Yeah, 1 minute, less than a minute.
Yes.
So this is exercise also important that gives you benefit because I'm not going to talk about it. So therefore, it's not what you eat matters. It's when you eat matters. So what I've explained to you so far, it's not what, but it's when you eat matters. With that, I thank you very much for the patient listening. I'm sorry if I short my time, but try to finish as early as possible. Over to Jimit.
Yeah. Thanks, Dr. Vijay sir, for enlightening us on the intermittent fasting and also saying that when to eat, what to eat, and to bring the scientific facts. Let's go to the next speaker for the day. Yeah, I think next speaker for the day is Dr. Sunil Praso. He's a professor in medicine and diabetologist at Government Medical College, Kollam. He's an MD, MBBS and MD General Medicine from Government Medical College, Trivandrum. Postgrad Diploma Diabetology from Annamalai University and PGDH Science Lab from Hopkins University and Chairman Ethical Committee, Jyotidas Diabetic Center, and is an invited speaker for various conferences, publications, and national and international journals as granted. Over to Dr. Sunil.
Shall I share the screen?
आपला थोडे डायल केलेला नंबर यावेळी स्विच ऑफ.
Thank you, Arvind sir. And let me at the onset itself thank Dr. Arvind Jagdisha, my very close friend, for this fantastic opportunity. It's a real pleasure to be here. Pleasure and privilege to be here presenting on a topic, diabetes arthropathy. Now, as we all know, diabetes is growing in epidemic proportions, and we do see so many complications of diabetes. Among the various complications, one of the most ignored or neglected complications is the rheumatological manifestations of diabetes. So whenever we see the arthropathy or arthritis, we always tend to focus on primary rheumatological disorders. The rheumatological manifestations of diabetes are often misdiagnosed or neglected. If you go for a Medline search, unfortunately, you will see very less than 1% of the articles are published in PubMed relating to the rheumatological complications. This is a very famous rheumatologist, the William Hibberd. He once said, rheumatism is a common name for many aches and pains which have yet got no peculiar appellation owing to very different causes. So whenever we come across the rheumatological manifestations, we should be very give more importance. But unfortunately, the poor awareness, the late recognition, the late therapeutic intervention, all these lead to so many morbidity and disability in our diabetic patients. The most important aspect of the rheumatological manifestations is it has got a relation to the poor glycemic control and the duration of the disease. And to some extent, there is always an association with predominantly the microvascular complications, and to some extent, the macrovascular complications also. Now, if you look at the pathophysiology of rheumatological manifestations, what we see is there is an abnormality in the connective tissue. The increase the connective tissue, the hardening of the connective tissue, the increased activity of the myofibroblast. Then the second, the neurovascular mechanism leading to various complications. Then there is a genetic mechanism because of the antigenic sharing. But the most important thing is the increased or decreased actions of the insulin or the IGF, the insulin-like growth factor. As we all know, insulin and insulin-like growth factor is absolutely necessary for the mineralization of the bone, to increase the density of the bone. This is a very important thing. So when there is deficiency of insulin or ineffective action of the insulin-like growth factor, the mineralization get affected, the density get affected. There's going to be osteopenia and various types of arthropathies. Now, if you look at the rheumatological manifestations as a whole, the most important areas which are affected are the hand, shoulder, and spine, and to some extent, the lower limb also. So in the shoulder, we are seeing so many cases of adhesive capsulitis. There is shoulder hand syndrome. And if you look at the hand, there is diabetic hand syndrome, there is flexor tenosynovitis, there is trigger finger, debutrans contracture, carpal tunnel syndrome. And if you look at the spine, you can see diffuse idiopathic skeletal hyperosteosis and osteoporosis. The foot problems are uncommon. If you look at in that way, the uncommonly encountered is the foot, the Charcot's joints of the foot, the muscle, the pyomyositis, the necrosis, the diabetes, amyotrophy. When compared to the previous ones which I have told, there is an uncommon varieties that we see. Now, coming to one of the most important manifestations, the adhesive capsulitis. It is very famously known as the periarthritis or the frozen shoulder. It is not unique to diabetes, but it is common in diabetes. Around 25% gets affected, and it is related to poor glycemic control and has got an association with increased duration of diabetes. It is especially seen in patients with type 1 and type 2 diabetes. Now, whenever the patients will always say that they will have difficulty at the movement of the joint, and when they lie on that side, it gets affected, and there will be painful restriction of the movements of the joint, especially the external rotation and the abduction gets affected. And when you take an X-ray, you can see an adherent capsule when the joint space is also reduced. This adhesive capsulitis often is seen in a bilateral. It is disabling, at the same time it is disturbing. And in some cases, there may be a spontaneous resolution in 6 months to 3 years. The most important treatment is the analgesics, the physiotherapy, local steroid injection, and in some cases, we may have to do surgery, the arthroscopic capsular release surgery. Now, coming to a very important second aspect, the limited joint movement of the hand. This is very unique to diabetes, and this is known as cheroarthropathy. And it is seen especially in type 2 diabetes and also in type 2 diabetes also. And it has got a positive correlation with duration of the diabetes and poor glycemic control. And as I have already told you, that the limited joint movement has got a very important association with microvascular, to some extent macrovascular complications also. It is just like a pseudo-scleroderma, like skin changes over the dorsum of the hand. There is contractures of the finger. There is limited mobility of the fingers, and it is usually painless. So this is a very famous, the two signs which we do to elicit the limited joint mobility, the prayer sign and the tabletop sign. Now, if you look at the diabetic hand syndrome, as I have already told you, it causes discomfort, but it is not disabling as that of the periarthritis shoulder. And the treatment is often physiotherapy and dynamic splinting and good glycemic control. Another very important thing that we come in the hand is the hand flexor tenosynovitis. It is very common to the tune of 16%. It occurs both in type 1 and type 2. And the most important aspect is the flexor tenosynovitis is nothing but the thickening of the tendon sheath of the fingers. And if the flexor tenosynovitis occurs in 3 or more fingers, always suspect diabetes. That is a very, very important thing. In some of the patients with flexor tenosynovitis, you may come across the trigger finger. Many of the patients might have told you that there is locking movement when they try to flex and extend. So this is the trigger finger. And the treatment is analgesics, physiotherapy, local steroid injection, and in some cases, we may have to do surgical release. Another very, very important is the carpal tunnel syndrome, which is very common, occurs to the tune of 16%, both in type 1 and type 2 diabetes. Now, there is no specific association with the poor glycemic control as far as the carpal tunnel syndrome is concerned. All of us know there are so many other conditions also, like pregnancy, hypothyroidism. These are the other conditions we come across this carpal tunnel syndrome. The carpal tunnel syndrome is nothing but a compressive or entrapment neuropathy affecting the medial nerve. Classically, the pain and paresthesia occurs in the medial 3.5 fingers. And this is one classical way of eliciting this carpal tunnel syndrome, the Phalen's sign, which we often do. And another is the Tinel sign, just tapping at the wrist and eliciting pain. This is the way to elicit carpal tunnel syndrome. The treatment is always by giving analgesics, the cock-up splint, the mobilization exercises, the local steroids, and surgical decompression. Now, another very, very important thing, common, which we see in some of our patients with the diabetes is the Dupuytren's contracture. It is commoner to the tune of 25 to 30%, both in type 1 and type 2 diabetes, associated with the duration of the disease. Now, one of the important things regarding the Dupuytren's contracture is in diabetic patients, the Dupuytren's contracture typically affects the 3rd and 4th fingers, but in non-diabetic patients, it is usually seen in 4th and 5th fingers. So always, if you see 3rd and 4th fingers, especially in females, always think of Dupuytren's contracture due to diabetes. And occasionally, it is seen at the onset of the diabetes. We may have to do physiotherapy, local steroid injection, surgical release, and injection of collagenase. All these are the treatment options. This time, I was telling about the hand. Now, when it comes to the spine, one of the classical things that we see is diffuse idiopathic skeletal hyperosteosis. It's seen in around 10% of the patients, predominantly in type 2 diabetic patients. What we see is there is an endothelial ossification, the spinal endothelial ossification. There is also ossification of the anterior longitudinal ligaments in the spine. It always mimics an ankylosing spondylitis. The way to differentiate between an ankylosing spondylitis is in dish, classically the IVD, the intervertebral disc space is maintained, and also there is the sacroiliac joint is also normal in dish. And the management is always an NSAIDs, injection steroids, and muscle relaxant and physiotherapy. One of the classical things all of us know, the metabolic syndrome, diabetes, do have got an association with osteoarthritis. Osteoarthritis is nothing but the degeneration of the articular cartilage. The cartilage is degenerated. All of us know. In diabetes, there is an inflammatory, there is an increased inflammation, the AGE, the advanced glycosylation end products, all these causes damage to the cartilage. So the osteoarthritis can affect many of the bones, the large bones, small bones, joints, large joints, small joints. So this is a very common thing that we see even in our general population. So that in diabetic patients are also, we are sure that we are coming across more patients with osteoarthritis. And the treatment is giving NSAIDs, the physiotherapy, surgery, there are drugs like glucosaminoglycans, all these are effective. Now, when it comes to the food, the Charcot arthropathy is a very, very important thing. This is a very, very, the incidence wise, if you look, it is very less. It is only 0.5%. in long-standing diabetic patients due to the long-standing neuropathy. Is the main cause of this Charcot arthropathy. And most often the initiating event is the neuropathy. There is trauma causing bone fracture, there is gross deformity. And ultimately, many patients may develop a rocker bottom type of foot. There is joint swelling, effusion, there is joint instability, multiple bony fragments, and there is a downward collapse of the tarsal bones, leading to a convexity of the sole. And the treatment is basically by rest, offloading by total contact cast, there is bisphonates and surgery. Gout is another thing that we usually come across in metabolic syndrome patients. Here also the prevalence comes to the tune of 20 to 22%. Now, what we know about this gout is there is a promotion of renal tubular reabsorption of uric acid by insulin. But as glycemic control improves, there is always a potential risk. There is a mild worsening can happen, because I have already told you the insulin causes promotion of uric acid reabsorption. So this is one thing that we should understand. Another important bone abnormalities that we come across is the osteoporosis and the increased fragility fractures, then regional osteopenia. Especially many of our diabetic patients may be having diabetic nephropathy and chronic kidney disease. In such patients, all of us know that vitamin D deficiency, renal osteodystrophy is very, very important. And also we see so many patients, there is an always increased falls risk is there. The quality of the bone is reduced. And all of us know the drugs like thiazolidinediones are always notorious to produce osteoporosis, and fractures are very common when you are taking such kind of drugs. So some of the important clinical pearls which I want to reiterate is, so whenever you happen to see a patient with a limited joint mobility, always think that it is peculiar to diabetes. The limited joint mobility, especially the hands and shoulder, it always has a relation to the microvascular complications also. There are so many conditions which are common in diabetes, especially the adhesive capsulitis of the shoulder, deputans contracture, the carpal tunnel syndrome, the flexor tenosynovitis. There are so many conditions uncommon, like the Charcot foot or the foot-related problems. Then if you see a patient with the flexor tenosynovitis of 3 or more fingers, always it is a pointer to diagnose. And always, whenever you come across the limited joint mobility, it is a pointer to microvascular disease. So just to summarize what I was trying to convey in the last 15 minutes, the rheumatological manifestations are common. It's not an uncommon thing. Most of the time we neglect it, or we misdiagnose it, or we think in terms of the primary rheumatological conditions. Always look for the common things that we see in diabetic patients. Maybe it is mistaken for primary, as I told you, primary rheumatology conditions always come to our mind, but we should have this knowledge that these are some of the common things that we encounter. They do have association, especially to microvascular complication, and to a certain extent, the macrovascular complications also. We should all understand that a unique or peculiar to the diabetics is the limited joint mobility. There are so many common conditions, which I have told, the flexor tenosynovitis, deputans, carpal tunnel, and uncommon conditions like Charcot. But Charcot, if it happens, nowadays, the most common cause is undoubtedly diabetes. In all these patients, achieving euglycemia is absolutely important. Always try to achieve euglycemia. And the most important thing is the management is multidisciplinary. Analgesics, physiotherapy, surgery, injections, local steroids, all these are the treatment approach. But the most underlying statement is always prevention is better than cure, and always have an open eye and try to see the patient as a total. Thank you. Thank you for your patient listening.
Thanks, Dr. Sunil. Good enlightening us on some of the orthopedic topics in diabetes, and at least these are the things which are very important in the practice but never taught in the MBBS data, not given much importance during postgraduate days. And we realize that now that during the practice, these are the most important things. And for a medical, or for a physician, for a diabetologist, bringing what are the treatment lines, steroid injections, and other treatment modality. Thank you. Thanks for this nice presentation.
Thank you, sir.
Thank you, Dr. Sunil. At the outset, on behalf of Dr. Arvind Diabetes Center and ADC International Virtual Diabetes Summit 2020, I wholeheartedly thank Dr. Arvind, who is my classmate, batchmate from Bangalore, and Dr. Jimit, and Dr. Ram Kumar, and Dr. Vijay Neglur, and Dr. Sunil Prasad for your wonderful talk and deliberation. And I thank you for being a part of our conference and for your valuable time. Much appreciated. Thank you so much. To this, we come to the end of this conference, and we have come to the conclusion ceremony. So, Neelam, can we play that video, please? Thanking video.
Also, banquet.
Good wishes, everybody. At the outset, I thank wholeheartedly all the faculty members, delegates, pharma peoples for being a part of our conference. So we had an excellent 2 days conference, a virtual conference, which was well attended across India as well as across the globe. I'm happy to share that we had nearly 2012 registration across the globe. It was an excellent scientific extravaganza, which was appreciated by one and all. I personally thank our orators and keynote speakers, Professor V. Mohan, Professor Shashank Joshi, Professor Anup Mishra, Professor Kamlakar Tripathi, and Dr. Banshi Sabu for their wonderful deliberation and oration and discussion, which was much appreciated by the faculty members and the delegates. And I thank all the faculties for their wonderful participation and wonderful presentation and discussion, which was well appreciated by all the delegates. Any conference will not be successful without the delegates. So I wholeheartedly thank all the delegates who participated actively across India and took active part in the discussion as well. Without pharma people, no conference will be successful. Their support means a lot. I thank wholeheartedly all the pharma people, especially USV, Micro, Novo Nordisk, Sanofi, Abbott, Biocon, Sun Pharma, Eris, Intas, Pocard, Torrent, Serdia, and Mankind for their active participation in our conference. I thank Mr. Banu, who actively supported me in this conference in the preparation. I thank Dr. Shweta, who participated in coordination of our conference. Not but not least, Dr. Hardik and the RX events team for their successfully managed program through their event page. Dr. Neela, who is the wife of Dr. Hardik, Dr. Nirav, Mr. Neela, for their involvement in the success of the conference through the event managed. I wholeheartedly thank one and all. Thank you for your wishes and blessing. Hope to see you all in person in next year ADC International Diabetes Summit 2023 physically. Thank you so much. Good wishes, everybody.
So thank you, everybody. So that brings us to the end of this 2 days conference. Thanks for all your active participation and your wishes, suggestions, and blessing. Thank you so much for being a part of our conference. Hope to see you all in the next year physically in Bangalore. Thank you once again. Thank you once again.
Sir,
Bye.
Pardon, sir.
Yeah, Shweta.
I would like to thank you, sir, for taking me as a part of a ADC team and considering me. Thank you, sir. Thank you so much, sir.
You did a wonderful job, Dr. Shweta. You did a wonderful job.
No, sir. I should
the
thank
Hall
you.
B was completely managed by you. Thank you so much.
Thank you, sir. Thank you so much, sir.
Thank you. Thank you.
Dr. Arvinda, we will laugh together next time in live. Okay?
Sure.
Thank you very much.
Thank you.
Bye.
Bye, Arvind. Bye, Jimit. Bye, Sunil. Bye.
Thanks, sir.